guide for sophisticated surgery, wide range of clinical indications, and excellent convenience. One guide is convenient to use. With an ultra-simple drilling technique, the implant can be placed at the plant site in only 3 drillings for shortened surgery time. One guide also offers high precision. The site, direction, and depth of implant can be precisely planned using digital method and used to manufacture a one-guide template. This allows the implant to be placed as planned. One guide template holds the drill to help maintain a precise path even during high-speed drilling. The stopper is in contact with the top of one guide to enable precise control of drilling depth. One guide is particularly useful for surgery in the posterior region. In addition to the basic closed type hole, open type hole can be selected for designing. This function allows a drill entry through side and posterior teeth with insufficient vertical space. Open type hole helps to secure additional vertical space. One guide can be used for various clinical purposes. One guide kit for cases of single to fully edentulous. One CAS kit for maxillary sinus lift surgery. One MS kit for the anterior region with narrow bone width. One 485 kit for short implant in mandible molar. These 4 dedicated kits are available for a wide range of clinical cases. Improve the convenience of digital implant surgery with one guide. It is simple and precise. Introducing the One CAS kit, the digital sinus surgery kit. If you use the One CAS kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the one guide template first. Then, use the drills with the rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the One CAS kit for safe and precise sinus surgery. Introducing the One MS kit, the implant surgery kit for anterior region with narrow bone width. In the anterior region with narrow interdental space and also in the narrow bone width, place the one guide template. And then you will be able to place MS implants with the most narrow 2.0 mm diameter and TS3 3.0 implants exactly in the planned position by using one MS kit. Try the one MS kit, the implant surgery kit for the anterior region with narrow bone width. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movements. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate.
One-jet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or
We'll
higher
soon start
precision output height.
the event of today.
Users can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The one-jet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. One-jet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. One-jet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic one-jet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. One-jet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, one-jet LCD. Milling machines must be capable of manufacturing precise prosthetics. One Mill 5X is equipped with high-quality servo motor and high-power spindles. Servo motor offers more precise control of position and speed. Spindle with a high power of 500 kilowatt offers stable machinability based on high rotation of 80,000 RPM. For plus and minus 5 micrometer processing repeat precision. Many processing tools are needed for processing of various prosthetics. One Mill 5X is equipped with ATC, a system that automatically replaces 10 processing tools. This allows simple and convenient processing of zirconia prosthetics and PMMA for temporary teeth, as well as hybrid ceramics for inlays. One Mill 5X can simultaneously using 5 different axes during processing for detailed and precise fabrication of prosthetic external shape and internal undercut. This allows processing of various prosthetics from inlays to implant full arch bridges with screw holes. Dental equipment must be simple and intuitive to use for any step. Using a touch panel, One Mill 5X is easy and simple to use, from starting the processing to changing tools and cleaning. The front LED display on the equipment tells you the processing progress and remaining processing time. Circle LED on the door shows standby processing and errors of the equipment in different colors for easy identification. The white tone design is suitable for dental offices as well as patient waiting room and laboratories. One Mill 5X provides an aesthetic look of modern digital dental clinic. With servo motor and high power spindle, One Mill 5X manufactures high precision and high quality prosthetics. Simultaneous 5 axis and 10 tools offer limitless processing. Touch panel, LED display, and 3-way airflow system provides
간절해진 주제로 돌아온 오스템 미팅 2023 서울. 오스템 임플란트 본사에서 진행되는 오늘 행사는 앞서가는 디지털 치과를 위한 다채로운 강연으로 꾸며지며 영어와 중국어로 동시 통역되어 대놀 사이트와 유튜브를 통해 해외로 생중계됩니다. 이번 행사는 앞서가는 디지털 치과 전환무치학 편으로 폭넓은 경험을 갖춘 좌장 5분을 모시고 전환무치학 수술의 새로운 지평을 열어줄 유상준 교수, 오승환 원장의 강연이 포문을 열고 전환무치학에서의 아날로그 및 디지털 보철에 관한 박희웅 원장, 배정인 원장의 강연을 비롯해 양승민 교수, 박영범 교수, 박창주 교수가 자리를 함께 전환 임플란트 수복 시 치주, 보철, 외과에 대한 다양한 관점에서의 견해를 나눠봅니다. 오스템 미팅의 하이라이트 라이브 서저리에서는 김영진 원장, 이수영 원장이 선보이는 오스템의 디지털 워크플로우가 공개되며 특별 세션으로 이종국 원장과 지대경 원장의 투명 교정 강연이 진행됩니다. 현장에 참석하신 분들을 위한 특별 프로모션과 무료 프로필 사진 촬영까지 다채로운 이벤트가 준비된 오스템 미팅 서울. 전환무치학에 대한 명쾌한 해답을 내려줄 오스템 미팅 2023 서울. 지금 시작합니다.
Good morning, ladies and gentlemen. I'm an announcer MC of Osstem Meeting 2023 Seoul. My name is Im Han-ul. First, I would like to thank you for your support for Osstem Practice Exhibition. My sincere gratitude to the participants, online and in-person visitors to the exhibition at the Osstem Implant Magog head office, who listened lectures and participated in various programs, gave us a very good review. Thank you very much for your support. It's 9:02. So we are going to talk about advancing digital dentistry for mouth implant placement. Let's open Osstem 2023 Seoul. Today, we have sessions in the Osstem head office auditorium and special program on the third floors, the seminar room, lectures for digital hygienists and lab technicians, and on complications is to start at 2. All the programs and lectures are broadcasted real-time through the dental portal. If you log in, you can join various events. So please give us a lot of support. Osstem meeting is getting a lot of attention from dentists around the world year after year. Academic Congress currently going on in the auditorium is interpreted into English and Chinese to 33 overseas Osstem implant offices in 28 countries. Please join us and watch. Now, what is going on in the auditorium is being broadcasted, as I said before. Please turn off your cell phone or put it in the vibration mode. Let me introduce various events and programs. If you join and log in online, then on site, we'll have a lucky draw after the event. The lucky draw winners will get various gifts, including Galaxy S23, Galaxy Watch 5 Pro, Osstem mobile kit. Stay with us. On each floor of this head office, we have various programs. On the first floor, we have the Osstem free photo zone and the various exhibition events are going on. And the 2023 One Guide System book exhibition is going on as well. It is co-authored by the Dr. Ki-Sung Kim and Yong-Suk Kim. It is about the One Guide System clinical indications, advantages, clinical cases, and how to use the kit. You can visit and buy the book in the exhibition hall. on the first floor or through the dental homepage. And we have cafeteria on the first floor, and we distributed coffee coupon, and you can use the coupon for iced coffee or various confectionaries. So on the second floor, there is the Osstem product exhibition hall where you can see and experience various Osstem implant products. At the right side entrance to the auditorium on the fourth floor, you will find 30 superior posters and catering service. And then visitors to events will get some gifts if you get all the stamps from 5 places on the stamp tour paper given to you as you entered. Submit it to the reception desk on the first floor to get special gifts. At 3:30 and 5 p.m., a 2 building tour is organized to look around implants, medical devices, biolab, and up to the product exhibition hall and model dental office. To join the tour, please come to the cafeteria at the given time. Also, we have gifts who come to the lectures online. So if you watch our programs online, and we are going to give out coffee and dessert coupons to 2,700 participants, and pop-up windows will appear, and you will notice one on the dental site, and please apply for the gift. Offline participants can join using the cell phone, and there's a high chance that you can win the lucky draw. After the lectures, the coffee coupons will be distributed and the winners will be announced. And the Galaxy S23, Galaxy 125 Pro, and mobile and other gifts are all prepared for you if you stay with us until the end. And one thing to note, to participate in the online event, you need to log into the dental site. If you have the membership in advance, it will help. And you need to use the landscape mode if you want to use the cell phone, so that the pop-up window can be shown to you. After the lectures, the Q&A will be held. The best questioner selected from the real-time chat and from the floor will receive a Wapic electric toothbrush. Offline best questioner will get the gift on the spot, and online best questioner will be contacted individually. Lastly, from 1:30 to 2:30, a discussion session is scheduled. Please participate in the survey, as you see on the screen, regarding clinical questions for complete edentulism using the QR code on the screen. Before the session begins, the QR code to join the survey is also on the banner at the entrance of the auditorium. Please participate in the survey during breaks. And then we are going to send you the online participation link to the online viewers. Without further ado, let's start the main part of the Osstem Meeting 2023. Congratulatory messages from President Sungkyunkwan of Korea Academy of Dental Science will be given to you. Please welcome me with a big round of applause.
Ladies and gentlemen, esteemed dental colleagues, I'm Kwon Keung-rok, the president of Korean Academy of Dental Science. It's a great honor for me to congratulate you on all the successful opening of the 2023 Seoul, Korea It's been 20 years since Osstem meetings started, and it has undoubtedly become a global celebration. Osstem has grown to be a renowned implant company not only in Korea but also worldwide. Alongside with this growth, it has also made significant strides in implant-related clinical practice and research, setting standards. And it has also provided guidelines on global scale. It is evident that it continues to make investments in R&D for top-notch implants and educational programs to foster exceptional clinical practitioners. And I would like to express my gratitude to Osstem as a dentist. On this occasion, the theme is the charm of digital dentistry for edentulous. While this is a challenging topic to address in clinical practice, I believe that through presentations of our esteemed speakers and their clinical experiences and know-how, we will witness advancements in our own clinical practices. For those present at the venue and those joining us online, from both within and outside the country via YouTube, you'll be given the opportunity to experience cutting-edge digital systems integrated with the best implant clinical cases presented by top clinical experts. This is our first face-to-face meeting since the end of COVID-19, and we have all eagerly awaited this day. And I look forward to today's contents. Finally, I would like to express my sincere gratitude to all Osstem staff who have worked tirelessly to prepare for this event. Thank you for your hard work.
President Kwon, Kwon, thank you very much for the message. Please give him another round of applause. Now let's get started with the first session. The moderator of the first session is Professor Yang-Jo Seoul, School of Dentistry, Seoul National University. Professor Seoul achieved the DDS MS PhD from School of Dentistry, Seoul National University, served as Vice President of the Korea Academy of Oral and Maxillofacial Implantology. Currently, he is a professor, Department of Periodontology, School of Dentistry, Seoul National University. Please welcome me with a big round of applause. Good morning, ladies and gentlemen. I'm the moderator of the first session, Osstem Meeting 2023. So, I would like to thank, and it is my honor to be able to be with the many renowned lecturers. Let's get started. And Professor Sang-Joun Yu of Chosun University Dental School is the first lecturer. He's going to talk about the full arch ridge augmentation tips and strategies. And please welcome me with a big round of applause.
Greetings, I'm Dr. Sang-Joun Yu from the Department of Periodontics at Chosun University. Is mic working? Please check. Can you hear me? Yes. First, I'm honored to be invited here at Osstem's meeting, and I'd like to express my gratitude to all the staff, as well as Professor Yang-Jo Seoul. The topic that I've prepared is full arch ridge augmentation in edentulous jaws. Chosun University is located right front of Mount Mudung in Gwangju City, and Chosun University Dental Hospital and Dental College is situated at the main entrance of Chosun University, and I practice at the Department of Periodontics on the second floor. As shown, in order to provide fixed prosthesis, we need to place multiple implants. This is necessary. If the remaining width and height of alveolar ridge are sufficient for implant placement, it is relatively easy to perform implant placement across the entire arch using digital guide system. However, encountering such patients is not so easy. What if alveolar bone is lacking in all areas and require bone augmentation? As shown, we can place implants and do bone augmentation dividing areas. However, in fully edentulous cases, if we divide the cases, then the individual surgeries, the number of it will increase and overall treatment duration will increase. Additionally, the temporary prosthesis delivery will be delayed and period for temporary mastication recovery can be prolonged. Therefore, it may be more advantageous for both the patient and surgeon to perform the surgery all at once. However, if we are to place implant to full arch, the most important thing is the duration of the procedure. If surgical time is prolonged, it may not be feasible to perform the surgery chairside, and local anesthesia instead of general anesthesia may be needed. We have already developed a system to reduce the time. This is digital guided system. If this is the experience of surgeon is very important. If there is a peri-implantitis, implant needs to be placed once again. And if the defect is extensive as shown, implant placement may not be feasible. When we face these kind of patients, this kind of thought comes to mind. Is there a way to avoid bone augmentation? Perhaps we may provide fixed prosthesis while placing minimal number of implants. In many literature, there's many reports placing 4 to 5 implants in premolar area or anterior area. We may be able to provide a full arch prosthesis. These reports are being made, but as shown, if the anterior ridge is knife edge in premolar area, the residual bone width is less than 5 millimeters. And if there's lack of alveolar ridge, in such case, bone augmentation is critical. Through bone augmentation, if we can get adequate width and height, then we should utilize it, and we need to provide it and place the implant for long-term function. I think this would be more favorable. If the patient is willing and financially capable, full arch ridge augmentation procedure should be performed. What kind of method is the best way? In choosing surgical method, what we should concentrate is the ultimate goal. How much bone augmentation do we want? Our goal is to create alveolar bone. The answer is given. There needs to be at least 8 millimeter in width and 10 millimeter in height in terms of alveolar ridge. And the ISQ value of 60 or higher should be secured in terms of primary stability, and there needs to be little alveolar crest or resorption. Such alveolar ridge needs to be formed. The surgical approach, are we going to do immediate implant placement or delayed placement? Are we going to do staged approach using bone augmentation? In order to do full arch bone augmentation, primary stability is very important. Also, this approach is feasible when dealing with little alveolar ridge defects of at least 4 millimeter in width and 7 millimeter in height. Then the use of digital guide system can facilitate precise implant placement. However, where it is not possible to achieve primary stability, especially when ideal implant placement is challenging or when significant amount of ridge augmentation of 4 millimeter or more is required, a staged approach with full arch ridge augmentation should be performed before implant placement. My typical approach involves simultaneous implant placement and ridge augmentation. When performing that, horizontal and vertical bone augmentation range is about 3 to 4 millimeters, and particular bone graft and resorbable membrane using Smart Builder is done. Different tools can be used. if the defect is significant and if implant cannot be placed, the smart builder will not be used. Titanium mesh can be used, or non-resorbable membrane reinforced with titanium along with a particulate bone grafting is used for full arch. I do not use a block bone for bone augmentation. It is not to say block bone is bad. I use membrane along with particulate bone graft, and I also use titanium mesh for three-dimensional space maintenance. I can shape the graft site according to my plan and create alveolar ridge in the desired position for the implant. In order to, if I can make alveolar ridge in the desired position form, I can place the implant ideally. This is the first case. The upper is Mish type 3 division BCD defect. The upper anterior area shows thin alveolar ridge. Posterior area shows lack of alveolar ridge horizontally and vertically. If you look at clinical image, alveolar ridge looks healthy, but if you open flap, especially in the anterior and premolar area, there is very thin alveolar ridge. What's the posterior area like? The right shows a residual bone height of 5 mm or less, while the left side has residual bone height of 2 mm or less. Vertical ridge augmentation is required. Surgical plan is formed. It is divided into three sections: the anterior region, right posterior area, and left posterior area. The anterior region showed thin alveolar ridge. Division B, our plan includes horizontal ridge augmentation. That's for right and left posterior areas, which require vertical ridge augmentation due to division C and D. We have considered sinus lift. We need to do predictable sinus lift. If there is a sinus in the posterior area, we need to do sinus lift. Additionally, vertical and horizontal ridge augmentation should be performed. When I do full arch surgery, I try to make a simple incision. I normally make one horizontal incision and two vertical incisions in the most posterior region. I perform surgery in this way. Following that, a full thickness flap is elevated and digital guide or surgical stent is used to determine the implant placement positions. Following that, the bone augmentation amount is determined. Sinus window replacement method is used for sinus lift, and horizontal bone augmentation is done to achieve buccolingual thickness of at least 2 mm in the alveolar ridge at the implant site. The horizontal bone augmentation should be performed, creating a bone graft site with buccolingual width of at least 10 mm. Once horizontal ridge augmentation in the anterior region is complete, then the posterior area of the alveolar ridge, a vertical ridge augmentation is performed to improve buccal palatal width using bone graft material. Then resorbable membrane is used and flap is sutured. Allograft mixed with PRF is used to enhance the handling characteristics of the graft material. In areas where space maintenance is key, space maintaining materials such as titanium mesh can be used on top of graft material. In the case of lower, there was sufficient vertical bone height and there was only buccal defect. Therefore, immediate implant placement and full arch ridge augmentation was performed with residual tooth extraction. First, we extracted the remaining two teeth, and then 4.5 by 10 mm implants, Osstem implants, were placed in the canine first premolar, first and second molars. We performed the buccolingual horizontal ridge augmentation using xenograft and resorbable membrane across the full arch, and then bone tack was used to fixate the membrane, and suture was done. This is after 6 months. In the upper, the graft material were not exposed, so we could clearly observe the successful completion of complete buccal-palatal horizontal bone augmentation in anterior and premolar areas. And in the posterior area, there's also vertical and horizontal bone augmentation in both sites. This is at the time of implant placement. Clearly, the surgical stent or the digital guide has facilitated precise positioning of implants. 8 years ago, the surgical stent was based on replication of temporary denture, and these days, digital denture is used, so surgery becomes even more simple. We focus on canine area to determine the position, and horizontal incision is made. Across full arch, horizontal incision is made, and at the most distal area, vertical incision is made to reflect the flap. Flap is reflected as shown, and you can see the titanium mesh beneath, and this is removed in a simple manner. I use scissor in this case. After removal, there's at least 10 millimeter of augmented alveolar ridge, both horizontally and vertically, and we normally start from the canine area, and implant is placed on the canine area. If there is digital guide, this process would be even simple, but there was no digital guide available, so parallel pin and mount was used to check implant angulation. Implanted drill. Under drilling is not done, and the implant platform is 1 millimeter below the alveolar crest. Multiple implants were placed, ISQ values were measured, and it all showed 65 or higher. If there is 75 or higher, then healing abutment is placed. Primary closure is done. After implant placement, panoramic image was taken. The secondary surgery for the upper was performed, and it was done for upper and lower. 2 horizontal releasing incision was made, and if you look at CT image after secondary surgery, you can see sufficient alveolar ridge augmentation buccolingually in the lower. This is final prosthesis. I do not engage in prosthodontic phase, so Professor Yu was in charge of that. So the final prosthesis, it was segmented into 3 pieces, and anterior, both posterior areas were segmented as shown. This is 3 years after, 6 years after, and this is 8 years after. If you look over here, there is very little alveolar ridge resorption, and it's maintained nicely. Let's look at the next case. It's a very similar case, and in upper Edentulous case, we come across these cases very frequently. MISH type 2 division BD defect. There is a very tight alveolar ridge in the anterior area and a bit of vertical bone defect. The alveolar ridge width is 3 to 4 millimeters, so horizontal bone augmentation was necessary. On both sides of posterior area, residual bone height is 2 millimeter or less, so significant sinus bone augmentation was required. Sinus lift and alveolar ridge augmentation was done in both sides, and it takes about 15 to 20 minutes, so you can complete it within 30 minutes even if you do both sides. And in order to do bone augmentation, decortication is done. In the area where bone graft is necessary, you check the position. The width of alveolar ridge is measured, and titanium mesh is folded chair side. I prefer folding it chair side, and you can check. The width is 10 millimeter, and you fold it like this. Once you get used to it, then it doesn't really take a lot of time. If you think it's going to take some time, you can fold it ahead. You can fold it within 1 minute as shown, and allograft and PRF is prepared in advance, and this is separated in order to prevent the clumping before bone graft. The releasing incision is made, and this is applied. The titanium mesh is used and bone graft material is applied here, you can save time significantly. Next, you need to fixate it. In this case, bone tack was used. So about 2 to 3 bone tack are used for each segment. You can use a screw. I apologize. Three segments. In this case, the surgery was done here. The gap between segments, bone graft materials were used to ensure bone contour. Then primary closure is done, and before that, you use a resorbable membrane here, and primary closure is done. This is after primary closure. This is post-op CT. If you look at the post-op 6-month CT, you can see nicely formed alveolar ridge, and there's very little resorption. Full arch flap is opened and titanium mesh was removed, and buccolingually there is 10 millimeter of width, and multiple implants have been placed focused on canine area. When you place implants, there needs to be at least 2 millimeter of buccolingually augmented bone. This is clinical image after final prosthesis. 3 segments were done for the upper, and this was done by prosthodontist Professor Kyung-Jae Lee. This is after 3 years and 9 years panoramic image, and you can see no significant alveolar crest bone resorption. And in full arch cases, when performing bone augmentation, approximately 6 to 10 months of maturation period is necessary. During this time, the bone graft may be absorbed if temporary dentures are used. Therefore, we do not let the patient use temporary denture, and at times patients are unable to have normal meals. However, as shown in this case, where 3 to 4 box-shaped rigid titanium mesh segments are used, temporary dentures can be worn starting from 2 months post-surgery. After 2 months, you can see that there is very little titanium mesh exposure. This is the final case. This is a surgery that has been performed 9 years ago, and this is possible. All teeth except the most distal tooth have been lost, and there's also posterior area loss in both sides, and upper is type 1 division D. And if you look at clinical pre-op image and 3D model, you can see that alveolar ridge in the anterior region has been completely resorbed, measuring less than 2 millimeter and extending to the nasal floor. And the CT scan shows that posterior alveolar ridge is almost non-existent. The maxillary sinus remains partially on the left, while the right side and the remaining areas are predominantly nasal cavity space. And this is possible too after horizontal incision. Flap is reflected, as mentioned earlier. 1 horizontal incision and 2 vertical incisions are made, and titanium mesh is adjusted. And after that, you can treated the sinus first. So the sinus existed only in the left side. So sinus lift was done. I used piezo surgery saw to do replacement technique, and you can do it within 10 minutes. And the patient should be able to use temporary denture. So there was a little bit of bone in the most posterior area. So 4.0 diameter implant was placed, and the magnetic type abutment was used, so the patient can use temporary denture. Magnetic type abutment was applied, bone graft. Before that, releasing incision is done. As mentioned earlier, right after the beginning of surgery, PRF and allograft is used. If necessary, RHBMP2 can be used. The folded titanium mesh, and on top you add the bone graft material, and you can reduce significant amount of time, and fixation is done. the residual bone was less than 2 millimeter and 1 millimeter, so screw cannot be used. Multiple bone tacks were used to fixate the titanium mesh. 4 segments were made, and it doesn't really take long to fixate it because the plans are made ahead. 4 segments are fixated, a secondary suture is done, and resorbable membrane is applied. This is post-op panoramic image, and the horizontal and vertical bone augmentation is done nicely, and after 6 months, the titanium mesh is not exposed. If you look at CT, there's a bit of bone graft material loss, but overall there's nicely formed alveolar ridge. This is after 6 months upon implant placement. The implant placement positions were verified based on the replica of the denture. The most important position is canine. As I mentioned earlier, 1 single horizontal incision was made to reflect the flap, and you can see titanium mesh. This is removed. There are 4 titanium mesh used. Scissor can be used to cut the titanium mesh and remove it. This is a much easier way. In the canine area, the drilling is done. You can see that the drilling is not done nicely because it's very hard bone. Parallel pin is used, and mount is used to check angulation as we place implant. It can take a significant time, but because digital guide is available, you can perform it with much more peace of mind. After implant placement, IASQ measurement is made, and you determine whether to proceed with a secondary surgery or to do primary closure. Upon implant placement, as mentioned, buccolingually, there needs to be 2 to 3 millimeters. And in this case, 8.5 millimeter implant was used. A 7 millimeter drilling was done, and it was subcrustally placed. In this case, 7 to 10 millimeter of a vertical and horizontal bone was achieved, and multiple implants were placed. In all areas, the residual bone height was less than 2 millimeter, and a 1-piece hybrid type fixed implanted prosthesis was fabricated, and a vertical bone augmentation was done in the lower, and multiple implants were placed. If there's less of 2 millimeter of bone, you can do only vertical augmentation to place the implant, and sufficient bone augmentation can be gained. When we do full arch ridge augmentation, and if the amount of bone augmentation is significant, you wonder whether it's going to be maintained long-term after implant placement. After surgery, will the alveolar bone resorb, or will it be maintained? A lot of thought is made. The alveolar crest, the resorption occurs for different reasons, and the ridge resorption may occur within the following first year after prosthesis delivery due to different reasons. On the other hand, the cases where ridge resorption is maintained for more than 3 years, it can be considered successful. The resorption patterns observed after 1 year of prosthetic delivery can be influenced by factors such as prosthesis design occlusion and oral hygiene and maintenance. What I want to highlight is that if surgery has been done nicely, the implants are placed in the ideal position prosthetically and in terms of oral hygiene, ridge resorption around the implants can be minimal, ensuring long-term success. To achieve this, appropriate alveolar ridge augmentation should be done. If there is about defect of 7 to 9 millimeter or more and requiring vertical bone augmentation, long-term stability can be very depending on various factors. And like lower anterior area where alveolar bone ridge is very thin, prone to resorption, achieving predictable outcomes can be challenging. And you can see that after treatment, bone augmentation is done. This is post-op 5 and 10 years. There's no alveolar bone loss or gingival recession. And if you look over here, there's no bone loss after 5 and 10 years. If the bone width and height was very lacking, and about 10 millimeter of vertical bone augmentation was done. But if you follow the right principles and perform surgery, then long-term success can be ensured. I want to summarize now. In doing full arch bone augmentation, the key is to restore patients' mastication and function. We need to come up with an approach that is acceptable and yields favorable outcomes for the patient and surgeon. The surgery needs to be performed quick and simple, and it needs to be done within 1 to 2 hours. In order to do this, we need to understand clearly about the form of alveolar ridge that is to be formed, and we should not hesitate. The longer and the more we hesitate, the longer the surgery will last. And in those cases, digital guide systems can be of great help. You form the arch focusing on the canine and alveolar ridge of both width and height of 10 millimeter needs to be formed. I do not use autogenous bone. I use bone substitutes 100% of the time. If you do not use autogenous bone, you can reduce surgical time, and you can do it very simply. And I tend to use simple flap design. I make one horizontal design and 2 vertical incision. I try to design my flaps simple, and this will ensure simple suture design. And I use a sticky bone along with a PRF. I use allograft too. Then you need to layer it, and then you will be able to reduce surgical time. Also, particular bone graft technique is used, and digital guide systems can be used. In this case, accuracy and speed of surgery can be improved. Sufficient bone augmentation can be ensured. Multiple implants can be placed, and surgical and prosthetic complications can be reduced. By placing implants in ideal positions, oral hygiene can be done nicely, and this will help in ensuring long-term stability. This is what I've prepared, and at the Chosun University School of Dentistry, we have a team of 5 professors and 10 specialists who are dedicated to providing periodontal and implanted treatments. We have particular interest in vertical bone augmentation and full arch alveolar ridge augmentation procedures. I appreciate your attention. Thank you for listening. Thank you, Professor Yu. Please give Professor Yu another warm round of applause. Q&A for the first lecture will be done after the first session.
Let's go to the second lecture. This lecture will be delivered by Dr. Sung-Hwan Oh from Ohsunghwan Healing Dental Clinic with the topic of a new prospect in full mouth rehabilitation all on X. Please welcome him with a big hand. My name is Sung-Hwan Oh, as was introduced just before. Thank you very much for inviting me. Today, I'm going to talk about all on X, using a few implants. Full mouth rehabilitation is implemented. As Dr. Yu said, a lot of bone graft, the bridge type full mouth reconstruction was explained. And today, I'm not going to talk about such a big case. When a case is for a systemic disease patient or old patient, full mouth reconstruction cannot be done. And for those who have worn a denture for a long time, more simpler full mouth reconstruction approach can be adopted, which has been around for a long time, and I'm going to talk about that today. So I will focus on all on X, the strategy, and a long-term stability, and all on X complications using clinical cases, and using digital technology when the reconstruction is done. I'm going to talk about how easily you can do that and the outlook for the future. The computer doesn't work. Apologies. First, the clinical case, 76-year-old female patient. She wore denture for a long time, and there was a discomfort, and abutments were fractured. So she came to the clinic. So implant-supported reconstruction was to go, especially the implant could not be placed in the posterior lower jaw. Digital guided system was included in the plan. Implant placement right after extraction, customized healing abutment, and temporary bridge type provisional were fabricated for immediate loading. The lower anterior teeth were all removed, and multi-unit abutments were connected to implants, and the provisional was fabricated in a form of a denture. The patient maintained the temporary pretty well. 3 or 4 months later, segmented ER-type, bridge-type implants on the upper and in the lower, one-piece metal framework, resin teeth, and in the gingiva, resin facing. So prosthesis and fitness was pretty good. 3 years after, 8 years after, no major problems were encountered. So as it became old, the prosthesis could fracture, and there was no discomfort. At the 35, 8 years, the prosthetic fractures were happening. So at post-op 9 years, new titanium framework was provided, and the zirconia facing was done. Another case, in this case, there was no bone in the upper. A denture was used quite a long time. CT views, the bone was very thin. If you analyze it with the guide system, you can find the areas where implants could be. placed. So we used the minimal incision, and the bone was expanded. And out of 5 implants, temporary was used during healing, and 1 failed, but the 4 implants survived. And the fixed bridge, not fixed bridge, but metal framework hybrid prosthesis were delivered, and they had very good fitness. And the post of 3 years, 6 years, 8 years. So it was maintained very good, and the patient was very satisfied. The last case, another case, all on X for the upper, 71-year-old female patient. The teeth were remaining, and without extraction, the mandibular position was captured using the remaining teeth after extraction. So 4 in the upper and 4 in the lower implants were placed, and the temporary prostheses were delivered for immediate loading. Provisional was maintained because of the immediate loading. The implants, due to framework, they were connected strongly with each other. After surgery, after 2 years, 5 years, 7 years. So post of 7 years, a little bit of resin teeth fracture occurred, because there are many reasons. Recently, the patient received new titanium milled framework, and that was changed to zirconia facing. So she was retreated. The patient didn't experience major discomfort, resin teeth fracture, but there was no speech problem or food impaction. For a long time, using a few implants, fixed hybrid denture is used with all on X, utilizing the remaining teeth to the maximum, and the implants are distributed widely using tilted implants. So Dr. Malo came up with the all-on-4 concept in early 2000. Minimal graftless, long and tilted implants were used. AP spread is increased, cantilever length is reduced, and if possible, immediate loading was used. Fixed bridge, temporary prosthesis is used, and the screw type was used, so the provisional could be maintained easily. There are many evidences and long-term results. EAO consensus, a tilted implant and a small number of implants, of about 4 implants were used to maintain the rehabilitation for a long time. Many scholars talked about good strategy for all on X. 4 or more implants, when distributed appropriately, rigid arch splinting is required. From early 2000, I have been doing this quite a lot, using a digital guide, more accurate, appropriate implant the positions are captured, and a minimal invasive placement, and the 4 implants and mandible, and at least 4 implants in the maxilla, and 2 additional implants in the posterior region, if possible, for all on 6. And after some time, implants, not after some time, but immediate implant replacement was done for immediate loading, and the vertical dimension is maintained with the digital workflow. And this process is using multi-unit abutments with the screw type. So the treatment results that I have performed from when I was in university, I opened my practice about 10 years ago, and I followed them up since I opened my practice, and 5 years or more follow-up was done with these patients from 2014 to 2018. 18 patients with 22 arches. So 4 to 6 implants were placed. This guided system was used for the placement. In most cases, immediate loading was done, and PMMA or 3D printing used for temporization. Final prosthesis used the one-piece framework, one-piece hybrid the prosthesis, and I reviewed the results. The critical points were identified, and these are the ones. Mechanical problems in prosthesis, food impaction or retention, and discomfort to the patient. And when tinted implants were used, any mechanical problem or periodontal biological problems in the long term. And another important factor was immediate loading. So with 4 implants, immediate loading was done, and what was the result? And the digital technique, whether it can be applied appropriately. That was the points of the review. 22 arches were reviewed, and 44 implants in the maxilla and the rest in the mandible. Success rate, 5 out of 44 in the upper failed. During immediate loading, they failed, and the failed ones were removed, and the implants were placed again, and immediate loading continued, and there was no failure in the mandible. And implanted types at the beginning, Straumann or Bronnemark implants were used. Recently, I use local implants. Osstem TS4 or TS3 are widely used. And this is the result. And complications, there are many factors of the complications, and most common complications, the discomfort to the patient, the mechanical problem with the prosthesis, the framework fracture, and it's not a major connector fracture, but resin teeth fractures were quite common, resin facing fractures. The reasons for that: a lack of a prosthetic space, so the resin thickness was not sufficient enough, and in the cantilever area, fractures occurred. When bone was reduced sufficiently, providing sufficient space for prosthesis, the fractures did not occur. So screws were loosened and retightening was made at the chair side when problems occurred. Resin has a pretty weak physical characteristics, so they are replaced by zirconia, resolving the problem. Zirconia facing, titanium milled framework, zirconia facing over the framework. When the prosthetic space is insufficient, mechanical problems occurred. One more thing, All-on X treatment protocol should have at least 50 millimeter for prosthetic space for both jaws. In the upper, the vertical dimension, if 50 millimeter of space cannot be secured, mechanical problems can occur. So that is something we have to pay attention to. When prosthetic space is short, there's a poor transition line and aesthetic problem can occur, especially for high smile line patients. And the prosthesis fracture and the food impaction may happen. So what we want to emphasize when it comes to All-on X, sufficient bone reduction is required, especially in the upper anterior region for prosthetic space. So I cannot overemphasize that. The second important thing when it comes to discomfort is the food impaction or retention. It occurs more on the maxilla than mandible. Especially in the posterior upper area, implants are placed lingually. So vertical bone defect can be severe in that area. And transition line is short when prosthetic space is not sufficient on the upper jaw. So on the lingual side, the space should be made sufficiently. And in the posterior region, vertical space should be secured for ease of cleaning to prevent food impaction or retention. In the posterior maxilla, when AP gap is severe, food impaction may easily occur in the anterior region. And in the lingual side, enough space should be maintained. In the mandible, food impaction, when rich level prosthesis was provided, enough space can resolve the problem. Food impaction. So after the treatment, the food impaction is not usually complained by patients. Tilted implants. What happened to the implants? In cases with 5 years of longer follow-up, there was no peri-implantitis. In the lower anterior region where straight implants were placed, 2 caries happened because of the short biologic width. That means the soft tissue height was not sufficient and the buccal or lingual bone volume was insufficient from the beginning. If you look at this case, 76-year-old female patient, and the treatment was done in 2015, immediate loading after extraction. One-piece metal framework was used after surgery, and prosthesis was delivered the post of 3 years, 7 years, 9 years. In the lower anterior, mucositis developed, and it developed into peri-implantitis. Peri-implantitis is being treated, and the prosthesis is maintained in a narrow reach in the lower anterior region. Bone reduction should be sufficiently done, so the remaining bone should be secured, and you need to consider the biologic width. 1 out of 18 cases, post of 7 years, screw loosening happened for the tilted implant. All on X is connected, and if screw loosening happens in one of them, it is hard to detect. They look rigidly maintained, but screw loosening happened and it was not detected, and the screw fracture happened. There was one case out of 18, a 67-year-old male. The 4 implants were placed in both jaws, and immediate placement and immediate loading. So fixed hybrid prostheses were delivered post of 2 years, 3 years, 5 years. At 5 years, on the left-hand side, resin tooth fracture and screw loosening happened. It was retightened several times, but post of 7.5 years, the tilted implant showed the fixture fracture, implant fracture, so it had to be removed, and the remaining 3 implants were used to maintain temporary, and implant was placed again. The initial primary stability was maintained, so immediate loading was done. And lastly, the final prosthesis was delivered again. The problem with all on X, when one implant fails, what is the answer? The remaining 3 implants can be used for immediate loading and immediate prosthesis. So when one of them fails, the rest can be used, and the one problematic implant can be addressed. For immediate loading related implant failures or temporary fractures that can happen frequently, I have been doing immediate loading from the beginning. So the implant problems, I was not afraid of the failures. Fractures occurred in most patients once or a few times. Now, digital approach is used. The temporary is provided immediately, but at the beginning, it was not so. When implant fails, it is in the upper, not in the lower. 2 failures occurred, and 3 failures occurred sequentially in one patient. Let me show you the case. All on X on both jaws. As you can see, implants were removed and implants were placed, and they were immediately loaded. The upper implants were addressed by removing the implant, and the immediate loading continued with the rest of the implants and up to the final prosthesis. Newly placed implants also integrated pretty well, and post of 6 years, 7 years, the implant prosthesis were maintained properly. Temporary prosthesis, and continuously they ask questions: do we really need to do immediate loading for the temporary prosthesis? The removable temporary prosthesis is not very comfortable, but this interim abutment gives a lot of convenience to the patients, but the people are concerned about this, the doctors. At the beginning, the holes were made and it was reinforced by metal, which had pretty good results. But when a denture cannot be used in a case, reinforced resin printing can be used as thick as possible. It is fabricated for immediate loading. Now it's much better. When digital technique is applied to All-on-X, what changes has it brought? I reviewed it. I adopted the digital approach about 6 or 7 years ago. For All-on-X, when digital approach was used, it started with the digital guided surgery to place implants. And the one-piece of framework, can it fit really accurately? That was the question. And immediate loading, 3D printing and milling was used to be delivered with a screw type. How can it ensure accuracy and provide comfort to the patient? Repeatedly, I went through trial and error. Now, I can achieve a very accurate outcome. I'm confident about this. So digital approach is very important for All-on-X. If you look at this case, a 57-year-old female patient, severe bone deficiency and denture discomfort was the complaint, and a guide system is used to analyze the situation, and implants All-on-7 was designed for the upper and All-on-4 for the mandible, and the remaining bone was carefully analyzed, and implant placement, immediate placement, and primary stability was achieved, and this is oral scan, and vertical dimension is maintained, and the temporary was delivered on the next day. The temporary was maintained until the final prosthesis, so that served as a foundation for the final prosthesis, framework for the mandible, and segmented bridge type for the maxilla. So all of this, full mouth modelless digital approach, incorporated all of this. Fitness was maintained long term. The last case, in the maxilla, a lot of bone resorption was observed. In the remaining bone, sufficient number of implants were placed using a digital guide, and vertical dimension is maintained, and multi-unit abutments were connected immediately, and they were scanned. The vertical position when guide was fabricated, and the lower jaw position was maintained too when fabricating a temporary. So the implants in the upper anterior region were stable, so provisional was maintained using the implants, and the first, third, and second, third provisional were provided before final. The framework was connected to implants as one piece, and because of the performance of multi-unit abutments, the fitness was very good. In the maxilla, 7 implants were connected with one piece. Conclusion. All-on X, a small number of implants are widely distributed, and then we fabricated a fixed hybrid prosthesis. In the past, internal hex implants, multiple screw type implants were considered very difficult for those, but now newly developed multi-unit abutments and oral scanners accuracy and mandible position vertical dimension can be maintained and preserved and transferred, so very accurate, much more convenient one piece of prosthesis can be delivered to patients. It is very safe, predictable, and it has long-term stability. So this can be a very comfortable treatment modality for patients. So it is the minimally invasive treatment for patients, and with the further development of digital technology, this can be improved as a much better treatment modality. All-on X, All-on 4 has a very brighter outlook for predictable treatment. That is my conclusion, and this concludes my presentation. Thank you for your attention.
Thank you, Dr. Ohsunghwan, for the wonderful lecture. And Professor Yu Sang-Joun, please come on to the stage. Their position on the stage. Now we will have the Q&A session. Let's look at a couple of questions raised on dental chat. First, Professor Yu Sang-Joun, you tend to use a lot of titanium mesh, and it seems that exposure may be frequent. So how do you address exposure, and how can I prevent titanium mesh exposure? Thank you for the wonderful question. Among my cases, in the case of exposure, it's less than about 10%. As I prepared my lecture, I did an investigation, and in 2012, since then, between 2012 and 2018, I've done about 50 or so cases, and in 6 patients, there was exposure. The 10% of exposure, it may be difficult to compare when you use a membrane, and exposure occurs in about 13%. So titanium mesh exposure percentage is not really high. When I first used titanium mesh, I decided to set a criteria for using titanium mesh. If the residual bone is less than 3 millimeters, I decided to use a titanium mesh, and there was no exposure. And 3 millimeter, I decided that there will be no exposure in the case of less than 3 millimeter. In the case of 2 millimeter, at times there was exposure. Once there's exposure, rather than addressing it, the first thing is to prevent exposure itself. The early stage exposure, which occurs within 2 months. Late exposure is after 2 months. It's not a problem, but early exposure is a problem. In order to prevent that from happening, below titanium mesh, when you do bone graft, you need to do it quite tightly, or else within 2 months, as healing occurs, a bone graft, if it is immature, then it will be sunken. Depending on the amount that is resorbed, the exposure of titanium mesh can occur. You need to do bone graft in a very dense manner, and if you add a resorbable membrane, then you'll be able to reduce the percentage of titanium mesh significantly. In the case of early exposure, there's no actual way to address it, as we need to keep it as much as possible. In the case of late exposure, it occurs after 2 months. So in that case, when the patient feels discomfort, you can use high-speed round burr to remove it. And normally, I have the patient keep it for about 4 months. And then in the case of late exposure, there's no inflammation. The patient may be a bit surprised, but the inflammation does not occur. So you need to do plaque control in that case properly. After GBR, you place implant after 6 months, and then after about 2 months, soft tissue healing occurs fully. And then you can do implant placement. The alveolar bone loss after exposure, it's about then if you do GBR about 2 to 3 millimeters, then you'll be able to avoid any problems. This question is related. If you do extensive bone augmentation, there can be lack of soft tissue. Is there a special tip to do releasing? Alveolar bone loss, if it is extensive, soft tissue can be lacking. The vestibule should be superior, but it becomes lower. So soft tissue insufficiency can occur. In the case of upper, when you do surgery, horizontal incision position is very important. You need to make it as much buccally as possible because the palatal flap, this is not mobile. And if you make a palatal incision, then when doing a suture, the suture line will not be crestal, but it will be palatally. Therefore, the flap exposure can occur. You need to make it as buccally as possible. 0.5 to 2 millimeter buccal side incision needs to be made. The buccal flap, you can do different releasing incision, so it's not going to be a major problem. It's the same with the lower. You need to make the incision as buccally as possible, and that is the key. In the case of lower, there may be lack of keratinized tissue, and it is very difficult to do keratinized tissue graft in certain cases. So by making the incision line buccally, you can gain as much keratinized tissue, and if there's lack of buccal keratinized tissue, you can do keratinized tissue graft in that cases. Thank you. There's also a question for Professor Oh.
In the maxilla, on the palatal side, especially in the canine area, when implants are palatally placed, the speech problem or discomfort, what kind of discomfort would the patient experience? Palatally placed implants, I had some of those, and the patient used the denture for a long time, and the denture can cover the palate. So palatally positioned implant didn't really create a problem for the patients. If the tongue space is sufficient, that means the vertical dimension is much higher. So the tongue to the palate can be reduced. So palatally placed implants would not create a problem, in order not to invade the tongue space. So the distal to the premolar should not go near there, but in the anterior region, the palatally positioned implants would not be a problem. So in conclusion, the vertical dimension should be sufficiently secured for the tongue space, and palatal position of implants should not be used in the posterior region. There was no complaint about speech by patients. Sometimes I intentionally place implants palatally in very narrow ridge. So it is very challenging to do a surgery if you want to do the bone graft. So palatal mucosa is very strong and thick, so GBR can be done easily. But as long as it is not too excessive, a little bit of palatally positioned implants would not pose a problem. Thank you very much. One more question. In All on X, the metal framework is used not in hybrid type, but cantilever bridge. What are the pros and cons of which? Cantilever bridge without a framework, yes, the long cantilever. All on X in the mandible, if it is within mandible foramen and they are connected as one piece, so mandibular flexion doesn't create a problem. And the framework has a very rigid cross-arch strength, so mechanical stability is very good. When cantilever bridge type is used, it is more unstable, so I use the framework from the beginning. All on 4, a cantilever is not very good, so I always try to place implants in the posterior region to reduce cantilever as much as possible. In the old Brennemark system with all on X, all on 4, so cantilever was allowed 2 times AP spread, but it was old concept. And when we increased the cantilever, metal prosthesis created fractures quite often, so I reduced the cantilever as much as possible. So the implant needs to be positioned in the posterior with the tilt as much as possible. And if the implant is lingually placed, the cantilever can be reduced. So geometrically, lingually placed implants can reduce cantilever. In the mandible, bone quality is not very good, so all on 6 would be better. With 2 vertical implants at the back. Socket elevation with a crystal approach can be done. So 1 or 2 implants in the upper posterior can be easily done. So immediate loading from the anterior implants and metal prosthesis, one piece can be used, reducing the cantilever and complications. Questions from dental chat? Do we have any questions from the floor? Please raise your hand. Please identify yourself. My name is Sang-Joun Kim. I have practiced in Cheonan, and my question goes to Dr. Oh, all on X. The physical property of prosthesis. Resin hybrid has been used and followed up by you from 2014. A hard zirconia or metal crown follow-up in relation to bone loss. Have you reviewed such cases? Zirconia, I changed the teeth to zirconia from a couple of years ago, and I used the resin teeth in the past. Resin was used over metal framework, and a denture was fixed in all cases. So I follow them up, as you said. The teeth fractured, but there was no problem with the framework. So your question, there was no problem other than resin fractures. So the time is up, and we can take one more simple question from the floor. Professor Kim. Thank you very much, two doctors. My name is Myung-rae Kim. I have a practice. Dr. Yu.
You use different forms. Titanium mesh exposure is concerned by many people. And you always use a resorbable membrane. Titanium reinforced Gore-Tex membrane is also used. If you just you use a resorbable membrane, but in order to remove titanium mesh, you open and remove mesh. And why do you do that? Gore-Tex membrane. Do you use it, or is there a reason why you try to avoid it? That is my first question. Thank you for the wonderful question. Titanium reinforced Gore-Tex membrane. In 2011, since I've been treating, it was not available in the market. Titanium reinforced cytoplast is also used. One of the downside is that, as shown in the case, in order to increase vertically by 7 to 8 millimeters, the width is 10 millimeters, and the length should be about 30 millimeters, and the cytoplast that is available does not reach that much. That is why I don't use it. In the case of non-resorbable membrane, if you use it, when you place implant, you need to remove it. The titanium mesh is the same. It does not mean that you need to do additional surgery. Thank you. Dr. Oh.
I think this is connected to the previous question. You started with all-on-4, and now it is changed to all-on-X. Sinus graft and cantilever is reduced using 6 or 7 implants. I agree. In the mandible, it is okay, but in the maxilla, it is hard to establish long-term follow-up with 4, and once it fails. So these days we use a digital. We use all-on-6 or all-on-7 more than all-on-6 or all-on-7 more than all-on-4. Thank you for your question. At the beginning, in the maxilla, I also used all-on-4. When you place more implants in the maxilla, can we achieve accurate one piece? So we placed only 4 implants, up to 4 on the maxilla, but we place 2 more implants in the posterior region, and there's no problem in connecting them in one piece. Based on my experience, I didn't have any experience of failures with 4. I showed you implant failure. That was the only one failure I experienced. So on 4 doesn't create a problem in the maxilla, but cantilever should be reduced as much as possible in the design. The most important thing when it comes to all-on-4 or all-on-6 is the material and the accuracy of multi-unit abutments. They are developed quite well, and multi-unit abutments are very strong and precise, and impression can be taken very accurately, and fixture design is important, but multi-unit abutment performance is also a success factor for all on X in terms of impression taking and in reducing cantilever. Thank you for the good answers. So we have so many questions, and in the dental side we have so many questions, and my apologies not introducing them, all of them. Best questioner, the nickname Hot Guy 12 and Joni. Those two who posted the questions on the dental, Dr. Kim Myung-rae and the doctor from Cheonan, who asked the questions from the floor, are chosen as the best questioner. Thank you.
Thank you, Professor Yang-Jo for serving as the moderator of the first session. For those of you who have been selected as the best offline question, we'll deliver the gift to you during the break. As for those who have been selected as the best online question, we'll contact you individually. Next is the announcement of the winners of coffee coupon event. A total of 300 people will win coffee coupons. So let's see who's won them. Congratulations. For the winners, coffee coupons will be sent to you via text message. You can also check the details on dental website notice board. If you were not selected in this draw, you do not need to worry. There are still multiple events remaining. Log in to dental site and stay with us until the end. And now we will have a break up to 10:45. If you go to the right side, there's 30 excellent posters and the delicious beverages and snacks. See you soon.
Introducing the E-Star Z series. E-Star Z is a zirconia block made by Osstem Implant. The E-Star Z was developed by our R&D specialist at Osstem Implant. Our in-house specialist at Osstem Implant developed the manufacturing process. Each product is inspected and completed through a systematic quality inspection. E-Star Z is a CAD/CAM compatible material that simplifies the process of creating zirconia prosthetics at the clinic. It can be fabricated in various dental restorations, including inlays, veneers, crowns, and bridges. Multiple prosthetics can be milled simultaneously with E-Star Z. The disc is in 98mm diameter and has 7 different types of thickness, which means you can select the right disc according to the length of each prosthesis, so that the material can be used more efficiently. Meanwhile, the shape of the block that comes with solid metal mandrel is diversified depending on cases. In particular, if you want to fabricate a long implant or bridges, you can choose block type with the 25mm height. With the E-Star Z HT, you'll experience natural-looking colors. With 3 different shades, A1, A2, A3, you can replicate the patient's natural teeth color. E-Star ZT has an excellent strength. Thanks to high flexural strength of at least 800 megapascal, you can fabricate stronger prosthetics for the posterior region that is susceptible to high masticatory pressure. Zirconia prosthesis material with natural-looking colors and outstanding strength. Try the E-Star Z series made by Osstem Implant.
Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these two parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer, and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutment by thickening the walls and implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution.
Introducing the Asset Kit for Narrow Alveolar Ridge Split. The Asset Kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The Asset Kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out.
Have you ever experienced difficulties in finding a right spot for implant placement? Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stent. Positioning Guide Kit contains both single guides and bridge guides, so clinicians are able to deal with different clinical cases. The single guide is transparent and cylindrical, comes with a diameter of 5 to 10 millimeters. Clinicians are able to put a single guide next to another single guide or close to an adjacent tube for drilling. The single guide helps clinicians to pinpoint the spot for placement and direction of the implant. The fan-shaped bridge guide enables clinicians to adjust interval from 7 mm up to 12.5 mm. Bridge guide allows clinicians to adjust the interval by the margin of 0.5 mm and to drill toward the same direction as previously drilled site with convenience. Positioning guide kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand.
Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. Smart Guide is made of thermoplastic resin. Dipping the Smart Guide in the 70-degree Celsius water for 1 minute. Then, clinicians are able to manipulate the shape of the guide as they desired. When the Smart Guide is shape shiftable, it is able to extend or reduce its size up to 1 millimeter when the guide pin is connected. Among 4 different types of 3D guides, clinicians are able to select suitable one for clinical case. Also, the Smart Guide enables to maintain the precise drilling path with 7 millimeter sleeves. Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. For your implant placement, try Smart Guide Kit now.
Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5 as both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. I would like to introduce T2. The T2 provides clear images and helps accurate diagnosis for dental treatment. T2 offers a multi-FOV sizes that help take images including facial, implant, TMJ, antodontic treatment, and other images depending on the type of dental treatment. All you need to do is take image of the area you need to examine, and low dose of radiation is used for generating better image quality. The T2 comes with easy-to-use software including the 1.2, 1.3, and VSET, which helps you deliver accurate diagnosis and set accurate implant treatment plans, and ultimately convince more patients to proceed with treatment. Make your treatments more efficient than ever with the T2 that provides clear images and helps deliver accurate diagnosis.
We're about to start the second session of Osstem Meeting 2023. Before we begin, I will provide guideline as to what kind of online event there is. If you check the second event pop up on the dental website, will be displayed. Don't miss it and participate to win your chance at getting coffee coupons. The draw results will be announced after the completion of the second session, and coffee coupons will be sent to you via text message. Please remember that as your viewing time increases, not only coffee coupons, but bakery coupons can be won. Your chances of winning will be increased, and you can also participate via your cell phone. And please note that the pop-up appears when you position the cell phone in vertical position. Let us begin the second session, and let us welcome Dr. Park Chun-jin, Director of Gangnam National University Dental Hospital. Dr. Chun-jin Park graduated from Seoul National University School of Dentistry and obtained his PhD from Seoul National University Graduate School. He has also served as an associate professor in Prosthetics Department at Osaka University Dental Hospital. Currently, he is professor in the Department of Prosthetics at Gangnam Dental Hospital, and he also serves as director of Gangnam National University Dental Hospital. Please give a big round of applause. Thank you. I am the second moderator, Dr. Chun-jin Park. Today, we are here in Osstem Meeting 2023, and we are here to talk about advancing digital dentistry. I hope we get insightful knowledge. And let me begin introducing the second speaker. This person is very famous, and Dr. Park Hwee-Woong is very knowledgeable. Dr. Park is going to talk under the title Planning for Implant-Supported Fixed Restoration of Fully Edentulous Patients, and is going to talk about how to restore fully edentulous patients, and he's going to focus on analog ways. Let us welcome Dr. Park. Greetings. I am Dr. Park of Seoul East Dental Clinic. I'm honored to be here in Osstem 2023 meeting. I have studied with Dr. Park, and I'm honored to present with the moderator today with us. When I was a student, I received a lot of help from Dr. Park Chun-jin, and I was able to complete my education, so I really feel appreciative. I would like to express my gratitude to Dr. Park. In this session, I'm going to talk about providing restoration for fully edentulous patients. I'm going to focus on prosthetic phase. Dr. Bae and I'm going to talk about this topic. I'm going to talk about analog ways. When treating patients with implants for edentulous or partially edentulous patients, so we need to think of this order. There are steps that we cannot omit. The conventional way or analog ways are as shown. As shown here, diagnosis is done, surgery is performed, and conventional prosthetic phase is done to deliver final prosthesis. As of late, digital technologies have emerged and advanced. For different analog steps, there are digital steps. How are we going to utilize the pro and cons of both the ways, and a lot of considerations are made as to which is more advantageous. And a lot of knowledge is being garnered, and I want to focus on analog aspect today. As I was preparing the lecture, in the end, the analog way is an older way of doing things, and compared with the digital dentistry, I believe that a lot of the old ways will be replaced. I think this is set. The conventional way still does hold value, and this is accumulation of our predecessors' hard effort, so we be able to provide efficient treatment if we utilize some of their know-how. I want to focus on 5 different clinical steps, and up to full restoration, and for maintenance, different steps are taken, and it can be classified into 5 different steps. The first, diagnostic phase; second, the surgical phase; third, provisional phase; fourth, the restorative phase; and fifth, the maintenance phase. Let me share with you a case, and I want to talk about different steps. The patient is male patient in 60s. There are very few patients with such good conditions. It's unrealistically favorable. Multiple implants have been placed at the same time, and the full edentulous ridge was immediately restored. The diagnostic phase is very important when we treated these complicated cases. This is complete denture concept. When we form complete denture, we use this technique. Preliminary model is used, wax trim is used, and vertical dimension and lip support is checked. Model mounting is done. Conventionally, wax denture is made, and a denture tooth arrangement is done. Here, I've used a bit of CAD/CAM technology. Digitally, teeth alignment was done and milling was done. Artificial teeth are all connected. The plaster model mounting is done. And to support the gingiva, the flange type of palatal pad was attached. And the different steps will be taken. What is most important is trial denture. And you need to try in and simulate the final denture. And then you make a hole, and you can use it as surgical guide, the analog guide, or after placement, you can change it to use it for immediate restoration. This is before surgery. This is a diagnostic phase. Trial denture is tried in, and as trying is done, just like trying in wax denture, you check vertical dimension and occlusion. Next, this is the surgical phase. I did not use computer-guided surgery. I just placed implants of freehand. The guide was used. I made a hole and placed 7 implants freehand, and guide was used. For resin prosthesis, relining was done, and this was used as temporary denture. Lower was done first. The reason why I do lower first is that setting occlusal dimension and tooth length, we can see it very intuitively, and the overall occlusal table and incisal table can be seen, and you can see it visually very easily. There can be slight deviations, though. Second, following that, the implants in the upper were placed. Flapless implant placement was done. 7 implants were used, and the temporary abutments were connected using resin. cross arch splinting was done. At the time the patient came to the dental clinic, soon there was to be his daughter's marriage. The patient wanted to take part in the wedding with teeth. So in the end, the patient had his restorations when he participated in the wedding. He had to make various visits, but he was able to get his function and aesthetics back ultimately using these provisionals. As for final restoration, 12 units were used, and the entire arch was not done at the same time. I tend to segment, and I did the lower 6 anteriors first, and then restored the posterior teeth, and then the upper anterior and lower posterior. The order itself is not very important, but for convenience, you can use a familiar way that is familiar to you. So follow-up is done every 6 months or 1 year to check the integrity between prostheses. After 5 years, it is nicely maintained. In the case of these patients, the overall process, conventional technique were used, and I want to look at the 5 different steps deeper. As is the title, I really think diagnostic phase is important. In diagnostic phase, when the patient comes in, what the patient finds most curious is how much the treatment is going to cost and how painful it's going to be and how long it's going to take. From surgeon's perspective, it's quite different. How to proceed the treatment smoothly and what kind of final prosthesis that is going to be delivered. First, you need to determine the number of implant and prosthesis form, as Dr. Oh has mentioned, placing few implants to provide fixed denture type of restoration, or to place more implants and then provide a segmented bridge type of restoration. You need to deliberate on that. For the patient, the difference between the two are not really clear. As shown earlier, full denture concept was used for implant restoration for edentulous patients. This is very useful, just like making complete denture. Vertical dimension is checked and a jaw relation record is taken, just like complete denture. Diagnostic model is mounted and trial denture is fabricated. You can make a flange denture or flangeless denture. The ultimate goal, if you think the ultimate prosthesis is not going to have a flange, then you can make a flangeless denture so that it resembles the final restoration. Depending on whether there is a flange or not, lip support can change. In full edentulous cases, vertical dimension is determined here. When we use implants, there are steps where we can make adjustments because fixed provisionals can be provided. Now, let's look at occlusion. The non-existent occlusion needs to be formed. OVD needs to be formed. The patient is in her 80s, very old. As a dentist, you'd be able to see that there's vertical dimension issue. And when you look at the patient's profile, the mouth corner is folded and it looks tense. And the mentum looks tense. The patient is very gentle, but she looks very angry. New wax denture was fabricated. Vertical dimension was increased by 10 millimeters. And I've just changed to wax denture, but you can see that there's relaxation of the muscle around the mouth and the patient looks much nicer. Vertical dimension, if you increase it significantly, then for complete denture, position can be an issue. In the lower, the patient received the 4 implants and fixed prosthesis was going to be provided. So I increased the VD more. And a new wax denture height, when you compare old and new, you can see that vertical dimension has increased significantly. In the lower, 4 implants have been placed and prefabricated trial denture was replicated and it was adjusted, and on the day all-on-4 type of restoration was provided for the upper. Complete denture was connected. This is a 3-year follow-up image, and now it's been about 6 years, and the patient continues to use it nicely without a problem, and the patient was really happy. Koreans are not really vocal about how satisfied they are, but the patient was really happy about it, and she uses it without a problem. For the rest of her life, I think the restoration will function. In diagnostic phase, vertical dimension evaluation needs to be done, and the various conventional ways can be taken to do that. Based on my experience, these are not of huge help though. Previous records, patient's phonetics, resting position, it is very difficult to evaluate them chair side, so I tend to rely on my intuition. This is very conventional way, and you need to go through a lot of trial and error in order to come up with good result. In terms of vertical dimension, the surgeon needs to make the decision. And if you're an experienced dentist, when you look at the patient's profile, you need to make sure that the patient is relaxed, and you talk to the patient so that the patient relaxes. The patient would answer, and when she or he responds, you need to look at how the lip moves. The lips, the upper and lower lips, should be in slight contact, and mouth corner should not be covered, and vermilion border should be exposed. The pink, the volume of the lips need to be considered as well. When you ask or communicate with a patient, you need to see whether the upper teeth is showing. The upper teeth exposure is important so that it doesn't really look like a denture. When I evaluate vertical dimension, I tend to use my instincts. But this cannot be delivered in an objective manner, and this is quite a disadvantage. And in order to reach this point, you need to spend some time. When measuring vertical dimension, there is also another disadvantage, and no consensus has been made in the lower hinge movement when the mouth closes and opens. Depending on where you measure vertical dimension, there's a historical gap in edentulous patient or close to edentulous patients. There are very little references that you can utilize, and once extraction is done, there's no reference. The patient's remaining reference points need to be used as much as possible. If there's reference in the posterior area, you need to utilize it. If there's no teeth, you need to measure using profile or use the articulator. Measuring soft tissue, the downside of it is that as the lower opens and closes, the nasal activity is not relevant, and the opening and closing, and the movement is much less than the movement of the teeth when the mouth opens and closes. This is a different patient, and the patient was using existing denture, and this is going to be converted to fixed prosthesis. A surgical guide and trial denture is tried in, And as was with the previous patient, when placement was done, this was used as surgical guide. The end result is implant is just a mean, and we need to provide teeth and restore masticatory function. The extensive restorations can be divided into, as shown, a partial edentulism patients. So we need to correct and stabilize occlusion, or there's a case where we need to remove a few remaining teeth and improve or form new occlusion, or we need to form a completely new occlusion for a edentulous patient. What is important is that regardless of the method that you use, it is very difficult to find the right occlusion for the patient at once. Providing fixed or provisional restoration needs to be done. Multiple adjustments need to be made, and once the patient is satisfied, then it can be replicated to final restoration. Next is surgical phase, and I'm a prosthodontist, but I do surgery. But I'm just going to address the surgical part briefly. I use computer-guided surgery. Normally, I tend to use the analog ways, because more so than just following the set path, I do not really like being limited. I tend to do it more freely. It's just a way of speech, and you'll be able to respond to different clinical situations more easily if you do that. The analog way was used, surgical guide was used. What is important here is that the implant buccal lingual position is determined by the bone width, and mesiodistal position is important. If it is satisfied, then the implant position is determined. Primary stability needs to be gained, and the provisional is provided. When you do computer-guided surgery, flapless guide placement can be considered a huge advantage, but whether or not flap is opened is just a supplementary factor. Bone profile on CT, you can see it, so you do not need to open flap, but computer-guided surgeries, the goal is not to do computer-guided surgery. The ultimate goal should be to place the implant in an ideal position. When you do guided surgery, in unfavorable conditions, I tend to open flap. In the posterior areas, 6 implants were placed and immediate restoration was provided. The anterior area needs extraction, but staged approach was chosen. The anterior area were used as reference for occlusion, and implant restorations were provided for the anterior area as well. Next is provisional phase. This is very important stage as we progress to final restoration. Function and aesthetics can be restored very quickly. You can, when you restore on the day or a few days later, there are a few ways to provide the temporary provisional. If it is not extensive, you can use stock abutment and use a temporary shell and do relining. Second, you can use a temporary abutment when you cannot use a stock abutment, and also attach resin temporary that has been prefabricated can be attached using resin. This is not really recommendable because it's going to take a lot of time chairside, and it's quite unfeasible in many cases. So if possible, rather than doing it on the same day, you need to take impression and do it a couple days later. If you do it within 1 week, it can be considered immediate loading. You can take impression, implant level, and fabricate it at the lab. Sending it to the lab for you, then the burden on the part of the surgeon can be reduced. If the placement position is favorable, you can use stock abutment and take impression. And the period up to custom abutment delivery can be reduced. If you do computer-guided surgery, prefabricated abutment and provisional restoration can be provided. You can provide it on the day. This is a similar case. 7 implants were placed and flangeless temporary provisional was provided. 7 implants were placed, but implant placed in the posterior area, primary stability was weak, so this was not used for provisional restoration, and 5 implants, only up to the second molar restoration was provided. And I've talked about how trial and error occurred as you find occlusion, and these provisionals serve a great role during the healing phase. Final provisional restorations are not failed, and they need to withstand at least 2 or 3 months of time. CAD-CAM was used, guided surgery was used here, and the span was quite extensive. In the case of immediate restoration for anterior area, you need to reinforce using wire, or else, as it functions, the provisional restorations can fail or fracture, leading to early failure of the implant. You need to reinforce a wire or use frame. Next, I'm going to talk about literature that compares the conventional and digital technologies. Computer-guided surgery or digital technology, if you use them, surgical time and prosthodontic time is reduced. However, below the scene, significant time and effort needs to be invested, and such effort, dentist effort as well as lab technicians' effort is required. The time that we spend can be reduced significantly. In 2021, EAO consensus report says that the more time and effort is spent in diagnostic and treatment planning phase when you use digital technology. If you consider surgical time alone, then the time spent using digital method is absolutely less. But in the overall process, it is difficult to say which is better. When we use digital technology, we need to look at the overall process, and other staff can help. So effort and time and effort on the part of dentist can be reduced significantly. And now moving on to the final restoration. There are analog ways you can take impression directly and pour model. Wax pattern can be formed, or cast can be done to provide final restoration. This is pure digital method. Model is not made. You just take a digital impression and provide the final restoration. You realize everything within oral cavity. I tried to intermix the 2 different ways. What I use is, rather than using digital scans, I prefer conventional impression, and I digitalize the lab process. The gypsum dye is scanned, and then CAD pattern is used, and it is tried in. I've talked about occlusion in the case of edentulous patients or with patients with little occlusion. In order to restore function and aesthetics, that you need to go through many trial and error phase. Good occlusion cannot be achieved at once, so you need to divide into different steps. You need to provide first provisional and second provisional, and then the final restoration is made replicating the provisional. You can use a scan and merging to provide a restoration, and the provisional restoration for immediate loading. If it is all right for the patient, I connect it to cast dye, and I use it for bite support. This main model is mounting, and custom abutment and second provisional is fabricated. the areas that were lacking in the first provisional are compensated for, and the provisional restoration is tried in and connected, and second provisional have been delivered. Impression for the final prosthesis, the conventional impression is taken. Occlusion and form of second provisional in order to translate it into final restoration. Cast mounting is used, bite record is used, impression is taken, or scanning is done to fabricate the final prosthesis. It's not exactly the same, but through time and error, the patient's oral cavity and or occlusion is restored. But still, occlusal adjustment may be necessary. This is after osseointegration and final restoration was delivered. Next is maintenance phase. As for this patient, this was a previously shared case. It's been 5 years post-op and the implants are functioning. Edentulous patients or close to edentulous patients, when we provide the implant, their systemic health has improved and they feel very happy about their restoration. And as a dentist, that makes you really happy and it's really fulfilling. I want to summarize, and I've talked about different advantages of conventional way. If you think about it, the surgical process, if it is complicated, then conventional way may have more advantages. Also, if alveolar ridge resorption is very severe in the lower, there can be issues with adapting surgical guide. Therefore, you just use it as reference, and doing freehand surgery may be better in certain cases. Occlusion-wise, if there's need for big occlusal change, analog knowledge may be more necessary, and in the case of complicated prosthodontic case, then conventional way may come in handy. To summarize, restoring edentulous patient, regardless of the way we choose, you need to utilize different advantages of different methods in order to benefit the patient. The dentist needs to understand fully about conventional and digital ways and need to select the different methods selectively. Rather than relying heavily on certain method or tool, you need to improve your know-how and clinical experience. Thank you for listening. Dr. Park, thank you for the wonderful lecture. Your lecture is really brilliant whenever I listen. The Q&A session will take place after Dr. Park's lecture. Thank you. Please give a warm round of applause.
In real time, questions are being received, and during Q&A session, we will open the floor for questions as you saw in the previous session. Please remember that, and we will have a Q&A session after the next presentation. Dr. Bae, are you ready? From Seoul Gangnam Dental Office, we have Dr. Jeong-In. So he's going to talk about digital perspective. Dr. Bae is performing almost everything in a digital way. So I think he has prepared a lot for the digital approach. and how to approach the cases done by the previous speaker in a digital way. Please welcome him with a big hand. Good morning. My name is Dr. Jeong-In. Thank you very much for inviting me to this Osstem meeting, and it is my honor to be able to be with Dr. Hwee-Woong Park and Chan-Jin Park. Digital is my title, but this is my title because I pursue rational treatment. So input, process, output is the process of all computer. Digital dentistry is the same. Data is acquired and processed, generating the output. Acquisition, process, and the output. CAD/CAM has the process of scanning, designing, and manufacturing. And analog dentistry has the same logic, but in the digital world, the physical limitations is disappearing, so clinical access has become better. Patient data is acquired, and prosthetic designing and manufacturing has become easy. So frequent scanning can be done with CAD. The prosthesis can be simulated, and provisional can be tried in, and feedback can be obtained. There's no physical limitations. Data can be collected and merged. It is easy to merge the data like big data. With the accumulation of data, new information can emerge and can be utilized in the treatment planning and treatment. So the layering is the information accumulation. Land registration map shows the attributes of road, railway, gas line. And you can view them by road, railway, gas line, and by time. And the CAD, it is the same. Not only scan, CT, facial scan, and motions can also be used. The motion is rather limited at this point. So digital has these advantages. So prosthesis simulation, try-in, and feedback can utilize the digital dentistry, and accumulated information can be utilized. Especially this is a foundation for very complicated case like Edentulous case. Difficulties of treating Edentulous patients. There's nothing in the mouth. There's no reference for teeth arrangement, and there's no reference for implant positions. So intraoral, extraoral measurement points are referenced, and jaw relation is set, and wax trim is used to arrange teeth. And if there is a satisfactory old denture, it can become a good reference. If such full denture is absent, we need to determine the positions of placement in the operation theater, but it is not easy if the teeth and alveolar ridge is displayed quite severely. So it is very important to check the arrangement in the oral situation to make a new denture and to use it for treatment purpose. And in the analog way, the denture can be copied using putty and gypsum, a radiographic or surgical stent. It can be fabricated. This is early guided surgery. And as Dr. Park showed, the stent cannot be used for completed placement, but used to get the drilling point. And the denture is copied, scanned, and the file is obtained, and the surgical guide is designed. And the data include the CT, upper and lower gingiva, and the denture scan. Edentulous arch has no bite, so the positions are all over the place. And then in the analog way, we can just mount, but in the digital way, we need to get the 3 common points to get the alignment, which is the positioning in the real world, and it is called aligning in the virtual world. So the form digital data need to be positioned. When you superimpose a land registration map, each coordinates should be aligned. In complete Edentulous arch, 5 scans need to be there. Bite and dentures need to be aligned with the 3 points on teeth. The denture, tissue, face, and gingiva should be aligned using the 3 points. So it sounds very difficult, but once you understand it, you can utilize the digital data to use the denture as digital reference. The denture and gingiva need to be scanned, and they need to be aligned. And using those 5 scans, edentulous patient can be treated. CTs need to be aligned, and if there are teeth, the alignment can be done. But edentulous patient is not possible, so we need to use markers. GP stopper and resin are used as markers, and the wax rim and others would have the markers. And then dentures, the wax rim with the markers would be mounted, and CTs would be scanned. And GP cone can be bonded, or a small implant can be placed to be used as markers. So like this, scans are aligned, and they should be merged with the CT. So they would look like this. Up to surgical stage, a treatment plan means surgical. It can serve as surgical guide design, and necessary data should be acquired timely, and they need to be aligned. And that is very important when it comes to digital dentistry, which is the advantage of the dentistry, and it is almost impossible to do it in an analog way. Lastly, the surgical guide would be fabricated, but in Edentulous arch, it is not possible to accurately position the guide. So dual scan protocol is used. The reference denture is copied with the resin, and the patient is sitting with the denture, and the denture alone is scanned, the dual scan. This stemmed from Nobel Guide. A scanner is not used. The denture CT thresholding is used to use it as a scan. In this protocol, special guides need to be fabricated, especially the 2-piece guides. The surgical guide and denture occlusal surface appliance are connected, and they are tried in, and the positioning is obtained using the tightly bitten denture. And the dentures are placed. The bite appliance is used as a positioning reference, and the guide is fixed when anchors are placed. A good idea, but intraoral feeding and bite may have errors. The causes of the errors, it is from CT, not from scan. So the device itself may have errors, and depending on the scanning condition, errors can occur. So depending on the remaining teeth, the occlusal forces can distort the guide, and jaw relation can be inaccurate. So it is questionable whether we use a patient's bite as the reference. Another important problem during drilling, the guide can be mobile, and anchor is recommended to be used, but anchor placement itself can displace the guide. If you look at this case, a bite appliance is used, and implants were actually planned at the center of this ridge, but it is lingually pushed, and there was the bleeding. A bite appliance was used for positioning. Guide positioning and fixation, depending on the ridge form, there's a big problem when it is flat or mobile. If you look at the CT, the mispositioned of the guide was not recognized, and the surgery can result in a fatal mistake, and you'd better not to use the guide at all. In such cases, as you saw before in the virtual world, the alignment is equivalent to positioning with hand in the real world. The fabricated guide is delivery. The fabricated guide is delivered. So in order to overcome the positioning problem, I use small implants at the beginning of the treatment. So we can have a consistent positioning of wax rim, diagnostic denture, and surgical guide. And mini implants are used. And I use this kind of implant. I prefer that. Remaining teeth can be used as surgical guide positioning, and they can be extracted after placement. And the reference implants are placed in bone, so they are absolute reference, a consistent positioning for wax rim, denture, and surgical guide. And surgical guide positioning and anchoring displacement can be prevented using this. It can be a very good matching point. Then positioning in the real world and aligning in the virtual world, and their connection can be achieved with a reference implant. It's a very good tool, but there are disadvantages. Poor ridge shape. In poor ridge shape, it should be used selectively. Treatment planning at the beginning of the procedure is to make implant placement planning, and ultimately surgical guide should be designed. So treatment planning in the Edentulous arch, the number 1 teeth reference is missing, so digital analog cannot resolve the problem fundamentally. Number 2 and 3, digital guide needs to be used, and problems can occur. So the reference implants number 1, 2, 3 would be helpful in solving problems. So the guide system which can address these 3 can facilitate accurate positioning of implants. So then that is all done before operation. So based on the planning, overall workflow of implant treatment for edentulous jaw. So a workflow. And first, I use 2 trios, and the model scanner and the facial scanner. I do not really use model scanner. CAD software is a dental system complete of 3 shape and the implant studio, and 3D printers and the dry milling machines that I use. And if you look at the lab work, in the full mouth planning stage, a 3D printer and the milling machines, compared to those, this can play a bigger role. If you have a scanner and printer, you can do what I usually do. The software is important too. Overall workflow is based on these 8 steps. As Dr. Park suggested, this is consistent with the 5-step process. The prosthetic process and the difficulties, how can they be interpreted and implemented digitally? In step 1, the reference should be made when there's no old denture, and a lot of implants will be placed in a breach, and a breach will be used. Initial scan should be obtained. There's no bite, so it is not possible to align upper and lower jaws. So recording base and wax rim can be fabricated. Wax rim is tried in, and then gingiva scanning and alignment. The wax rim needs to be realigned, and facial scan can be done. If a facial scan is used, 3 points need to be aligned with the markers on the wax rim, or residual teeth should exist, and it can be mounted on an articulator, or, as I said before, scan data can also can be used only for alignment. Facial scan can be aligned with intraoral scan, and 3 points of the markers are used as the basis. The facial scan years ago used the iPhone, iPad, or industrial handheld scanners, and now we have dedicated software for dental use. Mounting and arrangement is done, and we need to confirm the treatment plan, whether bridge type prosthesis can be used or lip support gingiva should be included in the prosthesis. Wax trim is the basic. Using facial scan, campus line, midline can be adjusted. Facial scan, not only for full mouth, but anterior, posterior can utilize the facial scan. And the arrangement is printed out and put in the mouth. So our views are not very objective, therefore various photos need to be taken, and the video should be taken in communicating with the patient. So the patient has a large displacement of alveolar bone, and we need to do arrangement, alignment multiple times. When alignment is satisfactory, and to align scans, so relining is necessary. After the first stage, the second stage is guided design. Dental reference is there, and it is copied, scanned, and trios can be used for denture copy, and 5 scan match need to be secured. And 3-point matching is done between the scans, the bite, and denture based on teeth, and reference implants can be used for matching. So the denture bite is captured in the oral environment, and the scans are brought in to the guide program, and they are aligned with the CT. Reference implants are used for the matching. The data is used to position implants and the anchors, and guide stand is fabricated after guide design. Just scan with implant info file is generated to fabricate a pre-surgical prosthesis. After the guide design, surgical stage, the guide is positioned accurately with the reference implants. After anchor placement, they can create some displacement. Not only the basic anchor, bone anchor, implant anchors can be used. If implants, like here, if reference implant position overlaps with the real implant, that implant should be placed at the last stage after removing the reference implant. So if they coincide in position, if the flap should be opened in that area, the rest of the implants should be placed first to place implants with the anchor implants. If you trust the guide too much, and if you proceed too fast, heat can be generated. And the tool can be caught in the guide, and that can create a confusion. So when the guide or drill is pushed, and if the surrounding bone density is not consistent, the implants can be displaced. So not path-sensitive one, but cementation type where relining can be accommodated. So cementation type needs to be used. So I don't do pre-prosthetics. Step 4, immediate provisional scanning. All implants need to be made into splinting screw type, and external type is preferred. Multi-unit abutments and scan bodies are connected, and the reference implants still remain here. The reference implants are included in the scan when we scan upper and lower jaws. right after surgery, scan cannot work perfectly, so the bite material can be used to do the scanning. Right now, the bite cannot be taken. In the past, the denture was cut to take bites. It is not a very sophisticated way. After the scanning, reference implants are removed. Scanning has been done and the lab work is fabricated. Bite scan was not taken. Existing wax rim denture guided design utilized the scans and they are aligned. So on the right hand side, this is scan right after surgery. So 3-point matching can be made. If anchor implants remain, they can be used for matching. And the ruge is used for matching as a reference was removed. So you don't need to cut denture to scan bites. This is similar to cross-mounting of a classical prosthesis. If you get used to it, the design may take 30 to 40 minutes, and the output printout is just 30 to 40 minutes. And it is delivered on the next day, and resin, it is one piece. And they fit very well, but you need to take photos from various angles, and occlusal adjustment should be provided, and loose screw and abutments need to be checked, and occlusal force gauge is quite useful for adjusting the full mouth. After 2 to 3 months, final prosthesis, the transitional prosthesis is the provisional that will lead to the final. ISQ is checked, and multi-unit abutments. Multi-unit abutments is a desirable form of the temporary. And the temporary prosthesis is segmented into 2 areas, anterior and posterior. And various feedback should be reflected to fabricated transitional prosthesis. The temporary is superimposed, and the photos are taken from various angles, and video is taken. On transitional prosthesis, if a patient and surgeon is satisfied with that, final prosthesis, multi-unit abutments is mounted. For final prosthesis, I usually use general custom abutments, but multi-unit abutments can be used as final. But then prosthesis can be simplified, and that is what I look forward to in the future. Skin bodies are connected and scanned, and the bite is using the transitional prosthesis. And the final abutments are fabricated, and the provisional temporary prosthesis is made on top of it. And abutments are separately scanned to use it later, or the abutments, the original STL file needs to be kept. This is the early work. So abutment design was something like this, and abutments and temporary are delivered. So the patient adjust to it and give us feedback, and screw is retightened 2 to 3 more times over 2 to 4 weeks, and abutment level scanning is done. I do anterior region first, followed by posterior in scanning. So in early treatment phase, data needs to be collected to minimize uncertainty. In the final prosthesis stage, we need to make the range smaller for better handling. So the abutment level scanning, the margin may not appear very well, but if you can use the scanned abutment, you can put it in. It is called a double scan, so it will result in more clear abutment margin. So temporaries can be superimposed and the anterior final prosthesis delivered. The patient wanted a gingiva at first, but it was considered very uncomfortable, so we made it like this. In the same way, the posterior scanning was done in double scanning. With the double scanning, final zirconia bridge was fabricated and delivered. So here there's a slight gap, but recall check by adjusting the occlusion, and all the steps are over. 8-step process. It looks complicated, but I explained it very well, so you understand it, right? Before the final prosthesis, the transitional prosthesis can be printed. Very easy, isn't it? So after presentation like this, people ask how long does it take before surgery, and it usually takes 1 to 2 weeks, including diagnosis. And the master, who is very good at the surgery, says it takes 0 minutes for preparation. So that would be our ultimate goal. Using the digital help, we can make the insight to be realized. It's Dr. Yong-Seok. Picasso could draw 80 million won worth of a picture in 5 minutes because he took 40 years of training to do that. So the same can be applied to digital. With the digital, clinical accessibility has improved, so prosthetic principles can be understood better. It looks complex, but I will explain it further in Osstem OIC and 3-shape superclass. So this is a video. Full mouth patient comes in. I welcome them because I love the case. So I hope you would enjoy the case. This concludes my presentation. Thank you for your attention.
Thank you, Dr. Bae, for the wonderful lecture. The process looks very complicated, but you've organized it very nicely. You need to have interest in it to really understand it. Thank you for your hard effort. And Dr. Park is also here with us. And now we will begin the Q&A session. Among the questions, there are so many questions. There was a question that applies to both of you. It applies to provisional. There are many questions regarding provisionals. Dr. Park, when you move on to final restoration, including occlusion and contour, you said replication. And in the middle, the clinical procedure and lab procedure you've done cross-mounting. In the process, how do you transition that to final restoration? First, when the patient is near edentulous or edentulous, I prefer immediate restoration. The prosthesis made on the day, after osseointegration, this is adjusted. You adjust occlusion and contour, and you remove the prosthesis, and implant level impression is taken. After a few days, once model is complete, you have the patient come in again. And in patient's oral cavity, the provisional prosthesis wash bite is taken. You remove it and the model mounting is done. Implant level mounting model is mounted and the primary prosthesis is adapted to that. The impression is taken to replicate it, or abutment level, you do digital process. Scanning is done. It's a type of double scan and you reference it. And second, provisional and custom abutments are fabricated. Once this is provided to the patient, I tend to segment the prosthesis. With posterior prosthesis, I restore the anterior region, and like a stepping stone, I do the treatment as shown. When you need to split the prosthesis, the main model, implant level impression is taken, and the model is made ahead. Analog way is used, the die is made, and you wash the temporary provisional and the stone model abutment is connected. And second, temporary restoration is provided to the patient. You need to make final restoration with the mounting. Scan with the temporary scanning is done. And this is used for contour of the prosthesis. There are many questions related to the topic. I think you've addressed it. The procedure that you have is that, and in the end, the patient, if immediate treatment has been provided, regardless of whether it's stuck or temporary, and then you make use CAD-CAM to fabricate abutment again. Yes, it differs from patient. In the case of lower stuck abutment is not adjusted in a lot of cases. In that case, abutment is not replaced, and from the first provisional, I move on to final prosthesis. If customization is required, then mounting is required twice, and it may, in the same patient, there are mixed cases. In terms of contour, this was addressed slightly. This is a replicated, you adjust it, and using the replication of temporary, this is utilized. Dr. Pei, would you like to add on this? This was addressed in your topic, so can you add? Abutment of CAD-CAM, you said you have the patient wear it for 2 weeks, and because implant is internal type, because of sinking down, the tightening is done again, you said. And in that context, the patient's CAD-CAM abutment, when you take impression, the margin becomes an issue, and you have mentioned that you do double scan. And with the original data, because you know the contour, you said that contour can be adjusted. Will this lead to inaccuracies in internal type when you tighten it because of occlusal force and the amount of adaptation? Three-dimensionally, there are changes, and I think there may be deviations. Three-dimensionally, how can it be saved? Is that the cement compensated with cemented space based on your experience? So will this be an issue?
Okay, I forgot the question while listening to you. The abutment alignment, you mean the change of abutment form? The exterior form is determined. When the file is brought in, the CAD-CAM margin is clear. But as you showed before, in the procedure, you use internal implants, and temporary is sinking, and that is tightened again. So there is a change in the three-dimensional space. I understand the question. So you may think it's funny that I mentioned about the sinking down. when I say scanning, the abutment is scanned, not the oral environment where the abutment is scanned. The abutment, after it is positioned in the oral environment, the abutment level scan would be the basis for the positioning of the abutments. Dr. Bae, you talked about markers. What are the recommended number of markers and positions in the upper and lower jaws? And there can be many different approaches. GP cone stopper is used in endo treatment. So in the palatal, in the upper jaw, and 4 or 5 markers are used. Sometimes some of them fall off, and during CT scanning, some can fall off. So 3 points is the standard, but 4 or 5 can be used. And in the mandible, we can 4 or 5 markers. So that's for your reference. Dr. Park?
In terms of 3D, there are a couple of questions. Is there a tip as to do it easily? You've talked about evaluation. There are many factors, and some find it quite difficult. Is there a know-how on this end? I've mentioned it in the lecture. Providing objective numbers, it's quite difficult. I do it intuitively. Corner of the mouth, I see whether this is covered, if there's a fold, if there is inflammation. When we need to look at the patient condition, and we intuitively understand VD. If there's a lot of attrition or collapse, deep bite, then VD needs to be increased. If the lips, when you try in temporary denture or other device, if the lip volume increases, in the case of Edentulous and VD is low, the lip looks very thin. Then the person looks weak and unhealthy and very weak. By increasing VD and protruding teeth, the pink of the upper lip becomes more visible, and it becomes more voluminous and more alive. So I've talked about visual inspection. Mouth corner and lips can be referenced. This is quite intuitive and subjective, so you need to garner more experience as you treat more patients. Understood.
Dr. Bae, ultimately, when you position the stent for the guided surgery, you prefer the temporary implants, and that's what you said during the lecture. And if you do not use the temporary implants, in order to do accurate positioning, what did you do? If you don't use the temporary implants, the stent positioning, what technique do you use? If the reach is good, the adaptation doesn't make any difference, and implanted displacement, slight displacement would not matter. But in the past, I did not use two-piece guide. I used hand and tried to apply even pressure, but there was some limitation to that. Dual scan protocol, two-piece guide actually looks very good, and it looks fitting very well in extraorally, but intraorally, it is not always so. Despite that, some errors cannot be avoidable. So I strongly recommend the approach that I introduced. And let's open the floor for questions. Please raise your hand if you have questions. No? Professor Kim? I am a panel. That's why I'm asking questions. My name is Myung-Rae Kim. I'm an oral surgeon. The two lecturers gave us very good lecture. Dr. Park is using analog and digital, and you use a model. And Dr. Bae is doing all the work using computer, using the reference implants. Is that right? Yes. So how much help do you get from the lab technician? Do you do all the lab work yourself? In the diagnostic step, I do myself to arrange the teeth and print out, and post-treatment is left to the lab technician. And the final prosthesis, the final abutment and prosthesis is designed by the lab, and I check the result.
It's similar for me. I make a model, and that is the only difference. When I prepare for surgery, I fabricate model and make recording base. And when I take a job relation, the lab technician does mounting, and the teeth alignment is done with CAD, and I adjust the position. I make the order. Once it is milled, regarding post-processing or adjusting on the model, I do it myself. The process is not really complicated. Digital dentistry, the reason why we are using it, the lab technicians, they may do a good job, but when they take a break or step away from a moment, this becomes a dilemma. I'm sure you have experience, but when the lab technician, there needs to be a team rather than one person. It needs to be more than two. I have one lab technician. Then you need to hold on to that person. I've been working with lab technician for 7-8 years, but that person has moved, so I struggled a little bit. Yes, I understand that there can be such issues. We're not able to do everything. The lab process is very specific and specialized, and there are areas where dentists cannot really dabble on it. I need to receive a lot of help from my staff, and my reliance is increasing in dental clinic. If you have a lab technician but in order to run it more stably, perhaps you need to co-work with a good lab. And if you have a great working relationship, that'll be great. I was just curious, and I wanted to open up, encourage others to raise questions. I also have one lab technician. So this person did not do lab technician work, but I've learned the digital dentistry on myself. So I taught to the staff, so the staff is working on it. Digital dentistry equipments are being bought, and people try to use digital dentistry, but you need to take the easy road. Custom abutment crown can be made within dental clinic, and if you have a little bit of know-how, you can fabricate it. If you're able to do it, even when lab technician is absent, you'll be able to handle much of the work. Thank you for great advice. Thank you for the realistic questions, and I can really relate to the answers as well. Are there any more questions?
My name is Chang. I'm with Osstem and Dr. Park.
In full denture case, the analog way. So this is an area that I'm interested in. Sample. Among different cases, a teeth alignment was done only up to first molar in one of the cases. When fabricating full denture, aligning up to second molar and aligning up to first molar, there are different circumstances. So when you treat open bite, such issues can occur. So I've always been curious about this. And how can I check a vertical dimension? In Edentulous area, when we restore a tooth, we need to find the vertical dimension for that individual, and a occlusal plane needs to be formed. In that sense, second molar, third molar in that area, how do you do tooth alignment? That I think that is a challenge, and this has been overlooked by dentists, but I think this needs to be paid attention to. When I looked at tooth alignment, why didn't you do up to the second molar and did up to first molar? In which cases do you do that? That is my question. Professor Zhang, that's a very sharp question. In edentulous cases, theoretically, in one arch, there's 14 teeth, and once this is extracted, I tend to place about 7 to 8 implants in bridge form. Up to the second molar, placement can be done, but extraction socket and alveolar ridge, because of rapid resorption, arch length is resorbed. Alignment up to second molar, it can be very difficult, or implant can be positioned too distally, and there can be many challenges in terms of surgery, prosthodontic phase, and maintenance. Restoring first molar, up to first molar, there will be more masticatory efficiency, but in the case of older patients in their 60s and 70s, arch length, if it is insufficient, then I skip second molar and I just use 12 units of teeth. Depending on patient, some may find it odd, and but in most cases, people are happy. In my case, the skeletal imbalance, open bite form. In the case of patients with such environment, the most distal tooth, by reducing the distal tooth, the occlusal plane can be adjusted. In that sense, the skeletal imbalance, we need to look at whether it is a deep bite imbalance or open bite problem. In the case of patient with long face, open bite tendencies are prevalent. In that case, the most distal tooth number, perhaps you can reduce it, and you need to adjust the occlusion. In full denture, do you also consider that? Regarding orthodontic sphere, I have very shallow knowledge, and I was quite caught off guard. So in the case of restoring a fully edentulous case, teeth are all extracted, and the patient's occlusion or skeletal situation is difficult to determine, and I didn't really think about that, so I'll pay attention to that area and study further. Thank you. Thank you, Professor. Because of time constraint, we will end the Q&A session. I will now close the second session, and I would like to express gratitude. Please give the two speakers a warm round of applause. Thank you. I will close the second session. Thank you.
네, 자작 마지막으로 수고해 주신 박찬진 병원장님께 다시 한번 큰
Big
박수
hand
부탁드립니다.
to the moderator, Dr. Chang-Joo Park.
네, 그럼 지금부터는 많은 분들이 기다리셨던
Now
로그인
it's
시청 이벤트를 진행해
the
보도록 하겠습니다.
login
이번에는요, 300분께는
event.
커피 쿠폰을
300 people will get coffee coupon and 200 people will get sweet dessert. Let's choose the winners of the lucky draw.
네, 당첨되신 분들 모두 축하드립니다.
Winners, congratulations. Then outside the bulletin board can be used to check the details, and coffee coupons will be sent as text messages. In the afternoon, we'll have discussion session. Those who are here, please use the QR code on this screen, and at the entrance, please join the survey. If you participate, we'll appreciate that very much. Another event after lunch, from 12:40, in front of the auditorium, we will give you numbers, and 10 people will receive one guided system book. Dr. Ki-Sung Kim will hand out the gifts. So we'll have lunch until 1 p.m. Enjoy your lunch and look around the building. The practice exhibition, which was held yesterday, will be shown, and the complication lecture and lectures for hygienists and lab technicians will go in parallel on the third floor. Please participate in those lectures as well. I'll see you in the afternoon. Thank you.
Introducing Scan Body. The Scan Body is a simple and easy way to take digital impressions of implants. Thanks to the dedicated carrier, the Scan Body helps you assemble implants more accurately and conveniently. The coated surface reduces reflections, so the clinicians can scan quickly without spraying any additional substances. You can fabricate implant prostheses with great accuracy using the high precise ready-made abutments and a custom abutment library. Use the Scan Body for an easy and accurate implant impression taking experience. Introducing the Digital Lab Analogue offers 3 advantages when you're creating a digital working model. First, you can place the dedicated positioning jig in its correct position with great precision and in line with the direction of the hex. Secondly, the triangular-shaped holding component at the bottom, along with the screw, prevents unwanted rotation while fabricating the prosthesis. Third, easy removal of a lab analog from the model without any damage is to unfasten the screw. The digital lab analog creates an error-free digital prosthesis. Introducing a link abutment is used for aesthetic restorations placed in an interior region. The crown component of a link abutment is made using zirconia, which helps produce a natural-looking crown shade and obtains the appropriate cervical color. Even when you're placing a prosthesis in the anterior region where space is narrow, using an open-type base can help fabricate the implant without removing any structure. The link abutment lineup features products that can facilitate different heights and gingival thickness requirements. Clinicians can select the right product for specific placement conditions and the patient's intraoral environment. Try the link abutment when placing aesthetic implants in the anterior region. Introducing the MS Kit. The MS Kit is designed exclusively for MS implants. The MS Kit is designed exclusively for MS implants, which are used in areas where the bone is narrow, such as the anterior mandibular region. With the MS Kit, you can place an MS narrow ridge, MS denture, or MS provisional implant with a quick and simple procedure. Try using the MS Kit when placing an MS implant. Introducing the Scan Healing Abutment, which helps you to take implant impressions without removing the healing abutment. You can use the dedicated carrier to fasten the Scan Healing Abutment in the correct hex direction more conveniently. The Scan Healing Abutment is available in different lengths. You can choose the right abutment for each patient's implant surgery case. When using a CAD program, the unique shape of its upper surface helps you identify the abutment's length. You can also create custom abutments. Edentulous case. Using a multi-scan body, the surgeon can select from a dedicated library to 2 digital scanning options, TI base, long or short. To ensure a proper fit and eliminate any possible errors, the prosthesis must be seated in the mouth before being cemented onto the TI base. Try our simple and accurate TS Multi-TI base. Introducing Magic Align, a digital clear aligner. Using less than 20-step aligners. And maximum 4 mm of space case can be corrected within about 5 months using less than 10-step aligners. Line is trimmed based on the patient's unique gingival line without covering the gums, so the patient can put on easily and accurately at once. Magic Align provides diagnostic analysis files and 3D setup simulations to help establish accurate treatment plans. In addition, orthodontic treatment can be carried out according to the initial treatment plan by applying the Magic Setup system that checks and supplements the teeth movement every 12 weeks. Start orthodontic treatment with Magic Align that can correct various orthodontic cases accurately and conveniently. 커피 쿠폰과 디저트 세트 쿠폰을 드리는데요. 매 세션이 시작되기 전에 대놀 사이트에서
On the dental site, for 3 minutes, you'll be able to see the pop-up screen. Please click on it. Those on site, you can participate using your cell phone. Go to the dental site and try your chances. If you're participating with your mobile phone, you need to set your mobile phone on vertical orientation. The pop-up screen is displayed on dental site, and you'll be able to win your chances at getting coffee coupons and bakery goods. The winners will be announced after each session, and texts will be sent. Finally, those of you staying with us until the end online, Galaxy S23, Galaxy Watch Pro, Osstem Mobile Cart can be won, so I hope you stay tuned. There are presents for those offline. In the Q&A session, the questions, once they're raised online and offline, WAPIC dental tooth can be won. This gift can be delivered right away for offline audience, and for online question raisers, you'll be reached out separately. Afternoon session will be begun. CEO Omtaegan of Osstem Implant will open afternoon session. Mr. Please come to the stage. Please welcome him with warm round of applause. Nice to meet you. Did you enjoy lunch? Thank you. Thank you for coming to Osstem meeting. Today I want to talk about the advancements in the dental field. I want to focus on a couple of topics. It's right after lunch, and I know some of you may be getting sleepy, but I'll try to help you keep awake. So, do you really feel the advancements of the technological advances? The autopilot mode in the automobile is in third stage, and the fourth stage will be complete within 5 years. I'm sure you are more interested in 3D printers. This is related to material rather than technology, so the growth rate is slower. AI has developed more quickly than anticipated. In the case of ChatGPT announced last November, this is truly a groundbreaker. So what is the advancements like in implant? Implant technology, some say that has peaked. So I want to talk about this topic. The product and technology, when you look at the life cycle of it, introduction, growth, and maturation stage. So where is implant at? I believe it has passed the maturation phase, and it is about to enter the peak phase. So is this the end for implant? Everyone does implant, and the paradigm shift will occur in implant as well. Paradigm shift, what does it constitute of? Digital is definitely in one axis. Is this the end? No, I think there's something more. In Osstem, of course, other companies are working, but a lot of people are putting effort to do this paradigm shift. In order to achieve paradigm shift, you need to have brilliant ideas, and with just a brilliant idea, you cannot achieve paradigm shift. When you look at the night sky, there's a faint starlight. It has been present for millions of years, and it has transferred for millions of years. So this is referred to as faint starlight. In order to get meaningful achievement, you need to hone for a long period of time. And this is referred to as scale up. In order to do this, a lot of money and effort is required in Osstem. The brilliant ideas that have been raised a decade ago, we are still working on it, so we are now really reaping fruit. Yi Sun-shin has made a comment not to make his death known to the enemy. And we have a very important projects that are top secret, and this is referred to as Yi Sun-shin project. And I'm going to share with you a part of this top secret project. As mentioned earlier, the paradigm shift in implant is digital dentistry. So where are we at in terms of digital dentistry? In terms of life cycle, in my opinion, we have passed the growth spurt stage, and we are continuing different advancements. Digital dentistry, how will it advance? In Osstem, digital brand will be made into one digital. As shown, this means integration. This graph shows implant surgeries by different countries. When you look at different literature, per 10,000 people, the number of implants used. Based on our data, we've looked at the number of dental clinics, and as shown in the case of US, it is 42%. Japan 23%, Hong Kong, it's a smaller country, so it's 69%. In the case of Korea, the numbers are quite predominant, it's 83%. As shown, the reason why it's number one is thanks to our effort. Korea is where implant has become more widespread. Osstem has worked long and hard for national oral health, and I would like to express my gratitude for your support. And will we be able to continue on with this track record? Will we be able to excel in implant dentistry? Based on the recently acquired data, there are some uncertainties, so I want to share with you. This is that, and this data is from Osstem Guide. I've looked at different number of dental clinics. What is remarkable is that Japan, in the number of dental clinics that perform implant dentistry, the numbers were low, but it's number one here that has transitioned to digital dentistry. And this is not nationwide information, it is Osstem-based information, but Osstem is a important axis in dental field, so I think it's quite remarkable. In Korea, it's only 17%. It's just 17%. In this circumstance, what we should do? The reason behind this, I think there are two reasons. First is the slow rate of technological advancement by the companies, and second, the Korean dentists are really deft with their hands. However, no matter how well a person may calculate with their head, they will not be able to win the computer. And I believe that digital dentistry will replace analog. The digital bus will continue on, and I hope you hop on before it's too late. Digital dentistry is not an option, it's a must-have. It's not whether or not you're going to do it. You need to think about how well you're going to do it. That is the issue. So I want to talk about digital dentistry and Osstem's perspective on it. We refer to it as one digital PMS software platform is used, and one workflow is formed to address all that occurs within dental clinic. Patient registration and planning, designing, fabricating prosthesis, patient record management, and filing for insurance. All of it can be handled with one digital. Next, 3 different dental clinics can exist with one digital: first floor, second floor, third floor. The third floor is A, second floor B, and first floor C. The left is dental clinic and right is company or lab. And I'm going to explain by different types. This is A type. Before I go in, digital can be divided into 3 steps: data pickup, planning, design, and manufacturing. In A type, in dental clinics, the data pickup is managed. Planning, manufacturing is done by a company or the lab. This is the A type. In the case of B type, it's the middle stage, and planning and software is done at dental clinic. And in manufacturing stage, lab or the company is utilized. Third option is done by dental clinic. In the end, this includes planning, manufacturing, and this is referred to as mini-factory. A mini-factory is formed within your dental clinic. Let me summarize. A type, if you choose this, you will focus on the innate function, and B type, you'll be in charge of dental treatment as well as adding a manufacturing process. By running manufacturing process, more opportunities exist for profit, but the risk increases along with it. Even if you choose C type, it is like running a manufacturer using AI. This is not about running a manufacturing company. AI is used so that it becomes a smart dental factory. Osstem continues on with technical advancement, and I'm sure we'll be able to provide with you tangible results soon. Osstem's one digital direction is as shown. Based on big data, we recommend the recommended treatment method, and you'll be able to use computer guide very easily. As mentioned earlier, if you choose a C, it is not about running another manufacturing company, but you'll be able to focus on your treatment, and the manufacturing process will be managed by the AI. In order to do this, all treatment process, in other words, implant manufacturing and the partnering lab, all areas of treatment should be connected as one network, and the integration of such network can be based on one click from Osstem. I'm going to switch gears now, and I'm going to talk about implant body technology. When there's problem with the clinical aspect, I feel really unfortunate and I feel sorry. And the implant body fracture is something that I feel really sorry about. From 10 years ago, we've devoted ourselves to continue on with technology, and ideas that have been raised 10 years ago are reaping fruit to these days. So I want to focus on that first. So let me share with you some data. This data was released in 2018, and it was raised in a journal. Implant body, 19,087 were evaluated. If you can just look at the yellow part, among 1,000 implants, 15 implants have fractured. In the case of Astra, 9 implants are fractured. Osstem, 2. The fracture rate is 2%. I don't have Straumann data, but I'm sure there are many fractures there. Next, I want to look at the evaluations of Osstem implants. If you look at x-axis, 3.25, 4.0, 4.5, 5.0, And on the left, if you look at 4.0, it is 2.1. So about 2 implants are fractured out of 1,000 implants. So this is data of the past, and 5.0, 0.3 means that 3 implants out of 10,000 implants are fractured. What we want to say is that we want to change the unit of it.
If you look at this data, it's about fatigue fracture, a life cycle, 3.5 compared to 4.0. The fatigue life increases 260%. So fatigue fracture is proportional to the diameter of the implant to the power of 4. But we challenge that. That means a 4.0 millimeter diameter would have fatigue strength of 5.0 millimeter diameter. So the result is this: 4.5. This is a normalized numbers. 4.5, 100. It's 1 or 2 fractures out of 1,000. Diameter 5.0, 2 or 3 fractures out of 10,000. Our current status is TS. The yellow one is TS plus. We reached diameter 4.5 millimeter diameter. So KS plus reached 5 or 6 fractures out of 10,000. It is not quite 5.0 diameter, but it is getting close. And in terms of diameter, based on 4.0, TS 100. 100 is the criteria standard. TS plus, KS plus. You can see the fracture rate in red, 2093. That's the real data compared to that. If it is converted to fatigue fracture, KS plus would have 600. So that's 5.0 is close to 0. 4.5 is 72. So we are getting closer to the goal. So TS is at the leftmost side. TS is no longer produced. TS plus and KS plus. TS and TS plus. Surgery protocol and the prosthesis are the same. You can continue to use them, and it will show just the better results. KS plus and KS. It's a small thread, 5 millimeter. The thread. The surgical approach is the same, but the prosthetic components are different. You need to use a different prosthetic component for KS plus. So 4.0 millimeter diameter has a strength of 5.0, which is strongly recommended for you to use. And then let me switch the gears. On the left-hand side, it's a bone carrier. 6 or 7 years ago, we used the carrier on the left to put bone in. It was quite inconvenient. And on the right-hand side, bone carrier was made by Osstem 6 or 7 years ago. And still, it's not quite satisfactory. And we came up with a new one. On the left-hand side is the current bone carrier. On the right-hand side, it looks a little bit different. It is fitted into a handpiece. On the left-hand side, in the carrier, a bone material is put in, and cell line is added, and they don't fall out. On the right-hand side, it is connected to the handpiece, and it is the bone material is filled in, and that is developed and produced and distributed to university hospitals. And you can see the bone graft materials in there. And it is very convenient to use if you look at it more close. So it took 2 minutes and 20 seconds. It used to be like 4 minutes to feel the bone material in the carrier, but now it is reduced to 40 seconds in order to get rid of the inconveniences. This has been developed for a long time, and this is not to increase our revenue, but it is designed to facilitate surgery. Next, CT T2 Plus. It has 4 advantages. The sensor is replaced. The voxel size is changed to 50 micron from 80. Very good resolution. And the CT scanning took 22 seconds. Now it is reduced to 10 seconds. And the panoramic view is reduced from 16 to 10 seconds. And if a patient move, the vibration of the images is quite reduced as well. And the radiographic dose is very important, which is an issue. But the general, Korea Center for Disease Control recommends 2060 MGY, but we have 1.5 or lower, which is closer to panoramic V. So this is the ultra low dose that we have produced. And Osstem's advantage, the design is really aesthetic. There are white, blue, red colors available for you to choose. Next, the K5. K5 received Good Design Presidential Award in Germany. It won IF Design Award, which is top 3 worldwide awards. We are concerned about infection, and water control is very important. On the left-hand side, new water pipe, and on the right-hand side, 7-year-old water pipe. So a biofilm would be accumulated when water is not very clean, as discussed by this paper. So Osstem developed this sterilized water supply device. So central supply water supply device is used usually in a dental clinic. And if sterilized water is supplied only from the center, as it travels a long pipe, long tube, a biofilm would be affecting the water because biofilm is attached to the tube. And the water going into patient mouth would be recontaminated. Therefore, sterilized water devices developed by Osstem. And K5 chair has this mounted in the system, and it is a basic feature of K5. So K5 has so many features, so it is a little bit more expensive, but if you consider the features, not necessarily. Experimental data, x-axis is the days, y-axis the sterilization level. The pink area is if you drink water, it should be 100 or below in terms of CFU. DWCS is almost 0. So our sterilized water is very well sterilized. And if you look at the KTR experimental test result, log reduction 5 or more. So biofilm, 99.999% is removed. That is the power of sterilization of our device. Second, We have developed a very good feature because patients fear cold water, and I have sensitive teeth as well, and it is difficult for me to drink cold water. But in a dental clinic, there's people are afraid of syringes as well as cold water. So we want to reduce the fear of patients. Handpiece, scaler, and all instruments would be supplied with warm water. So that's what we developed. That is already mounted in K5. So if you look at the graph, experimental data, the blue line. In the wintertime, 5 degrees Celsius water is entering the device, and 25 degrees of water is continuously coming out of handpiece, and K5 has this warm temperature supply. And the patient is quite happy with that. And I show this picture to our staff, and they say, if that lady treats me, I would be really happy even though I have cold water. And the suction holder in a Korean dental clinic, as well as in America and Europe, we have difficulty in hiring staff. So one-man dental clinic is getting popular and popular without using staff. So here, suction holder would make the number of staff to be reduced, or even though you use the same number of staff, a staffed hand can get free, and that can be attached to the back side of a chair. And if it is attached to other parts, if it is fixed, that is not very good for the patient. So this will be launched in September this year, and you can see the device on the first floor today. So this is to show what we are doing very well. Osstem, based on revenue, we ranked number 5 around the world in 2020, number 4 2021, and last year we ranked number 3. And thanks to you, we climbed one step above every year. Please give yourself a big round of applause. Thank you very much. So if we do well, Nobel Biocare is the originator of implants, and we may be able to go higher than Nobel Biocare next year. That's our hope. And I would like to thank all of you who have supported Osstem Implant, and we will answer your support with good products and services. And one more data. We talked about implant ranking, but now this is the total revenue ranking. Number 1 in terms of the manufacturing, Dentsply with 5 trillion won of revenue, Invisalign and Align, and number 3 is Straumann. And Osstem ranked number 9 with 1 trillion won of revenue, one step higher than the previous year. And hedging fund joined Osstem Implant, and you asked these questions, so let me talk about this. So we did purchased and we secured 96% in April in terms of equity, and they will be delisted in August. So let me explain that. Basically, we will be able to secure stable management, right? As you saw from the outside, there was some problems with the management power. Now we can focus on management, how to realize the management philosophy of ours, which is a good friend for dentists. So it will be more favorable to increase our company valuation. Is your chairman working still? That's the question I get, and he is here with us. So he comes to the office early in the morning, 7:30, and there's no change in the management, and he's doing really diligently. And Osstem has the philosophy which is helping our customers' success, and that will continue to be pursued. And please give us continuously your trust in us, and we'll do our best. Thank you very much. Thank you.
네, 오스템 임플란트의 미래와 비전을 잘 설명해 주신 엄태관 대표이사님께 다시 한번 큰 박수 부탁드립니다. 네, 이제 바로 이어서 강연을 이어가도록 하겠습니다. 아마 많은 분들께서 기대하고 계셨을 시간이지 않을까 싶은데요. 세 분의 연자께서 풀 마우스 임플란트 리해빌리테이션에 대한 수술적, 보철적, 치주적 견해를 나눠보신다고 합니다. 그럼 바로 연자분들을 소개해드리도록 하겠습니다. 연세대학교 치과대학병원 박영범 교수님, 삼성서울병원 양승민 교수님, 한양대병원 치과 박창주 교수님을 모십니다. 큰 박수로 맞이해 주시기 바랍니다.
Greetings. Nice to meet you. I'm Professor Yang-Min of Samsung Seoul Dental Hospital. I am Professor Park Young-bom of Yonsei University Dental Hospital. Nice to meet you. I'm Professor Park Chang-Joo of Hanyang University Hospital. I'm honored to meet you two, and I'm honored to talk about the full mouth implant rehabilitation and surgical prosthetic and periodontal perspectives. And I'm honored to speak in front of offline and online audience, and I look forward to today's session. It's really great to see all of you. So I'd love to hear your 2 cents. I'm honored to be here where we can take a glimpse into the future and vision of Osstem. And as we prepare for the future, I want to talk about the full mouth rehabilitation cases. So today's session is based on the survey that has been taken ahead, and I hope we'll be able to utilize the data as a milestone as we move forward. This is a separate topic, and we met a lot of times, and this was truly a learning experience. And we discussed it as to how to convey our message, and through the session, I hope we'll be able to provide the meaningful information. First, I want to talk about how we have provided treatment for full arch cases. I want to talk about a conventional case. As shown, the patient came in. It's been about 20 years, and I want to show you how it was treated then. The patient was wearing RPD in the upper and lower. The abutment of the RPD was damaged, so the patient came in the patient could not chew or eat, and the patient wanted treatment here. And if you look at oral cavity, RPD abutment tooth is here. And there's a lot of plaque. And on X-ray, a lot of gingival recession and alveolar bone loss was observed. And the prosthodontist and I worked together to come up with treatment plan. Rather than saving teeth, I thought it would be better to do extraction and proceed with treatment. Extractions were done. And this was mentioned in the morning session, but after extraction, provisional denture was used to provide, to stabilize the VD and to get information regarding this. Patient profile was observed. Dr. Bach has mentioned soft tissue and other profile issues were observed. The different references were checked more so than anything else. I thought that muscles were quite developed. I talked with Dr. Oh, the prosthodontist, and implant-supported denture was planned. Implant positions in order to get them in the past. This is the form is slightly different from what is mentioned earlier, but this is the original type for different tooth positions. Surgical stent was made, and along with that, the implants were placed. I'm sure you can see, but implant placement position is not as favorable as planned, and there were some difficulties, and following that, prostheses were delivered. It looks slightly odd. There are many issues here. On X-ray image, did you see what is off? If you take a closer look in the posterior area, there is radial opacity. At the time, when making denture, in most cases, resin was used. Resin denture form was used, and these days, zirconia is available. Great materials are available now, but it wasn't then. Prosthesis was made like this. In the posterior area, how did I approach it? If you look at clinical image, there's a crown, gold crown. At the time, the materials were not as good, and implant prosthesis. So the final restorations were because of that vertical changes would occur. So crown was used to maintain it. After that, the patient did not come for follow-up. If you look at for 8 years on the X-ray image, it is nicely maintained. The prosthesis, when we make it, regarding how it was made, it was briefly observed. We did a survey in the morning and during lunch break, and the questions raised were, did you ever have experience with full mouth dental implant rehabilitation? Then about 80% responded yes, and 20% answered that they have yet to face such cases. So the pool of the survey is very important. The online, offline audience. The topic of the day is a full mouth dental implant. So you're obviously very interested in the topic. So the assumption is that you have some experience. And in the past, we did the same survey as well. At the time, the survey was held on group that did not do a lot of dental implants. For instance, groups related to the orthodontic treatment or root canal. When we did the preliminary survey, the results were the other way around. 80% did not have experience. So when we prepare this session, regardless of beginner or whether you're an expert, through this session, we try to devise and design the session so that you'd be able to get meaningful information. Conventional method was addressed just before, and as the CEO has mentioned, I want to talk about how digital dentistry affects this treatment rather than conventional method. How does digital dentistry fall into the digital dentist full arch rehabilitation? In the case of this patient, the patient had a blind fear against dental treatment. Minimal number of implants were placed as in order to adjust for the lower denture. Implants were placed. Implant-supported overdenture was provided. When you provide a treatment like this, the patient starts to have the desire to chew better, and they gain confidence that implant treatment is not difficult. The digital one guide was available then, so in the upper and lower, surgery was performed. And this is at suture removal. And provisional was provided earlier than planned, and final prosthesis was delivered. I was able to guide the patient through this journey because full arch rehabilitation has become cheaper. In the past, it used to cost about 50,000, but now the cost has become much less. So that is why a lot of attention is being focused on full arch rehabilitation. The reason why I brought this case is that because I've never tried it, I'm not interested. But with experience, the patient, as we proceed through it, there's no specialized implant practitioner, and this you may face this kind of case as well.
I used the conventional approach. Impression was taken and the VD was adjusted, and Dr. Park is applying digital technology. So we did the survey in advance to utilize digital guides in the treatment plan for full mouth implant rehabilitation. As you can see, for full mouth implant rehabilitation, the answer was 8 to 2, yes to no. But now, conventional approach is used more than the implant than the previous questions. So let's look at how digital approach is used in treating full mouth implant rehabilitation. Dr. Park Yong-Bom is going to talk about it. Dr. Park Chang showed you the digital cases are encountered more and more. Let's have a look at the process. In this case, the periodontal problem was there with the patient in the early stage. The treatment intervention can be provided with implants or conventional prosthesis, but in this case, the patient was fearful of dental treatment, so the patient was delaying the treatment. So over several years, the patient used temporary denture, and ultimately all fell out. So the old denture was not a complete denture, but provisional denture was repaired and used. So before full mouth rehabilitation, the temporary was made like this, and based on the information, prosthesis-based approach was used. So there are required materials, intraoral scan data, and direct or motor impression can be used. So tissue side data is required, and CT data. So the implant diameters and lengths can be chosen based on that. to design the case. And denture scan data and CAD/CAM software needs to be used. Dr. Yang did manual teeth setup 20 years ago, and how to place implants were designed using a model surgery. Now, based on prosthesis, how many implants need to be placed, and the diameters and number of implants can be determined. Motor scanner or intraoral scanner can be used to scan the tissue side, and jaw relation vertical situation can be transferred to prosthesis, and we do the setup between the two jaws, and the patient's jaw relation and alveolar ridge situation, and it can be reviewed. For full mouth rehabilitation, we usually think of a fixed rehabilitation. Then at what locations, how many implants, and the lengths of implants, they all need to be considered based on the CT data to see whether the surgical site is appropriate. So all those need to be planned before surgery. As Dr. Park said, in the morning we talked about a similar topic, and this is a review of that. And when we do treatment planning using digital, and he talked about that. And using digital approach, virtual planning is done. And how can we apply it to surgery? Can you comment on that? Let's look at, if you look at the result of survey, unexpectedly I realized the people here are experts. 80% have experience in full mouth implant rehabilitation, but they do not use guide as much. Maybe they are very confident in surgery without using a guide, and they may have very good expertise. So they don't need to use the surgical guides. But as I mentioned at the beginning, we need to talk to beginners as well as experts so that they can do prosthesis more easier and more accurately. So if we use a lot of information in planning prosthesis, that should be transferred to the digital world. And 3D printers can be used, which has enjoyed a lot of advancement recently. And various materials can be used for the printout. And then the information is used for the planning, and implant positions are determined using the same CAD program. A guide can also be planned, which is an aid to surgery. So based on the implant positions, a guide is designed and the data is transferred to a printer. So in-house, you can use the printer to print out a guide, even though you can send the file to a lab to get the guide made by them. But here, some regrettable mistake is observed. Dr. Park Sang-Joun Yu give us some case regarding that mistake. Prosthetic planning is important, and fixating surgical guide is as important. As you can see, the sleeve of template is used, the vertical anchor, bone anchor or bone anchor screw is used here. It's not tooth supported. A full mouth rehabilitation, it is tissue supported, so mobility is very critical. So you can prevent left and right movement, but it cannot prevent up and down movement. Lateral movement can be prevented with this. And anchor screw is used to prevent the movement mesial to distal. So precise template fixation is very important. Bone anchor is a vertical anchor. So the sleeve is used to place implant in an accurate position. And based on the implant anchor, sleeve used, so it is a vertical anchor. So it is so drilling can be done with these anchors. Digital technology is being advanced more and more. I showed you a 20-year-old case, a prosthetically compromised cases are being reduced, and more better prosthesis is achieved. Clinically, we encounter some issues. Clinically, the clinical time is always time to make decisions. For full mouth surgery, what are the issues that we encounter? If we have a full denture patients, it's good. But as Dr. Park's experience, there were many teeth left, but gradually they fall out, and eventually they present a full mouth case. So at what point, what surgery do we need to do? That is a matter of decision. So when a patient comes in, what surgery should be done? So we did a survey on that topic. What is your preferred implant surgical placement for full mouth rehabilitation? If teeth are remaining, do you place an implant immediately right after extraction, or do you place implant in a delayed way? And we need to make a decision to choose between these two. So let's have a look at the pros and cons of these approaches. For the viewers, what we need to be careful about. We will discuss that. So this is my case. This patient.
RPD abutment was used and abutment all fractured, and the patient came in and said, "Can I receive implant treatment? And I want to be able to chew properly." The patient and I talked, and extraction and form needs to be observed, and because the patient's desire was other way, prosthodontic plan was formed and different ways were considered. This was the profile in oral cavity. You can see in the upper, it's a very unique case. The lower is intact, but the upper, there's nothing left. The decision was so that in order to satisfy patient's requirement, immediate implant placement and loading was planned. Digital planning was done, and following that, digital planning process was already addressed, and one guide was used, as Professor Park has mentioned. The fixation is very important. Anchor pin is in, and following that, implant virtual planning was done. I'm sure some of you might have noticed the digital planning when you do it, and the interior and posterior design is slightly different. TS was used in the anterior area, and for the posterior, US was used. For full arch rehabilitation, a digital guide can be used. Some people only use TS, but my prosthodontist in posterior area, they use SS or US and TS for the anterior area. In those cases, not just TS, but you can use SS or US when doing digitally guided surgeries. Implants were placed. So the case looks really nice. I talked with the patient. There was a bit of bleeding. The patient suffered. So one step was forgotten. The original plan, immediate implant placement was done. So implants should be placed deeply. Because it was placed deep originally in one guide, the guide recommended way is to do flattening drill to trim the bone to remove interference. But I skipped that part. So abutment, if you look at it, it's not fully seated. The prosthodontist did it multiple times, but couldn't, and just did loading in this state. Continuous adjustments were done. You can see that it's fully seated gradually, but there's still a little bit of a remodeling going on. In these areas, it has been seated, and prosthodontically, it has been completed. Final prosthesis was delivered. Step by step, as immediate implant placement is done, it can be done using different steps. But as mentioned, the advantage is that you can provide the restoration that the patient wants. And with surgery, there can be many challenges. So rather than that, some people do prefer delayed placement. If you look at the survey, the delayed placement was favored 5.5 to 4.5. So Professor Park is going to add on this topic. I'm a maxillo-oral surgeon, so I really like immediate placement and immediate loading, but delayed loading and delayed placement do have benefits. This is upper edentulous case. Extraction was performed first. I waited sufficiently. If you do this, the biggest benefit is that there can be soft tissue fill and bone fill. It's not about placing implant. Additional procedures are done at the same time. But at times, there can be lack of soft tissue, let alone bone. If you have sufficient soft tissue, there can be advantages in that. That is the first advantage. The second is digitally. If you wait sufficiently, bone and soft tissue can be differentiated. In immediate case, the boundary between that is kind of vague, so it's quite difficult to address. But if you heal sufficiently after extraction, then you can tell where it is hard and soft tissue. So upon planning, you can tell that apart. In the upper, temporary denture was used. What I want to address again is that in full arch rehabilitation, the war with the provisional starts. The patient wants quick results. Temporary denture needs to be prepared ahead, and this is also another benefit of delayed placement. And temporary denture has an immense amount of information. You can utilize that, or one guide radiologic template can be used to reflect the occlusal dimension and occlusion. This is another benefit of delayed placement. As shown, surgery was done. Primary surgery was done. Sinus left and right surgeries were performed, and the upper right is quite resorbed, so extensive GBR was done, and the secondary surgery was done after healing, and the temporary denture was not used. A fixed prosthesis was provided. Overall, delayed placement and immediate placement, there are different pros and cons. Professor, when you do delayed placement after extraction, do you just leave it or do you do different procedure? That's a very good question. In this state, I did extraction and did additional procedure and did secondary surgery. 3 surgeries were performed as of late. Ridge preservation or alveolar ridge preservation (ARP) is more frequently done. It's not a full arch case. The upper central incisors, there's root fractures. Rather than just doing extraction, after extraction, socket grafting or ARP is done. AOS collagen was used, and the lack of soft tissue was observed. Connective tissue graft was done. After that, right after surgery, the panoramic image shows that significant grafting has been done. There will be significant bone fill, and the bone is sufficient for implant placement. Template is formed, and upon surgery, because primary stability is good, the healing abutment can be connected. This is final prosthesis. In the past, 3 surgeries were performed, but if you do ARP, the number of surgeries can be reduced to 2 times. That is why socket preservation or ARP go well hand in hand with digital dentistry. As shown, immediate implant placement and immediate loading, delayed placement or delayed placement, soft tissue and hard tissue, augmentation. I think as we provide clinical treatment, this is a dilemma. And the 2 cases have been shared, and as you have watched the 2 cases, I think you'll be able to get more information regarding how to use them as references. We've only talked about the surgical side, and prosthodontically, what are the benefits and disadvantages of delayed placement and immediate placement. So in doing full arch rehabilitation, and as we plan implanted treatment for that, the reason why we fabricate the guide is that basically, if you're going to do immediate placement and immediate loading, that is the ultimate goal. If possible, there are benefits in providing immediate placement and immediate loading. So guide is fabricated precisely, and you need to fixate that, and surgery is performed. Osstem 1 guide in its early stages, the ministry at our hospital work together. I want to dive deeper on that. Immediate implant placement or site preparation and staged approach. There are different pros and cons in the 2 options, and prosthodontically speaking, after immediate implant placement and immediate restoration, the benefit is that the abutment design and crown design, if you do it ahead, and as bone remodeling occurs, bone soft tissue remodeling, it becomes reflectant of the prosthesis form, so it's easier to maintain and it has many advantages. However, we did 1-year follow-up. The results were all good, conventional, when we compare with conventional approach. When delayed approach was done, compare with delayed approach and immediate implant placement, the only difference was that the quality of healing after 1 year or more of follow-up. The only disadvantage was that statistically meaningfully, there was slightly higher failure rate, and the failure rate was statistically meaningfully high. And we did data analysis once again. Various indicators, the torque upon placement, different tests and evaluations were done, and primary stability, and does have high relevance with implant success and failure rate. And based on that, we only tested implants that fell under criteria if If it didn't, it was divided into control group and delayed placement and delay loading was done. However, no matter how stringent our criteria was, there was a failure. So primary stability leading to osseointegration and secondary stability. This is not 100%. So there can be prosthodontic issue if loading control is done wrong to the slightest or based on patient's occlusal pattern or masticatory pattern. If it exceeds the average level, then there can be failures in that sense. Two, be it the immediate implant placement or delayed placement, we need to understand it thoroughly and we need to understand the risks fully before proceeding with treatment. Then we'll be able to provide the optimum treatment. So it's all related to loading and how much primary stability is really dependent on that. Up until now, how treatment planning is done and surgery is done, in the end, it's about prosthesis. What kind of prosthodontic treatment is provided on this end? The survey was done. And what is your preferred option for full mouth implant restoration? 80% of the time, fixed prosthesis were provided.
And 6% removable prosthesis, 13% all-on-X hybrid prosthesis. So for each, I believe there should be some criteria. We cannot just blindly go for fixed prosthesis. Let's talk about the criteria which needs to be considered during treatment planning. Dr. Agyongbom, when we can choose a prosthesis, we can choose, but sometimes we cannot have choices because of the medications that a patient uses and economic reasons. So we cannot afford to choose some modality. So apart from the surgeon or patient's preference, so we need to have some scientific criteria, especially in the anterior region. Aesthetic evaluation should be done, when to go for the fixed prosthesis and when to choose for removable. This is my resident's case. The fixed rehabilitation was chosen based on logical rationale, justification. As you can see, there's a discrepancy between dentated and indentated part of the jaw. Recently, the smile line is the trend, and the most important factor of a smile line is the anterior teeth and smile, the lip forms, lip support in terms of horizontal factor, whether a lip is supported properly by teeth in an aesthetic way. When smiling, if white teeth is to be slightly exposed or fully exposed, so these need to be analyzed. So the incisor area of the teeth needs to be naturally showing. In that case, the fixed prosthesis can be chosen. But if that is not the case, the remaining alveolar bone is not the original bone. Remaining alveolar bone and lips need to be evaluated in terms of horizontal and vertical bone volume, which can determine the aesthetic results. So evaluation should be done based on that. In this patient, the remaining teeth were all extracted and old denture was turned into a provisional, and that is copied, and digital scanning was done and printed. And the aesthetic factors can be evaluated. for fixed prosthesis, flangeless denture smile line need to be evaluated. The flange actually made the lips protrude too much, so flangeless natural looking one showed more natural lip support. So as was shown in the previous paper, there was a vertical bone defect. So the pink porcelain is used to compensate for the cervical area, but vertically. So horizontally, the smile line is okay. Therefore, we made a decision to go for the fixed solution. So implants were properly placed, and we could satisfy the patient with prosthesis. Based on all of these, whether to go for the fixed or removable should be decided. Lips, teeth, and ridge. The relations between those two need to be considered to go for the fixed or removable solution. Based on the survey, 80% of the dentists chose a fixed solution. And I believe they believe there's a vertical defect but not a horizontal. So let's have a look at my case. The patient used the removable denture before this, and the full denture was worn in the upper. And implant-over denture is planned for the mandible, and the implants were placed. And if you look at the lip support of the patient, it is horizontally concave. Can we use a fixed prosthesis? But so we decided to go for removable over-denture supported solution for the mandible. And the patient was quite satisfied, and he wanted the same for the maxilla. And we removed the one implant which was interfering with the support in the posterior region. Removable was chosen because it looked more favorable, and railway was laid, which can provide support in the posterior region in 2012, 2016, and it was used very nicely for 10 years without bone loss, and it was maintained properly. So removable prosthesis, which is chosen based on some criteria, can be maintained for quite some time. As Dr. Sung-Hwan Oh talked about hybrid prosthesis, which is a hot topic these days. So Dr. Chang-Joo Park will talk about what we need to consider in using hybrid prosthesis. Hybrid prosthesis is quite popular around the world, and I tend to talk about automotive. So the hybrid automotive has electric and a combustion engine. So this hybrid prosthesis has fixed and removable aspects, and the patient used a removable denture which did not fit very well, and the old denture has so much information. As was discussed in the morning, dual scan is used to prepare a surgical template, and I looked at Dr. Yong-Jin Kim's live surgical information, and all denture is used to prepare for temporary, and the importance of temporary cannot be overemphasized. So dual scan is used in. We are interested in creating bone in placing implants, but hybrid approach is different. bone augmentation is not the point. Bone reduction is the point. We can get primary stability of implant, and as Dr. Young-Won Park said, prosthetic space can be secured, and mandibular thin ridge is reduced sufficiently, and 4 implants were placed in the maxilla. Sinus graft was also done. Primary stability was achieved. The healing abutments were connected, and the healing was progressing. The typical one is all on 4, because everything is on 4 implants. All on X means it uses a little bit more implants to avoid the sinus in the maxilla. The letter M is used, and in the mandible, implants are placed in the pattern of W to avoid the foramen. All on 4 usually has a limitation in the placement depth and length. The magic 4 is quite helpful when surgery is done. The T-bar is mounted at the interim structure, and fixed tight prosthesis is delivered. This can give quite good satisfaction to patients, especially this is economically beneficial. The patient hardly smiled, and I realized the patient has beautiful smile once this was delivered. However, it is economical, and it gives a lot of satisfaction to patients. But in terms of maintenance and mechanical complication can lead to biological complications, because the prosthesis should go through the repair process. So that needs to be remembered. We had a question regarding fracture on X, how they can be repaired. Looking at this case, I felt that how to clean the area around the implant abutments, because I'm in the periodontal department. So in terms of oral hygiene, we need to provide a favorable environment for oral hygiene. So when we place implants, as was mentioned before, we can go for fixed or removable prosthesis. In the past, after placing an implant, the bar type was used for the prosthesis. If you look at here, the implants were placed in 2002 and disappeared and came back in 2018. Fortunately, the bone loss was not there and the bone was maintained. But the patient came back because, as you can see in these photos,
the interdental tooth did not go in between the left side, so the patient took a vigorous care of it. The bar type restoration was provided. In the case of upper, around the implant, soft tissue proliferation can occur. In that case, with long-term use, the oral hygiene cannot be maintained. The patient came, so we made sure that oral hygiene can be achieved. The gingivectomy was done. The patient maintains it nicely. It's the same patient. If you look at the lower, there were few teeth, but fixed prosthesis were provided. In the upper, although it was the same patient, in the upper there was a soft tissue proliferation, but there was resorption in the lower. In the canine area, when the patient said that she was unable to do toothbrushing, and through FGG, the soft tissue was altered. After that, the patient maintains it very nicely, and then the patient does not come back because it does not have any problem. When the patient returns, then we can provide treatment accordingly, all on 4, all on X. And when we provide that kind of treatment, if there are certain issues, we can address the maintenance. Is a very important factor in that. Not just a periodontal perspective. I think in terms of maintenance, a prosthodontal the prosthodontic perspective is very important as well, as shown in this case. There's a lot of tooth wear. Plaque control was done nicely, and obsessively the patient was managing his or her tooth, but continuously between the teeth, food impaction occurred, and it was very difficult to maintain oral hygiene. It was difficult to use interdental tooth. If you look at this kind of case, implant treatment is done using digital dentistry, or site prep is done. For instance, we can use ARP. An implant is positioned nicely as shown in the textbook. Plaque control is done. If you do that, in different situations, when implant is not positioned, then prosthodontically, then it can be a very challenging situation. If the prosthesis is less than ideal, there can be periodontal issues continuously and biological issues as well. If you take a look at the white, there's something here. We removed it. After that, when I took a look, there's continuous inflammation. Prosthesis form is very important in maintaining the implant. It was opened and we made sure the patient was able to maintain it, and this issue was resolved. What I want to say here is that, as mentioned, if you place it in ideally and provide an ideal prosthesis, it is much easier to provide to do maintenance. If the prosthesis form is odd, we need to make sure that the interdental space is clear. If the space is slightly vague, rather than doing this, you need to make the punning small and then make sure that the patient can maintain oral hygiene. So based on survey, different topics were addressed and the preparations were done. So full arch rehabilitation experience, it's 80%, but guide is used 50% of the time. And in getting the contour in terms of prosthesis, if you can do a good job surgically, then it's not a problem. The form and position needs to be ideal in order to address and mitigate many problems. We were able to share our experiences together. Now we will entertain some questions that have been raised offline and online. First, let's look at some questions raised online. We'll pick one of the questions. Not just patients with a lot of alveolar bone. If the patient has resorbed the alveolar bone, should I place multiple small diameter implants, or should I do bone augmentation and place a few implants? This is a very difficult question. Periodontally and prosthodontically and surgically, could you answer the question first, prosthodontically and surgically as well? The question, the number of implants. Should I do site preparation sufficiently as shown in the morning session, alveolar bone augmentation? If you do that, if you have done such effort, then placing multiple implants is better than placing few. But based on multiple evaluations, if you think you need to place few implants, then you need to consider what kind of a prosthesis that is going to be used, and you need to think of various aspects. A site preparation needs to be done and use a appropriate diameter implant. Then you'll be able to provide successful treatment next year. In Osstem, I think this is going to be addressed. I think Osstem is going to talk about short and narrow implants. And in many literature, a lot of people use it without a problem. So I hope we will be able to talk about it in depth. Sometimes I use narrow diameter implants in the upper and removable. There's higher percentage of failure. In lower, the success rate is on par with other options. So The short and narrow implants are great, but there are some risks when using it in the upper and removable types. Surgically, what do you think? From maxillofacial surgeon's perspective, if you have placed the implant along with bone augmentation, then that is the correct answer. But when you use a digital dentistry, you can scan the bone and get a rough sense. Mr. Has mentioned that implant is getting better. In the morning session, number 3 and 3 are considered very important, and there's a reason behind it. Lateral excursion or occlusal force is applied. As of late, the digital, if you can disperse a load, then adjusting the position and placing good implants and doing significant additional procedures, then you'll be able to get great results. And I have such experiences. What kind of treatment plan you choose is really important. Residual bone, placing an implant on top of that, and taking minimal surgical effect, or are you going to do ridge augmentation and place the implant in the ideal position? Clinically, that is a dilemma that we face almost every day. And depending on your surgical technique and prosthetic know-how, decisions may vary. Let us entertain another question.
Soon 48 is the nickname of the questioner. For immediate loading, what we need to be careful about, like not chewing hard food. Koreans have very strong occlusal forces, so what do we need to be careful about? What do we need to say to our patients from training purpose? I believe Chang-Joo Park would have better comment. For full mouth prosthesis, what do we need to be careful about? Of course, occlusal force should be paid attention, and we need to be careful about lateral force applied to the restoration. Immediate restoration is provided for immediate chewing, and we should not stretch the limit to go beyond the unsafe zone to be experimental. And we need to make a patient be careful about for a couple of weeks. So the first week and the next week, until the suture would be removed, they need to chew soft food, and a gradual recovery of chewing is recommended. I agree. In 2018, All-on-4 inventor is a Portuguese Dr. Mr. Malo, and I went to his clinic and I asked about All-on-4 to the doctor. I brought my father and my mother, and my father was used to very tough food, the Korean food, but when he visited Portugal, he experienced very much tough food there too. We were surprised, and we always looked on the data from Western world. It's different because we enjoy tough food. But from then on, I recognized that their food habit is similar to ours, and All-on-4 is expanded. How don't you think? How can we use it? But it's very aggressively pursued. And if you look at the long-term data of All-on-4, it has a very good success rate. And you've seen many cases. And hybrid approach would be arriving in Korea sooner or later. So I agree with Dr. Park's comment, and I added some other comment. As Dr. Youngbom Park said about immediate versus delayed success rate, that there was some difference. And unlike what we expected when we do the full mouth rehabilitation, the success rate can be very good too. And for full mouth rehabilitation, everything is integrated into one. So we can achieve a stability from grouping the teeth, and then we can gain some confidence from that. We answered some of the questions, and the best questions need to be selected. ID name Chakra and Som 48. Those two are chosen as the best questions. So we are approaching the end of this session. And when we provide implant-supported full mouth rehabilitation, treatment plans should be appropriately established, and based on the plan in the oral environment of a patient, the plan should be executed and the result should be appropriately manifested to ensure long-term stability. And we need to go step by step in planning the case and in executing the surgery. Doctors, I believe the preparation has been helpful to you. What are your closing comments? When I prepared for this discussion, and it is a pleasure to get to know these two doctors, and I learned a lot, and I thought about some factors that we discussed. And we tend to do a lot of complicated, and I tell my students nobody can do it from the start in an expert way. So you need to go step by step to provide a very good treatment ultimately to your patients. So do not think about jumping to the highest point at once, and you need to go step by step. And if you provide prosthesis treatment for about 6 months, unexpectedly, the patient can be satisfied if you take one step at a time. And a full mouth rehabilitation is not something we can easily jump into, but with the advancement of digital technology, the situation is very different from your case done 20 years ago. So one by one, you can approach to achieve the goal. For complete edentulous patients can be treated with implants. Knowledge on implants and the prosthesis need to be properly understood. So it's not as easy as you may think. When we met these doctors in the preparatory stage, I learned a lot, and now I could understand why the doctors in other disciplines talk something different from me. And I would like to thank Dr. Choi-No and Dr. Kim and the people in Osstem. And this can be a very boring subject, but I would like to thank you for your attention.
Dr. Park, thank you for the wonderful comment, and I'd like to express my gratitude to the online offline audience. And now we will close this session. Thank you once again, Professor Yang Seung-Min, Professor Park Young-bum, Professor Park Jang-Joo. Please give them a warm round of applause. This is the time we've all been waiting for. We will now look at the results of coffee coupon event. This time around, you'll be able to win dessert set. A total of 600 people will be able to win this. Let's start the lucky draw. Congratulations. The winners will receive the coffee coupon via text. As for specific details, please refer to the notice board on the dental site. Those who have been selected as best questions, individual contact will be made. From now up to 2:50, we're going to have a break. After break, there's going to be the fourth session, the highlight of Osstem meeting 2023. So Dr. Kim Yong-jin and Dr. Lee Soo-young is going to perform live surgery. Please stay tuned.
Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 millimeter short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS implant. Introducing the MS implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are 3 types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing the MS kit. The MS kit is designed exclusively for MS implants. The MS kit is designed exclusively for MS implants, which are used in areas where the bone is narrow, such as the anterior mandibular region. With the MS kit, you can place an MS narrow ridge, MS denture, or MS provisional implant with a quick and simple procedure. Try using the MS kit when placing an MS implant. Have you ever experienced the pressure of reoperation because of prosthetic issues such as screw or abutment fracture? Introduce ESR kit designed to solve a variety of prosthetic issues. In case of screw fracture occurs, the fractured screw can be removed by using ESR kit. Connect the SR drill with the fractured screw. After making a hole for drilling on the fractured screw, turn the SR tip counterclockwise and remove the fractured screw. Also, after using the reverse drill, connect the screw holder on the fractured screw. Then, turn the screw holder counterclockwise to remove the fractured screw. In addition to screw fracture, the ESR kit can be used for removing the fractured abutment, repairing damaged thread of implant and screw hex slip. Try ESR kit designed to solve a variety of prosthetic issues.
Port system is a removable overdenture solution which comes with various specifications at low height port cap. Port system requires only 3 mm of vertical space, and it is easily applicable to patients with narrow vertical dimensions of occlusion. The male is made of nylon, offers a variety of configurations from 6 Newton to 22 Newton, enables clinicians to respond to each patient's case. Also, it is suitable for long-term use. Port system, tailor-designed overdenture solution for clinicians.
Introducing the N1 portable X-ray, delivering high-quality imaging while being extremely easy and simple to use. A good portable X-ray should produce clear images. At 70 kV and 3 mA, the N1 produces clear standard X-ray images. Clear images relieve the clinician's stress during the diagnosis process. A good portable X-ray should be easy to operate. The N1 is light at only 1.61 kg, which is 30% lighter than a camera-type device. Also, it has a gun-type design which is easy to operate with one hand. This ensures easy alignment and high accuracy when taking images. A good portable X-ray should have a long-lasting battery. With 15% improved battery performance, the N1 lasts for a week on a single charge, eliminating problems with other wireless X-ray units. The N1 reduces the inconvenience of a continuous charging, which helps improve clinical efficiency. The N1 is easy to use and produces clear images. Introducing the IO1020, which is a highly durable oral sensor that produces clear images. The IO1020 produces clear images with resolution of up to 20 micrometers. The IO1020 helps you identify periapical lesions around the roots of teeth, the interdental space, the pulp, and the periodontal ligament much more clearly. The IO1020's cable is designed at a 0-degree angle to prevent the cable from breaking, and the impact-resistant bumper improves durability. The IO20 model is for adults, while the IO10 model is for children. Using the right size that fits the patient's mouth can help reduce discomfort. Try using the highly durable IO1020 oral sensor for clearer images. With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically, which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have two separate buttons, each for focusing and image-taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neck line is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth when inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera Snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients. 네, 오스템 미팅 2023 서울 이제
Osstem meeting 2023. So now we will begin the fourth session. Before we begin the fourth session, we will now proceed with online event. If you go to Butan's site, you'll be able to check the pop-up screen. Once you click on it, you'll be able to vote.
홍보에 참여하실 수가 있고요.
You can participate in the event. Offline audience can also participate on the event by logging into Dental's site.
이벤트에 참여를 하셔서 커피 쿠폰에
Please try your chance at winning coffee coupons.
오스템 미팅의
Osstem meetings highlight live surgery will be done in the second floor of Osstem's Magok head office. Dr. Kim Yong-jin and Dr. Lee Soo-young are preparing live surgery. First, let us meet with the moderator, Dr. Kim Kyung-won of Twin Dental Clinic and Dr. Kim Ki-sung of Namsan Dental Clinic. Dr. Kim Kyung-won has graduated Seoul National University Dental School. He has also completed the maxillofacial department. He is currently Osstem Implant Dental Research Director and a member of Twin Dental Clinic. Dr. Kim Ki-sung has completed Seoul National University Dental School. He has completed the Prosthetic course. He is currently the president of Seoul Implant Clinical Research Center. Please welcome the two doctors with warm round of applause. Greetings. I'm Dr. Kim Kyung-won of Osstem Implant. I'm Dr. Kim Ki-sung. we always are the moderators for the live surgery, which is the highlight of Osstem meeting. This year, we're going to do full arch rehabilitation. We are going to talk under the topic full arch implant rehabilitation with Osstem digital workflow. Dr. Kim Yong-jun is going to perform surgery, and Dr. Lee Soo-young of Seoul Dental Clinic is going to provide a prosthesis. Dr. Kim Gi-sung will also moderate this session. Dr. Kim, would you like to add any comment? The topic is excellent, and I am honored to be the chair of this wonderful session. I think participating in the live surgery is a huge stress. I'm honored to be the moderator, and I look forward to great surgery and great prosthesis. Now let us begin the highlight of the Osstem meeting. Let us introduce the speakers. Greetings, I'm Dr. Kim Yong-jin, who is going to perform live surgery at Osstem meeting. I am Dr. Lee Soo-young of Prosthetic part. In this Osstem live surgery, we'll demonstrate full arch implant rehabilitation with Osstem's digital workflow for a completely edentulous patient from surgery to prosthetic restoration. Before surgery, let me briefly give you an overview of the patient. He is a 65-year-old patient with controlled diabetes. On the panoramic image, bone height looks sufficient. This is the pre-op oral cavity. The patient has been using denture for over 10 years. There's a little bit of alveolar ridge resorption, but the bone width in the posterior area looks okay. This is an intraoral image with denture. Denture's VT or occlusion is not an issue. When applying digital guided surgery to completely edentulous patients like this, achieving proper merging can be challenging due to absence of remaining teeth. Osstem provides guidance for merging using denture-based methods, and we have applied this approach. Using Trios intraoral scanner, we scan the patient's maxillary and mandibular dentures, capturing both the inner and outer surfaces. These scans are used to create 3D printed models. Then, resin markers for alignment were attached to the outer surface of the denture. These resin markers serve as reference points for merging. If the denture fit is slightly inadequate, we can also obtain an index of the alveolar ridge using soft reline material or light body impression material. After obtaining the bite registration, CT is taken. We then perform another scan of the denture's inner and outer surfaces with the resin markers attached. These scans, along with the data from resin markers, are sent to Osstem's digital center. The data from the denture scanner recognized as surface data, and the resin markers on the CT is used for merging. This allows us to achieve ideal merging without the need for alveolar ridge impressions. By reversing scan data, we can obtain a positive image of the alveolar ridge, so there's no issue with the guide fabrication. Prosthetic planning is done, and now Dr. Lee Soo-young will explain further. The profile and VD looks favorable. Facial scans were done and merging was done. The merged data shows the current full denture in place and the profile. From lateral view, we can observe the alveolar bridge and the anterior area of existing denture, which exhibits some protrusion. This is the current state. Based on this, we designed temporary prosthesis for ideal implant positioning. With the concept of immediate loading, profiles are compared. These CT scans were merged. On the left is with denture, on the right is the new provisional restoration. This is the anterior relations. Dr. Kim Yong-jin need to place the implant accurately. Please tell us the details. As shown on the initial photo, bone within the posterior region is good, but due to prolonged use of denture in the anterior side, it is less favorable. Immediate loading was planned using multiple implants in the posterior area. For the maxilla in number 1 and 3, their ridge is very tight horizontally. In area 3, threads might be slightly exposed. In number 1, even if threads are not exposed, there will be very limited labial plate. In number 1 and 3, GBR will be performed for appropriate labial bone contour. Flap will be slightly reflected and GBR will be done. And from number 4 to 7, implants will be placed without a problem. The bone quality will be slightly compromised, but we'll try to overcome it through surgery. As a result, a total of 12 implants in the maxilla and 10 implants in the mandible are planned. However, we do not plan to use all of them for final implants. For the purpose of creating a fixed temporary prosthesis, temporary implants will be placed in number 5, and it's the same for lower 10 implants are planned. To summarize, in the maxilla, we plan to place a total of 12 implants, and excluding area number 2, all implants will be placed. As mentioned, in number 1 and 3, the ridge is very narrow, so GBR will be performed. Resorbable membrane and particulate graft material will be used for GBR, and after that, 10 implants will be placed in the lower. Prefabricated abutment and temporary provisional is going to be provided, and immediate loading is going to be done, and Dr. Lee is going to explain further. Once implants are placed nicely by Dr. Kim as planned, provisional restoration will be provided in this way. VD, the patient has been using it nicely for 10 years and up to osseointegration, the current occlusion will be maintained, and based on that, provisional restoration has been designed. Using the existing denture, provisional restoration and the existing denture are merged. You can see that on the anterior side, it looks slightly lower inward contour. And in number 7, this will not be included in the provisional. 12 implants will be placed. However, I'm going to use number 456. I'm going to use 3 implants, excluding number 7. 12-unit provisional restoration is going to be provided. I'm going to connect the restorations, and we'll try to do a good job. In the lower, the bone quality is anticipated to be good. Number 4 and 6, the 4 implants will be used to provide 12-unit provisional restoration, excluding number 7. Once Dr. Kim Yong-jin does a nice job, I think the prosthesis will be delivered without a problem. Good luck. Let's do this. Wish me luck, please. Thank you.
Can you hear me? Please go ahead with the surgery. Yes, I'll start with a surgery. This is the first time 22 implants are placed in a live surgery. The fitting is very good. GBR will be done at 1 and 3, and a tissue punch is used to make holes. So GBR will be done in the interior region with incision, and the tissue punch is used to make holes. As was mentioned during discussion session, planning is important, and the surgical stent should be fixated in proper position. On the palatal side, a lateral anchor is prepared, and the vertical anchor will be used to fix the template. And the initial drilling can be done without the punching, but according to Osstem protocol, the punching would help to satisfy the procedure, and for flapless punching is recommended, as Dr. Kyungwon Kim said. A guide barrel cannot come in contact with the guide, so a double contact is pursued using this. Anterior gingiva may be thick, and when alveolar ridge is thick, it cannot be cut off completely. So for double contact, the mucosa, overlying mucosa, is completely removed. So GBR is planned for anterior region, and horizontal incision is being made. So horizontal incision is made to raise a flap for GBR in the anterior region. So periosteum adhesion is quite severe when denture is used for a long time by a patient. In the upper jaw, the flap can be raised and the flap can be torn, so we need to be careful, and it should be elevated in a clean way. In the upper anterior region, if the bone is irregular, a tissue forceps is used to hold it, and some attached part is detached using the blade number 15C. Especially in the narrow upper anterior region, the periosteum may not be cut in a clean way. The papilla part is a little bit thick. As you can see, the periosteum, if it is not elevated cleanly, the 15C mask can be used so that the flap can be cleanly lifted. Drilling will not be a problem, and the vertical incision will be made later after placement. Please say ah. So for immediate loading, on the palatal side, the flap is not elevated at all. Only incision is made in the anterior region. Lateral anchor pin will be inserted. And anchor screws are used to create minor drill holes. Anchor pin positions can vary from company to company. In the upper jaw, palatal anchor screw would be the principal to prevent the palatal or distal pushing. So with the lateral anchor, if one side is pushed, it's not good. So the anchor is achieved by going alternately. If one side is fixed altogether, then there will be a risk of tilting. So lateral anchors are not pushed to the full depth, and they are placed with some depth left. And these four are placed first, positioned first. Through the anchors, the template is fixated, as was discussed in the discussion session. To fix the template in appropriate positions would be the most important part. To prevent slipping in the anterior region, one more bone anchor will be used. In the anterior region, bone anchor, where implant is planned to be placed. Say ah, please. The bone quality is weak, so without drilling, this is being used. Say ah, please. Positions are important. Lateral and bone anchors are used to the bone guided template is positioned. Let me start drilling. Of 3 vertical anchors and 2 lateral anchors are used to fixate the upper template. Initial drill. Number 21, initial drill. 3.5 by 11.5. A TS3 implant is planned for this. Number 23, initial drilling is being done. So initial drilling is done first, and the flattening drill is following it. Initial drill, if it doesn't go deep enough, a flattening drill can be used. A flattening drill is used to flatten the irregular bone in the posterior region. Initial drilling, and let me do the flattening drill one more time. Say ah, please. Flattening drill, because initial drill did not go into the full depth. When initial drill doesn't go full length, the subsequent drills can be cut, so flattening drill is important. After the flattening drill, the initial drill can go to the full length. The patient alveolar ridge height is okay, so in the upper jaw, the implant length is 11.5 throughout. Immediate drill will be under drilled. 4.20 implant will be placed, but in the anterior region, 3.5 by 11.5, 3.5 by 11.5 will be used. So up to 11.5 long implants, it will come in contact with the barrel. So from 5 to 5, initial drilling has been completed. And at number 11, number 3. The vertical anchor in the front is removed. And initial drilling. So initial drilling where vertical anchor was positioned. And using a wider hole in the posterior region, a 5.0 implant will be placed. Say R, please. Number 456, 4.0 will be placed. That's number 6.
Say R, please. On both sides in number 6, a wide hole is used. Up to number 6, the bone quality looks favorable. Initial drilling is done. On the apical side, I'm unsure about bone quality. So in number 6, TS4 was planned. Initial drilling is done. Flattening drill is done once again. On both sides, in number 6, the flattening drill is done. Initial drilling is done once again. Say ah. Number 6 and 7 are wide hole. That is correct. Number 6 and 7, 5.0 by 11.5 implants are planned. Say ah. Open wider. 3.5 by 11.5 millimeter drilling is done. Under drilling is done. 4.5 drill is used. The posterior area, because 5.0 the implant is going to be placed, the final drill is 4.5. It's going to be one step under drilling. So to prevent resin debris, it is better to irrigate the drill holes. So one guide template does not have metal sleeve. In order to prevent the resin going in, irrigation has been performed. TS4 implant, the 5.0 by 11.5 implant is placed in number 16. Final drill has been done up to 4.5. TS4 implant, the stability looks good. I was concerned about number 6 most. Number 7, the bone quality isn't good. I can submerge. And number 6, I thought if the bone quality, stability isn't good, I thought it may not be favorable, but it's okay. TS4, 3.5, 4.5 by 11.5. The benefit is that long implants have been used. Please give me number 26. Number 16 has been placed, and without removing implant driver, now Dr. Kim is placing on the other side. This is also used as vertical anchor. Please open wider, number 26. Final drill, 5.0. 5.0 by 11.5 TS4 implant is placed. Dr. Kim is using BA surface implant. Say on. BA surface. Dr. Kim is fully knowledgeable. Compared with the essay, there are many questions as to BA are better, but BA is much better. In my clinical cases, I've used them in an interchangeable manner. But compared with a soil or essay, BA is really outstanding. Stability is good in number 26. Hex needs to be adjusted correctly. Number 4 and 5, compare with essay. When you do BA, you can perform loading quicker. You can do it at 6 weeks. And number 5 is going to be placed. 3.5 has been done. And now implant is placed. In number 6, the hole, there are so many holes, so there was slight confusion. TS4 is being placed. This is TS3. So it says SA, but actually it is BA. The primary stability is good in number 5. 4.0 by 10 millimeter implant. So vertical position and hex is aligned. Implant hex position and placement depths need to be adjusted. Say Dr. Kim is concerned about the prosthesis that's going to go on top. Number 25, 4.0 by 11.5. The entryway is slightly tight, so say please. There's still time, so you can proceed slowly. So there's a little bit of, in this case, in order to get primary stability, in this area, you can do countersinking and 4.0 by 10 millimeter drilling. Final drilling was done only up to 3.5, 4.5 by 7 millimeter. A shorter drill is used to perform drilling here. Number 3, say The apex side, the bone is a bit hard. Say The bone quality, we were concerned whether it's going to be unfavorable, but the bone quality is very good. One guided drill. When you use one guide system, so you get a little less of tactile sense, and at times it's difficult to get that right sense. 4.0 by 11.5, normal drilling is done. In general, under drilling is not done, and today, because we're going to do immediate loading, under drilling was attempted to get better primary stability, so implants are adjusted. So it was planted deep. So no mounted driver interference is being observed. At times it's difficult to anticipate if you fixate it. The primary stability looks very good despite normal drilling. Up to number 25, implant has been positioned. Number 14. Number 4, primary stability may be very good. Number 4, 5, 6, 4, 5, 6. It's important to get the good primary stability. In number 14. Primary stability seems to be good. If there's excessive torque compression, necrosis may occur, so I'm going to widen a little bit. The final drill was done up to 3.5. 4.0 by 10 millimeter drilling is going to be done. In number 4, we're going to do it here on both sides. In number 4, 4.0 by 10 millimeter drill was used to extend the drill hole. At times, when you use one guide, no mounted driver, when you use it, if it does not go in, then, and if you change to implanted driver, then there can be gap with the guide, so the implanted position can be deviated. So you need to go in deeper with no mount driver and then change to implant driver. When in implant planning stage, if it is placed deep, the bevel area can be in the way, so you need to change to implant driver and place it here. Implant driver has not been removed and it serves as a vertical anchor. Implant is going to be placed. Primary stability seems good, so using no mount driver, implant has been positioned, and once it goes in, you can change to implant driver to prevent implant deviation. Implanted driver is used. There is more gap. There can be difference because of the guide hole size. In order to prevent the issues, bevel has been formed. In that case, fixture anchor can be used, but in order to prevent issues, in this way, surgery was performed. Dr. Lee Soo-young is going to connect the prosthesis. In number 456, the stability is over 30. In number 13, 3.5 by 11.5 implant is placed. This is an area where GBR is going to be done, so depth is adjusted. I tried to place in a zigzag manner. I tend to place one on right side and the other on left side. Number 23. No mounted driver is used up to about 80%. And on the other side, the implant is in place. As Dr. Kim has mentioned, it serves as a vertical anchor. In order to get the primary stability, once torque is applied, if guide moves, there can be deviation, but because there is sufficient lateral anchor, it looks very stable.
Number 11 site. GBR is planned for the anterior region. And the last implant in the maxilla. Actually, I need to place at number 7. Please watch the monitor. The last implant in the maxilla, and I will place implants at number 7 and 7. The vertical anchors are used at number 7. Due to bone quality, implants will be submerged at number 7. Vertical anchors are removed from number 7. Are you doing the initial drilling? Yes, at number 7. Initial drilling at number 17. Say please. The bone quality is not that bad. Say please. Irrigation, please. The final drill is a 4.5. Yes. 5.5 by 11.5. One guide drill has very good cutting power, and the heat generation is minimized with irrigation. 5.0 TS4. Diameter 5.0. The length 11.5. Number 27 first. This primary stability looks okay. Say please. No mount driver is used for the placement. Now hand wrench is used. The stability is not bad. Looking at the CT, as the patient wore denture for a long time, we were concerned about the bone quality, but it looks okay. TS3 is mostly used by many doctors, and when the bone quality is not very good, TS4 is favorable. TS4 is being used at sites with poor bone quality, and the upper part is a little bit wider. And number 17, we have a rather good bone quality. In preparing for the surgery, we were concerned, but so 12 implants are placed in the maxilla. Implant placement is completed. and 30 minutes has passed since the start of surgery, and 12 implants have been placed, and it took a little bit longer than Dr. Yong-Jung Kim as anticipated, because I didn't estimate the bone quality at number 4 and 5 properly. Usually when bone quality turns out to be better, we are happy, but due to constraint of time, it took a little bit more time for Dr. Kim. So I tend to remove this manually by hand because the patient may swallow it, and it can be an emergency if it goes into the airway. We always need to be very careful. And prevention is very important. Once it happens, it's a disaster. Okay, they're all placed nicely. So I'm going to connect the healing abutment to where loading will occur for Dr. Ki-Sung Kim, Dr. Lee, who will do the prosthesis. Yong-Jun Kim, Dr. Kim is connecting healing abutment. To prevent the lack of seating later for temporary prosthesis. And there are so many implants, and in order to check any interference in the superstructure, he is connecting healing abutments. Number 7. Are you going to connect the healing abutment? You plan to use a cover screw when bone quality is not good. TS-type implants, we tend to place them deeper. So when the top bone interferes, it interferes with the seating. So you need to check whether the top bone can pose an interference. Anterior region for GBR. Vertical incision is to be made for GBR. So let me do GBR first. I planned to use the cover screw at number 17 and 27. Number 16. And let me raise the flap. Number 13, the implant is not exposed as much as we anticipated. The result would not be as bad as we thought. The implants are not exposed, hardly exposed, and we expected very thin. If it is too thin, the labial bone plate can experience recession. So contouring augmentation would be sufficient in this case. The planned positions based on CT is used. The labial implant thread exposure is not observed, and due to the resolution of CT, it can be observed in the CT, but there's a information limitation that we can gain from CT, and they're all placed exactly as planned. Cover screw. So it was very well planned, and surgical plate was anchored accurately, and lateral anchor and vertical anchor were used for the placement. Also collagen position of a template is very important. If the template is misplaced, the placement of implant would be gravely affected. So if you have a severe palatal anesthesia, the guide would be floating. So 10 minutes prior to surgery, anesthesia should be given, and the swelling on the palatal side should be prevented. As Yong-Joon Kim said before, he gave the anesthesia around 2:10, and he was careful not to have palatal swelling, and in guided surgery, that's an important point. And Dr. Chang-Joo Park talked about accurate positioning of the template, and it proves to be really important. We are using digital power for planning, and from the surgical execution, the digital guide needs to be positioned accurately. It depends on the surgical skill of a surgeon. As Dr. Chang-Joo Park said, do not think that you need to use a guide for a complicated case. You need to use guides even for simple cases. In the past, Nobel Biocare used the anchor pins, labial anchor pins, the 3 of them, and it was discussed in the morning, and then patient by on, and if labial pins are used, the guide can be pushed labially. And the vertical pins are recommended by Osstem. AOS is being put in. The Osstem's bovine bone, and it is important to maintain the contour in the anterior region. Bone space maintenance is facilitated by the bovine bone, which is used in this GBR. Number 3 and 3, we don't need to augment the contour. Collagen membrane is placed. Collagen membrane tends to be attached to instrument when we use it in the anterior region. And I prefer to hydrate it in blood. Collagen membrane is adapted to position. Now I'll do suturing. Os guide, the collagen membrane tends to be adapted rather easily. Os guide, the collagen membrane. The releasing incision is not really necessary. The membrane itself is not fixed, and the top mucosa is used, and the releasing incision was hardly done, and it is going through adaptation. The midline is sutured first. The distal part of the flap is sutured. Didn't use the releasing incision, and the flap is very well adapted. The volume increase is not very much, so it'll be okay. So compared to what we anticipated, the implants are exactly on their places. So no, the labial bone graft volume is not very much, so it is very well adapted. Sometimes we get this question when we do GBR and when the flap is sutured. How can we do the suturing to prevent dehiscence? Tension-free flap suturing is very important. As you can see, the horizontal matrix is used to reduce the tension, and it is being sutured and adapted. Please check my earphone because I hear some noise. A strange noise is coming through my earphone. There's noise in the earphone. Horizontal matrix suture is being done to reduce tension. Suture is always difficult for me. So if you master horizontal matrix suture, actually rather than mastering so many sutures, you don't need to get used to them, all of them. As you said, the interrupted suture is good enough. Figure of 8, like a suture is being done. Now surgery is almost complete for the upper, and there's no particular procedure for the mandible, so I can go faster, but I don't know, maybe unexpected variable can happen. Bone quality is better than we expected in the upper, especially in the premolar area. The procedure actually repeated, so it took time. In the master course, so when we do live surgery in a class, many doctors find the suturing is more difficult than implant placement. So I always tell the students that it is a practice that you can go through when you suture the extraction socket. Dr. Young-Joon Kim is rather nervous because he's constrained by time. So you're listening to full mouth implant rehabilitation in a guided surgery. In a full mouth case, a guide is usually considered, but you need to go through the learning curve. Otherwise, you will encounter difficulties in a full mouth case. So if you plan to use a guided surgery, even though a guide is not really necessary in order to get used to guided surgery and they get used to the surgical kit, you need to apply it in a small case and apply it step by step in bigger cases. And in full mouth rehabilitation, there's a no reference point, and the merging is very important between the scan data. And Osstem provides a radiographic guide and denture resin marker using approach are preferred, and you need to take time to learn the procedures to have a good outcome. Fabrication of guides. CT scan is taken when a guide is mounted on a patient, and the guide is scanned separately, which is not very accurate, so you don't need to do that. Now everything is completed for the maxilla, and we will go to the mandible. So let me use the blocking the anesthesia because the time has passed a little bit. 10 implants are planned for the mandible. All regular drilling will be done because bone quality is expected to be good. So 3.5 by 10 millimeter implants for bilateral canines at number 4, 4.0 by 8.5, and number 5 is planned to have 3.5 by 8.5. Tissue punch is not used because attached gingiva is not sufficient in the mandible. And bone guide is positioned for lateral anchoring, 2 anchors in the front area and in the posterior region. The template is held and anchor screw drilling is made. Stability of a guide is very important. When we fabricate a guided template, on the model, the denture template the border should be extended sufficiently so that the template can be stable when it is held by hand like this. As you can see, we do drilling at the same time for correct positioning. If you do a fixation and drilling separately, it can easily be tilted. 4 drilling has been done and anchors are positioned alternatively. And you always consider the posterior region. Even though anchor positions are good, if it is in a location not readily accessible, it's useless. So it is buccally positioned here. And the bone quality is very good. In order to have sufficient border for the template for Edentulous patient, intraoral scanning, rather than that, impression should be taken and it should be reversed to get sufficient border. So for border extension, that's the tip. This patient, Dr. Kim copied the old denture and the impression was taken, and the reverse side is used, and the template has enough border. If you don't understand what he's talking about, in the one guide book, you will see detailed explanation of that. From a simple case to full mouth edentulous cases, clinical cases are explained in the book, and various cases are explained, especially the full mouth case, how template is to be fabricated, how to obtain data for the full mouth case. That's all described in the book. An anchor pin was inserted on the left hand side, and on the right hand side, anchor pin cannot be positioned with one drilling. Now it is inserted. The bone quality in the mandible is very good. The patient used denture. Bone quality is good. And the patient had diabetes, which is under pretty good control. So we can ignore the factor of diabetes here. Say ah, please. Number 3, in the lower anterior region, initial drilling, because it's not thick in the mandible and the bone has very good quality, and the bone chip is coming out. That means bone quality is excellent. And when you do guided surgery, initial drill is pretty much used all the time. Let me use a flattening drill. the regular holes at number 3, 4, 5. Number 3, 4, and 5. Guided templates, the regular holes. So flattening drill is used for number 3, 4, and 5. Flattening drill should be seated so that initial drill can go in without getting interfered. Bone quality looks very hard. Flattening drill is used to get rid of bone interference. Initial drill is going in there in full length. You can see bone taken out on the initial drill. It looks very hard. And the cell line irrigation is continuously performed. Say ah, please. At number 3 and 4, to avoid the buccal side, it is not easy to go to the full length with the flattening drill. Say ah, please.
It seems like a D1 bone. The bone quality is very hard.
The initial drill was used multiple times and the bone debris comes out continuously. And the bone chip is coming out continuously. In D1 bone, to facilitate the supply in the apical side, so 3.0 by 10, but I use at number 3, implant length is 11.5, which is 1.5 millimeter longer than the necessary one. Say ah, please. As the bone quality is very good, the assistant needs to provide the cell line continuously. So I planned 4.5 by 10 millimeter. And implant length is 8.5. Number 5 So you are drilling 1.5 millimeter over drilling. So it is okay because it is determined that it doesn't interfere with the anatomical structures. So I tend to drill 1.5 millimeter longer than the implant. When a template is fixated in Edentulous jaw, the template tends not to be seated fully. So I use 1.5 millimeter deeper drilling to insert implant more easily. So anatomic structures need to be understood in planning. Bilateral number 6, wide hole. In the posterior region, initial drilling is being done at number 6 and 7. The bone quality is pretty good there. The bone guide kit, you can notice the drill, which is gold coated, so you can easily distinguish the drill. A flattening drill at number 5 and 7. Everywhere the bone quality seems to be very good. Say ah, please. And the bone debris would come out with the drill, so you need to prepare multiple flattening drills. So if you do not remove the bone debris in the drill, the efficiency would go down. So if it is not a full mouth case, the debris can be removed one by one, but in this case it's a full mouth. Initial drilling, except number 37, 5.0 millimeter by 7 millimeter implants are planned. Except the number 37, the diameter will be 6 millimeters there.
The patient's level of mouth opening is okay. The drill extension is still on, but most distal area can be addressed. Because there's drill extension, it's very visible. Implant 7 millimeter can be classified as short implant. 5 by 6 or 5 by 7, it can serve its purpose, so you can trust it. You don't have to worry. 3.5 by 7 millimeter drilling is going to be done next year in Osstem meeting. In late half of this year, we're going to focus on narrow and short implant. Say ah. Because multiple implants are being placed, the patient must be experiencing difficulty. Say a little bit larger, number 37, 6 millimeter implant is placed. One guide kit, there's up to 6 millimeter drill, so you can place short implants. In the original kit, the 6 millimeter drill is not included. If you're planning to use a 6mm drill, you need to add optionally. We're almost done. Drilling is almost done. And number 3, fixation seems to be excellent. I'm going to try and do placement. Say ah. In the lower canine area, 3.5 by 10mm implant. 3.5. No mounted driver with a narrow connection. Number 3 is going to be placed. Narrow implant. The connection is different. 3.5 by 10mm implant is placed in number 3. Irrigation line is problematic, so the visibility is not so good. As we do live surgery, different circumstances occur. Say ah. No mounted driver. Is it regular? At times I make mistakes, so when placing mini implant, when you use a regular no mount driver, it is connected, but when you try to place the implant, it slips. So there's a little bit of difference in terms of connection. Yes, this is mini. Fixation seems to be good. Please give me number 4. Number 4 on both sides says 4.0 by 8.5mm implant is planned. Say ah. 4.0 by 8.5 implant in number 4. This is an implant where immediate loading is included, so fixation and depth special attention is paid. Loading is going to be done in number 4 and 6. Temporary loading, immediate loading is going to be done. In number 34, primary stability seems to be good. 3.5 by 8.5, say ah. Number 14. 4.0 by 8.5. Primary stability seems to be good. I don't think this is excessive torque. Number 4 and 4, I'm going to place number 5 and 5. So 4.5 by 8.5 are planned. Say ah. Say ah. Number 45. Say ah. Number 45. Fixation seems to be great. The bone quality seems excellent. So this is 6. 5.0 by 10 millimeter, 7 millimeter implant. So this is an implant where loading is going to be done. Number 46. The red shows that it's wide and no mount driver. Say ah. Number 6, stability seems good. It's over 30 newtons. One guided template wide hole. You need to place 5.0, so there's red mark. Say ah. Number 36. Say ah. So it's about 30 newtons. So I'm going to change to 5.5. Is stability lacking here? Yes. So if it is going to be submerged, it's not a problem, but immediate loading is planned. Osstem implants. Implant diameter is not from 5.0 to 6.0. There's 5.5 option as well. 5.5, the diameter hole is 5.8. So if the primary stability is lacking, you can use 5.5 implant. Removing implant is not easy. Let's try 5.0 by 7. Dr. Kim has a lot of experience, so he does it very smoothly. 5.5 by 6 millimeter. No, it's 7. Number 47 is going to be done. 5.5 by 7 millimeter. In the case of number 7, it was planned subcrestal. It's the same with number 6 because there's a bit of buccal dehiscence. In order to avoid it, in the case that there is distance to the canal, you can place the implant deep. Number 7. The press stability seems to be good, but it's not going to be immediately loaded. .5 by 7. 5.5 by 7. 5.0 by 6. Say ah. So I'm preparing 5.5 by 7, so it's not ready, so I'm going to look for it. In number 36, 5.5 by 7 implant is going to be placed. 5.5 by 7. Say ah. It seems much better. Primary stability is much better. Stability looks much better. Hex positioning. Hex positioning and depth control is done. Abutment for prosthesis has been fabricated using CAD/CAM, so appropriate positioning is important. 10 implants have been placed. The lateral anchors will be removed. 22 implants have been placed. Say ah. Lateral anchor is removed with the engine. And then manually it's being removed. In the case of use in nice bone quality, perhaps it's better to replace them. Initial drilling was done. As Dr. Kim has mentioned, when you use one guide in all cases, initial drilling is done. In the case of initial drill, it becomes blunt most frequently. Implants have been placed as planned. Implants have been placed in order to avoid interference with pontic base. In the lower anterior area, the ridge is slightly protrusive, so reduction was originally planned, but because of surgical time limit, it will not be done. As for implants that is not going to be immediately loaded, cover screw is used. Number 4 and 6 and 4 and 6 are going to be connected. Number 3 and 5 for cover screw are connected. Say ah. In the case of flapless surgery, if primary stability is not good, rather than healing abutment, it's better to use cover screw. In a lot of cases, after punch out, using cover screw may be a little bit not so good in the opinion of many people. Overriding tissue has been done, but even if a cover screw is used, in terms of healing, it's not going to be a problem. If you use a healing abutment, it's going to be better, but even if you use cover screw in the area, it's not going to be a problem because there may be interference with pontic base. At times, cover screw may be used, but at times when you use healing abutment, primary stability may be affected. So I use cover screw in those cases, but in terms of healing, it's not a problem. One guide, when it was first devised, the tissue punch size was narrow. There were two types, narrow one and wide one, but we have unified them into narrow one. Compared with drill, tissue punch, if it is done weak, tissue punch can be affected, but tissue punch diameter, the smaller one seems to help better in terms of healing. We're almost done. Number 4 and 6 are going to be immediately loaded. Healing abutments are connected, and as for the rest, cover screws have been used. Say ah. In the area where there were anchor screw, there's a bit of bleeding. Surgery has been done as planned. Now Dr. Lee Soo-young will take over. I'm sorry about the delay, more so than anticipated. Time has elapsed. Q&A session is up to 4:20, and the prosthodontic phase. What shall we do with Q&A session on online chat? There are a lot of questions. Can you turn on the computer, please? Dr. Kim Yong-jin is finishing up, and he still has some things to do. Let's look at some questions on online chat. There are many questions. Among the questions, for immediate hex, for immediate loading, what do you mean by aligning hex? For providing immediate prosthesis guided surgery, you need to determine hex position and vertical position. In the case of CAD/CAM abutment, at times it has orientation. Therefore, you need to align the hex so that abutment can be connected. In those cases, hex needs to be positioned buccally in order to provide immediate prosthesis. Hex positioning is done, for example. For immediate prosthesis delivery, if you have not fabricated the CAD/CAM abutment, or if you use a transfer abutment, stock transfer abutment, you do not need to align hex accurately. However, in order to provide immediate prosthesis delivery, if you have made a custom abutment, hex positioning needs to be done so that the orientation is right. So hex position is important. Another question, surgical guide implant, if it is in contact, will there be possibility of contamination? It's a question about sterilization. Dr. Kim is not up yet. The surgical guide itself, the template is not, it can be in contact with the bone. So in Osstem's one guide template, autoclaving is not done. Hexamedin is used. Dipping in hexamedin is not in perfectly line with sterilization principle. The recommendation from Osstem is 70% alcohol is used for 15 minutes. You need to soak it, and then when you adapt it in the patient, you need to use saline sufficiently in order to prevent the alcohol contact. Dr. Kim, well done. Once again, please give Dr. Kim a warm round of applause. So this was a case where I wondered this may be a tough case. So full mouth case was done last year, and I did single tooth, and rather than doing the exact surgery, I decided to be more bold and live surgery. Things don't go always as planned. Additional obstacles emerged, more so than anticipated. Bone quality was better, yes. In the case of number 16 and 17, 11.5, if there was no stability, I decided to penetrate sinus of floor and use number 13, but the primary stability was good. And buccal augmentation GBR rather than that, because the VD space was lacking, implant was to be placed deep, and that was the prosthetic plan. A lot of the implant was subcrestal, so stability was good originally, and as it was engaged with over 1 millimeter subcrestally, the stability went down on the online indicator as success. If you make incision in the upper anterior, there can be error in guide adaptation. Do you do posterior placement and then make incision? In the case of upper, you can get the mucosal support. So if you do not reflect the flap excessively and make incision, then after GBR, you need to get primary closure. So if you do reflection on crestal area and then do drilling, then you can get good results. That is the way I do it. In the case of placing implant in the posterior area first, because the anchor pin is used in the posterior area, then stability may be affected. So I tend to use my original method. Online, in the upper anterior, GBR was done, and the releasing incision was not done at all. When do you do releasing incision? As shown today, the thread exposure might have occurred. That's something that I have wondered, but bone augmentation after bone thread exposure can lead to difficulty in suturing, so I do releasing incision and do primary closure. But as shown, when you're doing contour augmentation, and if the amount of bone augmentation is not significant, rather than releasing incision, I do adaptation as was shown. Releasing incision seems good in the upper anterior, and buccal flap can be coronally advanced. Then keratinized tissue is important in pink aesthetics, and vestibule can be affected. So you need to make considerations in that end as well.
Do you have any questions? We'll open the floor from the questions. We'll entertain just one or two questions. So he placed so many implants so wonderfully. Now let's check the progress of a prosthesis. Dr. Kim, thank you for your work and continuing. The patient can chew from today, so let me connect the prosthesis. Initial stability is obtained sufficient enough. So as planned, let me provide the temporary, and I will connect the temporary on the upper first, followed by lower, and I will also check occlusion. First, E driver is used. Dr. Yong-Jung Kim connected healing abutments properly, and I'm going to remove them, and I'm going to connect custom abutments. So you're using E driver. There are, when healing abutments are removed. Number 7. This is number 7. What was the torque of number 17? Over 30 Newton centimeters. So this can interfere with the planned prosthesis, and we estimated the torque would be lower. So I thought it would be submerged with a cover screw. So for number 7, the bone width would be good. And let me do other areas first. And if a prosthesis has interference, I'm going to remove it and do the next step. E-driver during surgery and the prosthetic process. E-driver proves to be very useful. Say yes, it is very useful, especially suction please. When I remove the healing abutments, it is very useful. It would be very difficult if I use a hand driver. So they are removed of the number 6. And let me connect the custom abutment from number 6. Dr. Lee, we are running out of time, so just show us the seated condition. And 6 to 6, the stability is being obtained after delivering the prosthesis. The screw is inserted. A long one, please. Say ah. Shorter one. Number 16 is hand tightened. Open your mouth, please. So you replace it with a longer one. And is it fitting well, the maxilla? Actually, we are running out of time. The patient should take CT, and after this session, after ortho session, the final, we will look at the CT and completion of prosthesis. Custom abutments are connected 6 to 6, and I'm holding it with my hands, and they fit very well, and I'm going to work continuously, and the results will be shown later. Due to constraint of time, so I would like to invite Dr. Kim to ask a last question. That's a tremendous work. Without a problem, you place the implants wonderfully. This is a live surgery today. If the lower ridge is narrow and the sulcus is shallow, but otherwise, if you have some enough time, you can do the graft. So was it? Would you do that? Yes, I would do that if I had more time. In the upper anterior region, if you use the bovine, it would be easier. The ridge was narrow, so bovine can be used to cut it. You're right. The patient has a DM, and the patient has a pacemaker, so that is contraindicated. It's a good point. As you said, the ridge contour is not very good, and in the second surgery, the ridge augmentation will be done. Lastly, systemic condition is there. 22 implants are placed for close to 1.5 hours. Have you considered the sedation? You are not doing sedation? IV sedation is used for people with mental disorder. And 58-year-old male is the patient, but the patient had to maintain mouth opening for a long time. Yes, sedation is used from time to time, and general anesthesia is also used. Due to constraint of time, we need to conclude the session here, and let's give a warm round of applause to Dr. Kim, who did the surgery for a long time, and also Dr. Lee, who is still working downstairs. And after ortho session, we are going to look at the results of prosthesis and the CT, and we will have a review later. Thank you for your attention. Thank you.
Thank you, Dr. Kim Yong-jin, Dr. Lee Soo-young, for performing successful live surgery. I would like to express my gratitude to moderators Dr. Kim Kyung-won and Kim Ki-sung. Please give them one round of applause. So I think this is the moment you've been waiting for. Winners of online event will be announced. 300 people will win coffee coupons, and 200 people will win a sweet dessert set. Now we will do the lucky draw. Let us see the results. Congratulations to all the winners. For the winners, there's going to be a text sent, and the specific details can be seen on the notice board in the dental site. We're going to have a brief break up to 4:50. The final session will end with a lucky draw, which you have all been waiting for. So I hope you stay with us till the end. Thank you.
Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 millimeter short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS implant. Introducing the MS implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are 3 types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS Provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing the MS Kit. The MS Kit is designed exclusively for MS implants. The MS Kit is designed exclusively for MS implants, which are used in areas where the bone is narrow, such as the anterior mandibular region. With the MS Kit, you can place an MS narrow ridge, MS denture, or MS provisional implant with a quick and simple procedure. Try using the MS Kit when placing an MS implant. Have you ever experienced the pressure of reoperation because of prosthetic issues such as screw or abutment fracture? Introduce ESR Kit designed to solve a variety of prosthetic issues. In case of screw fracture occurs, the fractured screw can be removed by using ESR Kit. Connect the SR drill with the fractured screw. After making a hole for drilling on the fractured screw, turn the SR tip counterclockwise and remove the fractured screw. Also, after using the reverse drill, connect the screw holder on the fractured screw. Then, turn the screw holder counterclockwise to remove the fractured screw. In addition to screw fracture, the ESR Kit can be used for removing the fractured abutment, repairing damaged thread of implant and screw hex slip. Try ESR Kit designed to solve a variety of prosthetic issues.
Port System is a removable overdenture solution which comes with various specifications at low height port cap. Port System requires only 3 mm of vertical space, and it is easily applicable to patients with narrow vertical dimensions of occlusion. The male is made of nylon, offers a variety of configurations from 6 Newton to 22 Newton, enables clinicians to respond to each patient's case. Also, it is suitable for long-term use. Port System, tailor-designed overdenture solution for clinicians.
Introducing the N1 Portable X-ray, delivering high-quality imaging, while being extremely easy and simple to use. A good portable X-ray should produce clear images. At 70 kV and 3 mA, the N1 produces clear standard X-ray images. Clear images relieve the clinician's stress during the diagnosis process. A good portable X-ray should be easy to operate. The N1 is light at only 1.61 kg, which is 30% lighter than a camera-type device. Also, it has a gun-type design which is easy to operate with one hand. This ensures easy alignment and high accuracy when taking images. A good portable X-ray should have a long-lasting battery. With 15% improved battery performance, the N1 lasts for a week on a single charge, eliminating problems with other wireless X-ray units. The N1 reduces the inconvenience of a continuous charging, which helps improve clinical efficiency. The N1 is easy to use and produces clear images. Introducing the IO1020, which is a highly durable oral sensor that produces clear images. The IO1020 produces clear images with resolution of up to 20 micrometers. The IO1020 helps you identify periapical lesions around the roots of teeth, the interdental space, the pulp, and the periodontal ligament much more clearly. The IO1020's cable is designed at a 0-degree angle to prevent the cable from breaking, and the impact-resistant bumper improves durability. The IO20 model is for adults, while the IO10 model is for children. choosing the right size that fits the patient's mouth can help reduce discomfort. Try using the highly durable IO1020 oral sensor for clearer images.
With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically, which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have two separate buttons, each for focusing and image taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neck line is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth when inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera Snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients.
Osstem Meeting 2023 Seoul. We will begin the final session. Before we begin, I would like to notice you of the event that we all look forward to. There's going to be a prize draw after all sessions have ended. Offline audience, those of you here with us, please stay with us until we have the draw. Before that, there's also an online event for 3 people. Osstem mobile card will be given for 2 people. Galaxy Watch S5 Pro, and for one person, Galaxy S23 will be given. This event is currently ongoing in Dental site, and if you click on the pop-up, then you'll be able to try your chance. You need to log in to be able to participate. The offline audience can participate by using their mobile phone. When you do this, you need to make sure the mobile phone is in vertical orientation. The winners will be announced after all sessions have ended. Now we will continue on with the final session of Osstem Meeting 2023 Seoul. This is the first in Osstem Meeting. It's a session on orthodontics. So let me introduce the final moderator, Dr. Hwang Chung-Ju of Twin Dental Clinic. Dr. Hwang Chung-Ju has graduated from Yonsei College of Dentistry. He is a director of Institute of Craniofacial College of Dentistry at Yonsei University. He is a president of Korean Association of Orthodontists. He is a director of Dental Research Institute at Osstem Implant, and he is orthodontic director. Please welcome Dr. Hwang with warm round of applause. I am Dr. Hwang Chung-Ju. Nice to meet you. Osstem Meeting is an academic event that everyone across the world focuses on, and I'm honored to be here as a moderator. And now we are facing the final session of Osstem Meeting 2023. So, stable occlusion is provided for full arch edentulous patients, and we provided different treatment. As shown in the title, dividing orthodontic devices, it can be fixed devices. And now, this is also receiving limelight. I'm sure you're interested in this topic. The first topic is goodbye bracket, simple diagnostic protocol for clear aligner treatment, and Dr. Lee Jong-Guk is going to talk about the protocol that can be used for clear aligners. Please welcome Dr. Lee with warm round of applause. I am Dr. Lee Jong-Guk of Apgujeong Oracle Dental Clinic. I'm honored to be here at this prestigious event. The contents of the day is about clear aligners, and I'm going to talk about diagnosis. In terms of diagnosis, I cannot address everything within 30 minutes, and diagnosis can be construed as something that is not interesting. Clear aligners can be work, and I can do a good job. And if you leave it up to clear aligner, you may think that it may work. From beginner's perspective, what is more important is to do case selection appropriately, and we need to think about the guideline as to what should be considered. And I want to talk about this topic. I'm going to talk about the vision briefly, and I'm going to talk about the case selection for clear aligners and what kind of diagnostic steps are involved. What is important here is that we make a request to the manufacturer, and I'm going to talk about what should be included in the order. A friend living in New York texted me once. The text was received the year before last year in winter, so I did not really talk with this friend frequently. This was when COVID was really bad. And we exchanged different information, and the person was interested in clear aligners. And the person wanted to receive orthodontic treatment. My friend asked me to do diagnosis in Korea, and in fall that my friend came. The chief complaint is that the number 42, the intrusion was bothering the patient. When we do diagnosis, detailed diagnosis is done, and skeletally, class 3 malocclusion was observed. The occlusion was not perfect. The chief complaint was number 42. There may be different treatment options. The patient was living in the U.S. and the amount of time that the patient could stay in Korea was uncertain, so clear aligner was chosen with number 42. In order to correct that, I thought that clear aligners were an excellent option. So I made clear aligners worth of 6 months and then had the patient return after 6 months. So after 6 months, my friend texted me again, very happy. So you can see the spelling of Korean is wrong. So much so because the patient was happy. This was not remote treatment. When we compare the original photo within 6 months, a lot of improvements have been gained. I'm going to talk about the vision. Just because we have seen patient less, it does not mean good, but with fewer patient visits, you can get good results here as shown. I've just met with my friend 2 times upon the initial visit and delivery, and then I did not meet my friend. This may be a lucky case, but in the end, if we continue on with this vision, then the clear market potential can really shine through. The patient just came twice and there were no emergent cases. It will be really beneficial for both the surgeon and the patient. So I want to share with you certain cases. In terms of clear aligner, not many people find it really familiar. What do you write in the order request? All presentation material should be in English, I was told, so I wrote in English. These days we click, but with no information, a lot of people just write clear aligner. But this seems kind of off. I'm a orthodontist, but if you are to provide crown in number 11, it's the same as just writing 11 crown. It may be baffling because a lot of details are missing. I am unsure as to what should be written in terms of crown. When you do clear aligner treatment, you need to provide minimum information, and I want to talk about what should be included. Clear aligners are often compared with autopilot mode, and diagnosis and treatment is done automatically, thinks many people. But even when we use autopilot mode, you need to have driver's license. And when you use clear aligner, you need to have minimum orthodontic knowledge. And I want to talk about what you need to know within short period of time frame. In terms of case selection, if you're unfamiliar with clear aligner, then these 2 questions come to mind. What kind of cases can I treat with clear aligners, and what if the treatment goes wrong? I think this is the biggest problem. Let's take a closer look. If we can select cases where clear aligners will work, then it will be great. And as to what happens if things go wrong, we need to make preventative steps. And when there's a problem, we need to do troubleshooting, and we need to study that. Today, I'm going to talk about case selection. In terms of difficulty, it cannot be divided largely as shown. In terms of clear aligner, We're not going to do an extensive case. If you're beginning clear aligner, you cannot use clear aligner in class 3 with facial asymmetry. Although there's a slight imbalance, you may think that whether it's going to be okay to use clear aligners. First, you need to determine whether you're going to move posterior teeth, and it has a lot of influence as a level of difficulty for clear aligners. And in most cases, we're going to focus on the anterior case. If anterior adjustment leads to good result, if you're not going to move the molars and address the anteriors only, then I think clear aligners can provide predictable results. But if you're going to engage molars, then you need to study further and you need to check various factors. And you need to consider the level of malocclusion. I cannot say the 4 millimeter for sure, but if the crowding is about 3 to 4 millimeters, then you can get good predictable results. The crowding amount, how do you determine that? I'm sure you have heard while you were studying, when we are focusing on 6 anteriors, you measure the sum of it, and you need to think where treatment is going to be done. If the purple line is going to be adjusted, you need to measure the purple line and the amount of 6 anterior length. The crowding is 3.24. If we're not going to straighten to purple line, but straighten by the red line if the overjet is significant, if we're going to improve to the red line, then the treatment plan can change, because crowding level and treatment amount, it becomes different. What I want to accentuate is that in simple crowding cases, depending on how you're going to improve it, determines the level of difficulty. And central incisors play an immense role. So where we're going to position the central incisors plays a very significant role. Within oral cavity, teeth need to move. You need to rotate it. There can be tipping, intrusion, and extrusion. There are different teeth movement. Among the different movement, there are movements that can be achieved really easily with clear aligners and things that don't. And maybe we can use digital dentistry, and it feels as if everything is going to work out, but the way it plays out shows different tendencies. And I'm going to show you when it really works. This is a literature published in AJO, and regarding teeth movement, this is the most prominent literature. It says here that where there's spacing, we need to close off space, but with clear aligners, you can do a good job, but extrusion does not really work. And when the teeth are round, not lateral incisor, in the case of canine, rotation is difficult to achieve. This is a more recent literature, and it says here that compared with the plan and the result, the realization rate is about 50%. It may be buccolingual movement. In the case of anterior, it can be labiolingual movement. The predictability is good, but rotation is difficult to achieve. Such studies have been done, and based on my experience, I have divided the different levels of difficulty. There may be different considerations. If we look at the overall level of difficulty, it can be divided into 4 groups. Level 1, relapse case, spacing, and there can be a little bit of problem. And then in such cases, you may be able to get predictable result. There may be even bigger spacing, and there may be cases involving rotation. Level 1 and 2. If you're a beginner, then it's a good place to start. And as mentioned earlier, the big premise is that if based on the premise that there's no active movement of a molar, then you can get the predictable results with clear aligners. Conversely, if you need to actively move a molar and treating open bite, deep bite, and extraction cases, it may be difficult to apply. People say that the clear aligners are good in open bite and deep bite, but there are many factors to consider, so you cannot say with conviction that it really works, and you really need to study. There may be trial and error. So in terms of level 1, they are highly predictable. Officially, it's predictable. Not maybe in every case, but in most cases. I think this case is a good example of a clear aligner case. If there's need for slight adjustment, you can do it nicely with clear aligner. If there is spacing, you can improve the situation with clear aligner. When there is spacing in the anterior teeth, in most cases, within a short period of time, improvements can be observed. What is important here is that if there is little spacing, when you apply force, because the spacing is limited, it closes off. But if the spacing is more significant, in order to do this, you need to pay a lot of attention because this kind of movement can occur. Because of this, anterior case, if there's space of over 2 millimeter, when you come across a case where clear aligners were used successfully, it looks like this. The root does not really move, and only the crown has moved. So the more the space, the root movement is required. The root movement with clear aligner is visible, but it takes a long time, and there are many factors to consider. So just don't think of it as easy. You can apply it up to 1 to 2 millimeter. In the case where there is a spacing, it's slightly intruded. If there is a spacing in the upper, we need to also consider antagonist relations. Contact with antagonist occurs like this. If you do not consider this, relapse can occur and tooth movement may be limited. You need to consider these factors. Another point is that clear aligners may be able to provide more predictable results in these cases. When there's a case where rotation is limited and anterior posterior improvement may be needed. Regardless of the modality you use, you can get the improvements in predictable results in most cases. These cases, it's the same for the upper. Depending on the severity, the treatment period may vary, but you can get the predictable result. In the case of rotation cases, 5-6 years ago, I found it very hard, but as of late, there are very good materials and excellent attachments. They're shaped like handles made of resin, and with that, rotation can be solved. Based on different individuals, the treatment time may vary, but overall, you can get good results. In the case of lower, the teeth size are very small. Rotation control is very difficult. I still think that, but with time, when you use attachment, then you can make the right space and get the result you have desired. I am not just saying that this is the only case that is fit, but among different cases, you can get the good and better improvements using clear aligners in level 1 and 2. You can attempt clear aligners in those cases, and once you get used to it, you'll be able to get the better results with more extensive cases as well. Level 3 and 4. Dr. Ji-Young is going to address them. I always think that what is most difficult is cooperation. Patient cooperation is most important regardless of attachment. And if the patient does not wear the appliance, it doesn't matter if the patient does not start. But if the patient continues to wear for 2 to 3 months and then stops wearing them, then it not only does relapse, but there can be movement in different directions. So patient cooperation is crucial at times. I think there can be fractures, loss, or I think patient cooperation is most difficult. The patient cooperation is the big premise. Second is about diagnostic protocol. Diagnostic protocol for orthodontic treatment. I find it extremely difficult, and I continue to strive to study. But if you are set on studying orthodontics, people start off with studying diagnosis, and when you dive in, then people steps away from orthodontics because it's difficult. Some people give up. It's very difficult, and then how can we start off? Under a grand theme, let me briefly explain. In most cases, cast situation is evaluated. Teeth alignment is on top of your mind. They show you the cast. Shall I do extraction, non-extraction? What should I do? So it's very difficult to answer by just looking at cast because unless you look at patient profile, it's very difficult to make a diagnosis of the teeth. The teeth alignment is not the only thing that we should look at. We need to look at the profile. This is a prominent case. These two cases, when you take a look, they seem like similar cases. The teeth alignment are similar. However, if you look at patient profile, they show completely different profile. The patient on the left, the profile is fine, and the patient on the right, there's a bit of protrusion. Yes, we need to evaluate the SEF, and if you do that, you'll be able to understand better. But as a dentist, as a general dentist, not just a specific specialized diagnosis, you'll be able to tell the difference. What is more important is that the patient's perception of their lips. If it is okay for the patient, although there is protrusion, then it's fine. Then you will not be able to force the patient into orthodontic treatment. Patient's perception of the profile is very important. It looks like a very similar situation, but the profile is completely different, and hence the treatment plan can vary. At the center of treatment plan is whether into the central incisor, regardless of upper or lower. The anterior area is very important. We do not pull the lip using attachments. It's the anterior teeth movement that lead to profile changes, and that is something that we need to bear in mind. The upper central incisors are the key. The order of diagnosis, there can be different steps involved, and everyone has different order. And in my opinion, this is the order. People think of number 3 first. How should we do alignment? We need to look at patient's profile first and determine whether or not the patient profile is going to be changed, and making orthodontic diagnosis. This will be an important criteria, and what we can change in terms of patient profile is central incisor position, whether we're going to change it or maintain it is very important in orthodontic diagnosis. Regarding central incisors, diagnosis is based. There are many literature on this end. In the past, lower central incisors were used as criteria. As of late, upper central incisor positions have been considered very important in terms of aesthetics. This is used as the standard for coming up with orthodontic diagnosis. The most prominent literature is from last year, and there are different numbers. If you look at the order, if you come across this complicated case, then the factors that we need to consider include: first, you need to determine the position of upper central incisor. You need to study on this. Level of exposure or protrusion needs to be considered in the overall picture, and you need to determine the position of upper central incisor. Upper central incisor, once it's positioned, the lateral incisor and canines are positioned. Yes, you may do extraction, and next, occlusal table is determined. If you're going to adjust the posterior area, more superior, then the mandible can go through auto rotation. If that is good, the direction, then you can form your treatment plan accordingly. And finally, lower central incisor plans are formed. What comes first is not really important, but step by step, if you have a set of protocol in doing orthodontic diagnosis, it can be of help. And doing clear aligners, it's very difficult to change the occlusal table, so you need to find the position of the upper central incisor and then lower central incisor. Let me give you an example. This looks a bit rickety and the lips are slightly protruded. The different evaluations are done. The level of protrusion class 1 to 3, these factors are considered. In the case of this patient, it looks off, and the topic of the day is edentulous patient. Let's assume that the patient does not have tooth, and if we can position the tooth the way we want, then lower can be determined first. It's not to say that upper should be determined first. So once the central incisors are set, then we can find the right position of the entire treatment accordingly. The rest of the teeth are going to be aligned like this. Alignment of this teeth, can we do this within this tight oral cavity? Without extraction, can we secure space? You can secure space through IPR, arch expansion, or molar distalization. Even if you do all three, and if there's lack of space, extraction can be done, but normally non-extraction is preferred. Bolton ratio and asymmetry and different factors are considered, but I just want to look at the big picture. Overall orthodontic diagnosis. If we think of clear aligners, then this is the order that is recommended. First, which line is going to be used? Are you going to use the purple line, or is your goal the red line? Which is your goal? You need to determine that first. And at the center of that is central incisor, be it upper or lower. After that, you need to consider whether you're going to change the molar. Class 2 occlusion, let's say, are you going to make it class 1? Or if the patient has been using class 2 occlusion without a problem, and if occlusion is fine, then the determination is based entirely upon the dentist. And then you need to determine IPR amount, where and when, and whether arch expansion is going to be done as you go through the diagnostic steps. So you need to determine how much improvement you're going to do. If there's crowding, if you send this information and ask for clear aligner, the people who make clear aligners, there's no information. You need to improve using purple line or the red line. If the goal is red line, this kind of movement is necessary. If blue line is the goal, this kind of treatment is necessary. The amount of IPR changes, and perhaps extraction may be necessary, and molar distalization may be necessary. Depending on the line you're going to use as your goal, the treatment plan may vary. And in this case, if the patient finds the profile fine, if the upper and lower central incisors are fine, number 31 can be used as a criteria for improvement. These basic information is very important and should be included when we make a request for clear aligner fabrication. After that, how are you going to address the molars? Let me give you an example. This patient came to my dental clinic. It looks slightly protruded and the teeth are not aligned. Perhaps you can say intrude the teeth slightly. Ideal setup is provided, molar rotation. This may be an excellent treatment plan, but if molar movement is involved, then the level of difficulty and treatment time needs to be considered. If you just want to move anterior teeth, this can be an option too. There's no right answer. You can just ask the manufacturer to focus on anterior and say that molar movement is unnecessary. Then the treatment period is reduced. The clear aligner treatment should be short. If it becomes longer, then there can be more issues. So rather than thinking of it as a golden ticket, we need to make the treatment goal very simple in order to get good result. In the case of this kind of patient, you can see that other dental clinic has refused to provide clear aligner analysis is done, and in order to address this crowding, what kind of treatment options can we consider? In the end, orthodontic treatment is about securing space. You can use IPR or do molar distalization, and if you're just using IPR, you can get improvement like this. And in the case of molar, and this may not be feasible. Moving this doing molar distalization to secure space is also an option. If you look at SEF, the patient has horizontal facial pattern, mandible plane is very horizontal. So there's people with long face and short face. People with long face, they don't move anteriorly nor distally. So I've tried distalization and IPR. The amount of distalization is not significant. You need to consider this as we provide with treatment if the patient is younger. In number 23, the patient came in because of the crowding here. You can do IPR significantly. If you look at posterior occlusion, it's class 2. Then you can do molar distalization to make a space in number 23 to improve the alignment. The treatment period may be longer, but you can get good results using clear aligner. Molar distalization, whether we're going to do it or not, needs to be clearly indicated in the order request. IPR amount, the manufacturer always says, in the case of magical liner from Osstem, you can make a request. You can ask whether non-extraction can be done. You can get simulation, and that is provided for free. And even if you do not decide to proceed, then if you're curious, you can make a request and then think about it. IPR amount needs to be considered. At arch expansion, we can create a lot of space, and we can align the rickety teeth nice and like this, crooked teeth like this. Arch expansion, you do not need to make a request by certain millimeter. If the molar is labially tilted, you can ask for improvement. Lingually tilted, then you can get improvements, and following different steps, so you can start and then you add more information. Then you can get better treatment. What I want to mention lastly is that the upper incisors need to be considered. Whether or not you're going to move the molars need to be considered. You need to consider the amount of IPR and arch expansion. This can be considered ahead, or you can do it later. This order paper, everything has become digitalized, so with a certain click, you can make the order. You need to include the CC, chief complaint, at all times. Even in most famous clear aligner manufacturer, they do not ask about chief complaint. As manufacturer, they don't ask about it. We need to write the chief complaint, and if you can write whether it's non-extraction or extraction case, if you can write ahead, that's great. If not, you can simulate it first. Next, whether or not profile change is going to be done needs to be indicated. Upper incisor position can be determined by yourself or together. Also, if you're going to actively do molar distalization, indicate that. If you do not want molar movement, you can write about that as well. In the case of IPR and expansion, you can determine, or after simulation with the company, you can make a request to increase or reduce the amount of IPR and expansion. There are other factors to consider, and many considerations can be made. These 6 factors can be included in the order request. This is what I've prepared, and albeit in a short time period, I hope I have provided meaningful information. Thank you for listening. Thank you, Dr. Lee. Thank you for your wonderful insight as to make how to make the right diagnosis. Please give Dr. Lee a warm round of applause. I'm sure you have many questions, but we're going to have Q&A session after presentation by the second speaker.
The second speaker is Dr. Taekyung-ji. He's going to talk about, as Dr. Lee talked about, the difficulty of treatment was classified into different levels, and he's going to talk about treatment of deep bite. As you know, it's not easy to treat, and it is considered level 4 among clear aligner. How can we treat it with a clear aligner? Let's welcome him with a big round of applause. Good afternoon. I am Taekyung-ji from Seoul, my orthodontic clinic. This is Sunday, and for 30 seconds, let's hear some exciting music. So did you enjoy it? Just briefly, because you shouldn't fall asleep. And this is about the orthodontics. Dr. Lee, I heard that you are a senior. We graduated from same school. And I'm going to talk about full mouth rehabilitation and digital approach, an approach to treat deep bite, how to treat deep bite, over-erupted anterior teeth, upper and lower. So there are teeth problems, and mandibular angle is small in case of short face, especially the lower third of the face. That is the causes of deep bite today. I'm going to talk about these three. As was mentioned, the conventional type of bracket treatment can be used, and there's some difficulty using it to fix deep bite. And how can we improve the deep bite with the clear aligner? The strategy of treatment will be shared, and I will review cases. Magic Align versus Invisalign, the representative clear aligners. First, the conventional bracket ortho treatment can be used for deep bite correction, but there's a limitations to it. Regardless of whether you're doing it well or not, it is hard to attach appliance in the mandible, and the time can be lengthened, and that it can be attached at the back, and it requires using another device. Anterior bite plate can be used, and this is a treatment cases, so as indicated here, and extrusion of lower posterior region can be induced with bite turbo. For intrusion, the arch wire is applied. It is not easy, very difficult. And these days, mini screws are used to pull up or pull down anterior region of upper or lower. And all these need to be considered clinically. And unintended trouble is given to patients. But these are required for the treatment, and we are going to talk about the plastic piece to treat deep bite. A very simple case. 11-year-old male, and the chief complaint is deep bite. And they're canted, and there's mild crowding in the mandible, and the deep bite is quite severe. Chin prominence is observed, and skeletally deep bite is observed in panorama. So diagnosis and clinical goals are set. As previously mentioned, the digital orthodontic treatment is provided using clear aligner, and 3D simulation can be received. Have a look at it. What is important is tooth movements like this. Can it happen in real life? And you need to understand the mechanics of the teeth movement to do the communication with a set of designers. 20 aligners over 8 months. The anterior deep bite improved, and the spacing is closed, and mild crowding is resolved. It took 8 months. So conventional bracket treatment, can it achieve this outcome within this period of time? It is questionable. And I will talk about over the next 30 minutes. I'm not going to tell you that clear aligner is the best. And for a relapse case or mild crowding and other treatment, it can be done with a clear aligner. That's what I'm trying to say. 20 steps over 8 months before and after treatment. So clear aligners are used to treat a deep bite and biomechanics, the strategy needs to be looked at. The maxilla versus mandible. In the textbook, you learn the curve of Spee. The denture is sagittally segmented, and the curve of Spee is this. If it is deep, it can lead to a deeper bite. How to flatten the deep bite is the goal of the treatment. As you get older, curve of Spee would get deeper. In the posterior and anterior regions of the mandible would form a two-step occlusal plane. So lingual inclusion of inclination of the teeth, it is difficult to treat it. So we can have three strategies for that. First, lower anterior region can be intruded. It is called absolute intrusion, and molars and premolars can be extruded, and anterior teeth can be flared. It's not really intrusion, but relative intrusion is made. So relative intrusion is the expression used. So curve of Spee can be corrected with these three strategies. And let's have a look at a video. In actual patients, we get the 3D simulation video, and we are going to look at it with patient case. Bracket, other than bracket, what other things that need to be installed in the mouth other than appliances? And the three things will be discussed. Attachments. Attachment to teeth is not a bracket, but something is attached to teeth. And force-driven system. Aligners. Pressure spots would be controlled. You saw before, ABP, anterior bite plate, which is by the ramp, the structure can be used. Briefly, if you look at here, attachment is working as handles, but it is actively applying pressure force, and it is inducing extrusion of lower posterior region. And the molars are controlled, so intrusion of mandible is induced. Aligner can be different depending on the physical property, but it can improve further. Pressure spots are used, so tooth axis along with the parallel to the tooth axis, the intrusion force is applied. ABP is working using bite ramps, and many manufacturers are having this kind of appliances. Let me show you cases. Deep bite case, and some important points will be discussed. If you look at here, it is severely crowded, and there's a deep bite, and number 31. It is that a TFO is suspected, and that's why it led to this. In the upper anterior region, it's very narrow, and it is long. Size balance is problematic between the upper and lower jaws. In the ortho area, it is called the Bolton ratio. The same goes for the posterior region. Likewise, a low angle, and skeletally, the deep bite is observed. Diagnosis and the severe crowding and the deep bite, and the upper anterior and the lower anterior have big size discrepancies. It is not frequently used, but number 31 extraction is considered. As was mentioned, the manufacturers would hear our treatment plan and they send us the treatment plan, whether it is feasible or not, in coming up with the treatment plan without extraction. So this is the treatment plan, and through the digital setup, teeth sizes can be obtained, and Bolton ratio. The calculation is indicated here. Usually, the 77%, 77.2% is made up by the anterior region, but here it's 86%. It is definitely clear cut, but IPR, it is about 0.5 millimeter reduction, and if it is over 86%, the lower anterior extraction can be considered, but the problem is there. It's about the symphysis, and we need to discuss the necessity of the treatment and share the necessity with the patients. Non-extraction simulation. And there is a lot of movement in the lower posterior region and the lower anterior region. IPR amount is quite high, so this is hard to implement, and it would take a long time to achieve it. And the extraction plan, and this is the treatment plan we receive. According to the plan, a 3D simulation is also sent to us. The tooth movement process is simplified, and at a glance, I don't know whether it is just for me, but it looks clear. And number one extraction was decided, and the symphysis part is explained to the patient with the necessity of treatment. Attachments are attached, and the first appliance was used, and over 10 months. In the upper and lower anterior region, the vertical occlusion is being opened, so the alignment between upper and lower anterior region is achieved, and 30 for over 1 year and 4 months, considering the occlusion of the patient, it is not a very long time that is taken. The before and after treatment, upper and lower anterior region, 38 steps, alignment is achieved, and the bite is pretty much resolved. Curve of speed in the mandible has been reviewed. Next, let's look at maxilla, the upper anterior region. The orthodontist focus on functions for lower anterior, but for upper incisors, a smile arc exposure is considered, which is important for aesthetics. The TFO and others, the functional problems can also occur in this region. As you saw before, depending on the position of the upper anterior, there are these variety of situations, and the leveling of the upper incisors. What is the treatment strategy for that? The first one is usually because of anterior upper teeth, they are lingually inclined, and they need to be labially induced. So we need to look at anatomic structure as we look at the case, and can it work like this or not? and have a look at a case. In this case, on the left hand side, class 2, it's a division 2. The upper anterior region is lingually inclined and a deep bite. ODI, and if you look at the numbers, deep bite is observed in terms of a skeleton, and then the upper incisor position. If you look at here, intrusion should be made, direct intrusion. The cortical plate is in contact with the root, so it can be damaged. So regarding the treatment strategy, the labial flaring should be achieved, as you saw before. The diagnosis and the clinical goals, according to the video, whether the teeth would be moved like this. And let's look at a case. The first appliance was delivered and it was very deep, so the lower teeth are not visible, but over 6 months lower teeth began to be shown, and upper incisors began to flare, and the rotation should be resolved and the space is secured for that activity. And regarding what has been done and the progress system is something I want to talk about. I talked about the appliance and the bite ramps, which acts like a bite block. And on the left hand side, the patient had class 2, so class 2 elastics were used. Class 2 elastics, when it comes to deep bite, it has some effects. The posterior extrusion can be induced to flatten. And for class 1, elastic can be partially used. The bracket appliance is not there, so there's no structure where elastic can be connected. So precision cut or a button cutout need to be designed. Upper incisors need to be flared, and we need to secure the space, and the button was attached like a bracket. A button is attached to resolve the rotation, and the rotation cannot be resolved with a liner alone, so additional device was used. And now lucky draw. Over 16 months, I will ask a quiz later. 38 appliances were used over 16 months, and the treatment went well. It was not an easy case. Patient cooperation is not a choice, but it's a must that we have to gain. And over 16 months, 38 steps were used to resolve a deep bite, and occlusal plane flatness is also resolved, and crowding is properly resolved. Class 2 is addressed. Now we need to look at the last topic, case review, Magic Align versus Invisalign. I want to tell you briefly which one is better. I'm not trying to say one is better than over. And there are many clear aligners, and as I said before, there are some limitations in terms of patients, and the scope of treatment has broadened actually, and Magic Align case and Invisalign case will be introduced. They are both males, so with a similar age, and crowding, deep bite were similar in these two patients. deep bite is quite severe, and crowding is severe as well. And if you look at the severity, crowding in the lower, in and out, is a little bit easier. And curve of speed, the depth of curve of speed, the lower photo looks more challenging. So in terms of the difficulty of treatment, it looks similar between these two. So Magic Align, Invisalign were provided for the treatment for the upper and lower case. First, the Invisalign, a 22-year-old male. Crowding and anterior deep bite were the chief complaints. As you saw at the beginning, the deep bite is severe and severe crowding. And there is cantillation in the lower anterior region. Diagnosis and the clinical goals were set. And the manufacturer is providing the simulation of teeth movement. As I said before, can we achieve a tooth movement like this? This is just a 3D simulation. But is it realistic or not? That is something to be determined by a dentist. A bite ramp is used, which is similar to ABP. The structure or device is used. Over 16 months, 57 appliances were applied. Class 2 elastic was also used. Before and after treatment, a severe deep bite was resolved, and crowding is quite resolved. Occlusal plane before and after, a stable teeth alignment has been achieved. Magic Align case. Compared to the previous patient, this patient is 2 months older, male, and he had the same chief complaints. The anterior crowding is severe and deep bite is severe. This is the last case. Patient with a deep bite has some characteristics: low angle, over erupted anteriors, and chin prominence is severe. In such cases, we don't use extraction or the treatment. If we extract teeth, the bite would go deeper and curve of speed would become deeper. So through treatment, if we extrude the posterior region, the clockwise rotation can be induced in the mandible, and overbite depth and length can be improved in the mandible. So diagnosis and clinical goals were established. So once again, this is the simulation of treatment plan. And can we achieve such teeth movements? This cannot be achieved at one step. Setup designers and dentists need to communicate to modify the treatment plan, and after the plan is approved, the aligners would be delivered. Attachments are put on, and IPR was done, and they began to live with the appliances. The bite ramp was attached. Over 11 months, 22 appliances were used, and arches were expanded, and the leveling has been achieved. The upper and lower anterior crowding has been resolved before and after the treatment. Over 11 months, 22 steps. So if you go back to the beginning, the bracket, if bracket was used, bracket can achieve good results, but within 11 months, can it achieve this kind of outcome? It is questionable. So today, I showed you several cases, and the previous speaker talked about diagnosis, and I showed you the cases, and I compared the Magic Align and the Invisalign. I'm not saying that which one is better over the other. Clear aligner treatment. There's a vision, value, and possibility with the treatment. That's something I wanted to share with you. So this is the last one. This is a question quiz. I'm not an organizer, but if you can give those who answer the question, please give the gift to them. Hero is the hint. Who is this? Batman. Please give him a gift. Who is this? Iron Man. So you remember all of them? Third, Superman. The sound is not working. Yes, it's Superman. This is the last one. The biggest gift will go to you. My second son. And he wears the costume and he plays with his friends, and I take photos of him. And when he is in that costume, he is doing some virtual play. He saves the people who is drowning, and ultimately I want to say that a hero, definition of a hero is not someone with good degrees and a lot of money, but who has a charming story that can make people moved and excited. And this is a very academic definition. And these heroes can make a heartwarming world that can motivate the people to live. So throughout the week, you have suffered quite a lot, and thank you very much for coming to this seminar on Sunday until 5 to 6 p.m. And you are the real heroes who are making very attractive, charming story. And it's my honor to be given this opportunity to make a presentation, and clear aligners I hope will be used by you in your treatment. Thank you. Thank you very much.
There are a couple of questions. First, Dr. E, there's a question. When you make a diagnosis, you said you use upper central incisor. In the case of fixed appliance, there's not a lot of movement. In the case of removable appliance like clear aligner, the amount of movement is limited. And do you still use upper central incisor as a criteria? Whether to use lower or upper central incisor, this is not definitely set. Upper central incisor is receiving a lot of attention because we can move away from the restrictions of tooth movement aesthetically. And in talking about clear aligners, there are clear limitations and movement amount. And I am not saying that we need to focus on upper central incisor only. Sometimes you need to use the lower. And following the upper, the lower may be determined, and vice versa. You need to consider both factors, but if you think of the upper central incisor first, aesthetically, you may get a good result. Dr. Ji, there's a question for you as well.
To address deep bite, the curve of speed should be addressed, and expanding curvoscopy is not very difficult using conventional method, and if it doesn't work, occlusal matching is difficult. How is it addressed by clear aligners? In an ideal world, if occlusion is ideally made, when a patient with a deep bite in the planning stage, a reverse curve, precise nighttime or other things are used. So in the designing stage, as you saw in the 3D simulation, the ultimate teeth positions, if you look at them, it looks like open bite, and excessive design is often used. Thank you for the answer, and let's go to question for Dr. Lee.
So clear aligners are done by many, and I want to try. And if you're a beginner, what should you do, and what kind of contact, and how can I contact the lab technician? Can you provide a little bit of explanation? The biggest dilemma is whether you can proceed with this case, and I've mentioned it. And if you're troubled, then you can use Osstem's magical liner, and you can get a free simulation, and there are different steps. If you make a request, then for free you can get help as to how many steps are required and how much it costs. If the treatment becomes elongated, then it costs more, and or the treatment time can be shorter than anticipated. You can make a request ahead, and then if you add from there, then it'll be a soft landing for doing clear aligner treatment. Dr. G?
So a plan is made and simulation is conducted during treatment. Not everything goes as planned. So what do you do? Do you make appliances again? When things don't go as planned, do you fabricate the appliances from the start? And we need to understand, analyze the reasons why it didn't go well. So the conclusion, if it is not enough traction, the diagnosis and the goals need to be set again from the start. And when the patient is not compliant, or if the treatment design was not correct, that should be analyzed first. Do you have any questions from the floor? We can entertain a couple of questions. No questions? Professor Kim? I don't do ortho treatment, and I did a couple of clear aligner cases, but I don't do it anymore. And in the past, they said the appliances should be changed every week, and now they say should be changed every 2 weeks. Magic Align and Invisalign. What is the technical difference between those two? So each of you can answer the question.
So it may differ depending on manufacturer. You can have a patient use for a week to 10 days. A magical liner, you replace the appliance every 2 weeks, and it may depend on tooth movement. They say it's 2 weeks, but in the case of elementary school kids, they use it for a week. Nothing is set in stone, and this is not the major difference. Depending on different circumstances, orthodontists may make choices.
I talked about the cases comparing line and magic line. The technical differences may be the manufacturer's secret, but from a surgeon's point of view, overall, a clear aligner, when we use the clear aligners, the biomechanical process is the same. So the know-how is accumulated, and the class 2 elastic can be used by a surgeon, by a dentist, and we can estimate the tooth movement, and then the more knowledge needs to be accumulated through publications. That's what I'm thinking. And the Magic Online has some advantages. Can you go over that?
For beginners, to compare with Invisalign, you can scan every 3 months and get the feedback as to how progress is being made, whether we're headed toward the right direction, and if something has been omitted. And then following that, you can adjust your strategy. If it is advancing in the desired direction, you can get that feedback for assurance. So that is the difference. Is there something to add, Dr. Ji?
So 12 appliances are designed, and specific aligners are fabricated, and a better process is observed. Clear aligners is first mentioned in the Osstem meeting, and thank you very much for your wonderful presentations.
Thank you, Dr. Hwang Chung-Ju, for serving moderator for the final session. Please give him a warm round of applause. There's going to be a survey on how satisfied you are with the presentation. There is a survey being done regarding the presentations made at Osstem Meeting 2023 Seoul. Text will be sent to all viewers, all online and offline audience. If you click on the link, you'll be able to participate in survey, and a total of 200 people will receive chicken gifticon. So please participate and try your chance at winning your coupons. And the live surgery results have arrived. Dr. Kim Yong-jin is going to talk about today's live surgery as we look at panoramic image. Dr. Kim Yong-jin, please come to the stage. Please welcome him with a warm round of applause.
So I'm wearing a casual clothing because I thought I just need to do surgery. The result of the surgery, actually I am not very much agile when I move my hands, and my apologies for the delay. This is the result. Post-op panorama. The regrettable thing is that there's no issue in the panorama, but at number 11, this post-op CT, AOS was used for the contour augmentation. And if you compare these, this is the pre-op planning. I thought it would be deviated, but I was surprised when I opened it. It is in there exactly as planned. At number 13, the Lego plate was to be left thick, but compared to planning, they were placed really exactly as planned. And contouring augmentation could be done, not open the flap to reduce the time. And abutment is connected to 14, 5 and 6. and the sinus floor was fractured to place them. And number 7, stability is pretty good. Number 21, GBR was planned, and if you look at the cortical labial bone, it is maintained when implant was placed. Number 23, it is placed as a planned, and opening the flap was not necessary in terms of time. Number 24, abutment is connected. Number 25 and 26, and sinus floor was fractured a little bit. Number 27, in the mandible, the submerged. Number 33, the ridge here was narrow, but implant was placed quite well. And number 34, and the linguocortical bone was left quite a lot, and dehiscence was expected. And without doing GBR, the plan was to place it deep, and the flattening drill could reduce only 2 millimeter bone. So the initial drilling did not go in quite readily, so there was a difficulty. Number 37, intentionally, there was a big difference between buccal and lingual, and the VD can be raised, or occlusal space was not enough, so prosthetic options can be varied, and so rather a deep placement was planned, so drilling was difficult. 43, 44, 45, and 46. And the planning was a deep placement of the implants. And then before occlusal adjustment, this is the prosthesis. When prosthesis was designed, where is Dr. Lee, who can explain this?
Dr. Kim Yong-jin was very humble, 22 implants. It's very difficult to place within such a short time frame, and they have been placed very nicely. And as a prosthodontist, the things were very nice. From planning, the patient was using completed denture nicely, and using that occlusal relation, provisional was to be fabricated. Complete denture occlusion was bilateral balanced occlusion. So if occlusal force is applied, then it may be difficult to use as provisional. So from the planning stage, overjet was planned in the anterior area. It was out of occlusion, and patient's occlusion required adjustment. So this is after the upper connection, and the lower access hole is filled up, resin is filled, and occlusal adjustment was done. It took some time to do occlusal adjustment. Even if Dr. Kim finished on time, I think we may have stopped in the middle because of the time spent. It has been done nicely in the posterior area. Balanced occlusion was done. Group function was provided. So after 1 month, Dr. Kim Yong-jin is going to do an evaluation of soft tissue healing and osseointegration. And if things have healed nicely, we're going to move on to the next stage, provisional. This is the upper. This is after hole filling. It was fairly simple. I'm sure you'll be able to see the results, and please give Dr. Kim Yong-jin and Dr. Lee Soo-young a warm round of applause. One guide, they were in the upper Edentulous jaw, and we were able to see successful implants placement. Thank you, everyone. Please give Dr. Kim Yong-jin and Dr. Lee Soo-young for a wonderful lecture. Please give them a warm round of applause. And from yesterday, we have been having Osstem exhibit and Osstem meeting 2023 Seoul. Amidst many expectations and anticipations, we are heading towards the end. There is a special event to make Osstem mobile cart will be provided for 3 people, and 2 people will receive Galaxy 5 Watch Pro, and 1 person will receive Galaxy S23. And a lottery type of draw will be done because there are many people with a cell phone number that ends with 2875. We are going to select the 5 numbers. If the 5 numbers are overlapping, another number will be selected. Osstem mobile card winner. Let's look at the prize. 3rd place winner.
오스템 임플란트 모바일 카트를 받으실 3분 중에 첫 번째 당첨자를 바로 발표하도록 하겠습니다. 첫 번째 당첨자는요. 513790번님 축하드립니다. 네, 바로 이어서 두 번째 당첨자 뽑아보도록 하겠습니다. 9번, 2번, 6번, 1번, 3번, 926139번님 축하드립니다. 네, 오스템 임플란트 모바일 카트를 받으실 3번째 마지막 당첨자 뽑아보도록 하겠습니다. 마지막 당첨자는요. 889828번님 축하드립니다. 네, 3분께는 저희가 개별적으로 연락을 드리도록 하겠습니다. 이제 2등입니다. 삼성전자 갤럭시 워치 5 프로를 받으실 2분 중에 한 분 먼저 뽑아보도록 하겠습니다. 첫 번째 당첨자는요. 767868번님 축하드립니다. 네, 갤럭시 워치 5 프로 원하시는 분들이 꽤 많으실 것 같은데요. 두 번째 당첨자 바로 뽑아보도록 하겠습니다. 두 번째 당첨자는요. 485584번님 축하드립니다. 네, 이제 대망의 1등입니다. 삼성전자 갤럭시 S23을 가져가실 대망의 1등 당첨자는 과연 어떤 분이 당첨되셨을까요? 261290번님 축하드립니다. 네, 저희가 당첨되신 분들께는요 개별적으로 메시지를 보내서 안내를 해드리도록 하겠습니다. 6월 24일, 25일 양일간 진행된 개원 박람회와 오스템 미팅 2023 서울 여러분들 어떠셨나요? 네, 치과계를 이끌어주실 연자분들의 훌륭한 강연과 라이브 서저리를 통해서 많은 분들께서 뜻깊고 유익한 시간을 보내셨으리라 생각됩니다. 이 자리를 빛내주신 좌장 및 연자분들 또 끝까지 시청해주신 많은 분들께 감사의 말씀을 드립니다. 제가 인사를 드린 이후에는요, 이 행사 양일간을 돌아보는 멋진 기념 영상이 준비가 되어 있습니다. 또 오프라인 경품 추첨을 하시려고 지금 많이들 대기하고 계신 거죠? 네, 오프라인 경품 추첨이 진행될 예정이니까 현장에 계신 분들께서는 잠시만 기다려 주시면 되겠습니다. 그럼 이것으로 오스템 미팅 2023 서울을 마치도록 하겠습니다. 지금까지 아나운서 이만을이었습니다. 고맙습니다.